Dignitaries, distinguished guests, learned delegates from academia, professors, teachers, students, and our beloved Amrita family, a very good morning to one and all. Here at Amrita Institute of Medical Sciences, in our year of 25th anniversary, it is with great pride and honor that we are hosting this educational course on behalf of the International Stereotactic Radiosurgery Society in 2023. We are extremely privileged to be in the presence of several luminaries in various fields of medical sciences who will be sharing their valuable insights and expertise through multiple lectures over the course of 3 days. Our sessions will be an in-depth dissection of state-of-the-art management techniques of benign intracranial tumors, skull-based tumors, abdominal, genitourinary, and gynecological cancers. We hope that this conference will stimulate your interest and curiosity and serve as a platform for interactions, exchange of ideas, collaborations, and will overall be an academically enriching experience. Once again, we welcome one and all of you for the first day of our educational session. We extend our heartfelt gratitude for all of your support that has been instrumental in making this event a reality, and we thank you all for gracing us with your presence. We extend a special welcome to Professor Tejpal Gupta, Secretary of the Indian Society for Neuro-Oncology, Professor in Advanced Center for Treatment Research and Education Center in Tata Memorial, Maharashtra, Professor Krish Sridhar, Honorary Secretary, Neurological Society of India, and Consultant Neurosurgeon in Kaveri Hospital, Chennai, India, Professor Aditya Gupta, President of the Indian Society of Stereotactic and Functional Neurosurgery, Consultant Neurosurgeon in Artemis Hospital, Gurugram. Professor Venkateshan Srinivasan, Secretary General. We request the following faculty to please come forward to the dais. Professor Tejpal Gupta, Secretary of Indian Society for Neuro-Oncology and Professor in Tata Memorial Center, Maharashtra. Professor Krish Sridhar, Honorary Secretary, Neurological Society of India, Consultant Neurosurgeon. All right. Professor Aditya Gupta, President of Indian Society of Stereotactic and Functional Neurosurgery and Consultant Neurosurgeon, Artemis Hospital, Gurugram, India. Professor Venkateshan Srinivasan, Secretary General, Association of Radiation Oncologists of India. Okay. Professor Bhaskar Vishwanathan, Head of the Department of Radiation Oncology, Amrita Institute of Medical Sciences, Delhi, India. Dr. Ali Niaf, Consultant Neurosurgeon, ADK Hospital, Malé, Maldives. Okay. Professor Amir Al-Shahabi, Professor, Department of Neurosurgery, Ain Shams University, Cairo Gamma Knife Center, Cairo, Egypt. We request all the following faculty to please occupy the front seats. Dr. David Miles, Director, Zap-X Radiosurgery System, England. Professor Elitsa Incheva, Professor and Head of Radiotherapy Department, University Hospital St. Marina, Varna, Bulgaria. Professor Ian McCutcheon, Department of Neurosurgery, MD Anderson Cancer Center, Houston, Texas. Dr. Muhammad Fadil Salim Al-Balushi, Medical Oncology Specialist from National Oncology Center, Royal Hospital, Muscat. Dr. Maris Mizekis, Senior Radiation Oncologist, Radiosurgery Center, Sigulda, Latvia. Dr. Michael Chernov, Chairman of the ISRS Education Committee and Assistant Professor, Faculty of Advanced Technosurgery, Graduate School of Medicine, Tokyo Women's University, Japan. Dr. Pavel Ivanov, Head of the Radiosurgery Department, Medical Institute, named after Berezin Surgery, St. Petersburg, Russia. Dr. Rupesh Kotecha, Chief of Radiosurgery, Department of Radiation Oncology, Miami Cancer Center, USA. Professor Selçuk Peker, Chairman of the Department of Neurosurgery, Chief of the CyberKnife Radiosurgery Center, Koç University, Istanbul, Turkey. Professor Yoshima Samori, Director of the Center for Advanced Image-Guided Radiotherapy, Shunryugakoa, Kawasaki, Japan. Dr. Zahir Abdullah Muhammad, HOD of the Radiotherapy Department, Sultan Qaboos Comprehensive Cancer Center, Muscat. We once again would like to welcome you all, and we thank you for your presence. Now we request Honorable Brahmacharni Karunamrita Prana to guide us for the puja and the prayer. We request everyone to please rise for the prayer. Now we would like to request Professor Devnarayan Datta, Co-Course Director for the ISRS 2023 and Head of the Department of Radiation Oncology in Amrita Institute of Medical Sciences, and Dr. Michael Chernov, Chairman for the ISRS Education Committee and Assistant Professor, Medical University in Tokyo, Japan, for the inaugural lamp lighting ceremony. We request all of our distinguished faculty to join them as well. Please come forward. Now we'd like to invite Professor Venkateshan Srinivasan, Secretary General for the Association of Radiation Oncologists of India, for the opening remarks.
Thank you so much, and I'm happy to be the opening batsman because I wanted to start that we radiation oncologists has got the pivotal role in stereotactic radiosurgery and stereotactic body radiotherapy. So I'm happy to start, and I'm really extremely happy that Aroy could endorse this ISRS course, and I was happy when Dr. Deb called me and he said we want Associated Radiation Oncology of India to endorse this course. It's the first time an international conference is happening in India. So they've come out of, they started somewhere in 1991, and now after so many years, they've come to India to do this course. And we realized in Aroy that this SRS and SBRT is going to play a big role in future. Probably when I was in my UG curriculum, SRS SBRT was only a theoretical subject. So now for the past 2 decades, it has become part and parcel of every radiation oncologist's life. But still, I feel that in our country, we have different centers where all the centers doesn't have the facility to do SRS or SBRT. So as a Secretary General of Aroy, I feel that we should disseminate the knowledge of SRS and SBRT to our students. This we did during the COVID times also, when we did a ICRO webinar on SRS SBRT, we called Radiosurgery Masterclass, and it was well attended by all the students from the entire Asia, because it was a webinar, and I could still remember students from Malaysia, Indonesia, Thailand, and even from Mongolia attended this SRS and listened to the lectures of our Indian teachers. So keeping that in mind, I think in the coming Indian Cancer Congress that's going to happen in November 2 to 5, the pre-conference ICRO workshop is going to be on SRS. So we have a stereosurgery masterclass. We cover every site where we can give SRS and SBRT. And we know this is going to play a very important role in every future, because you can see every trial where you combine radiotherapy with immunotherapy, you give only a high fraction dose. That means you involve either SRS or SBRT with immunotherapy. So we have found out that radiation is going to have an impact on the immune mechanisms also. So the immunogenic effect of radiation along with immunotherapy is going to be used for the betterment of patient care. And I'm extremely happy when they've said there are more than 323 registrations for this meeting. I wish success to all the meeting, and I'm sure these 3 days you will have excellent academic fees from, I can see people from every country are here, the experts from every country are here, and you're going to learn from them. And obviously, like, we can share our knowledge in our and our expertise in SRS SBRT. I can see a lot of my Indian colleagues and a lot of my faculty from Indian College of Radiation Oncology here, so who are the teachers whom we have chosen on behalf of Aroy. So everyone are here, so make use of this. All the 300 delegates, make use of this conference, and please learn and make sure you disseminate the knowledge. I always believe it's not just you learn, you have to go and teach your colleagues and your students, so that the success of conference will be that. Thank you, Dev. Thank you, the team, for inviting me again.
Next, we'd like to invite Dr. Michael Chernov, Chairman of the ISRS Education Committee, to speak a few words on the occasion.
Oops. Okay, dear friends, good morning. I'm Michael Chernov, and I'm working in Japan for several decades, but I'm originally from Russia. Well, definitely you know my motherland, it's on everyday news right now. And I'm serving as the chairman of the Education Committee of the International Stereotactic Radiosurgery Society. I don't know how many of you know about activities of our society, but on the last day, the day after tomorrow, in the closing lecture, I will try to highlight a little bit our current projects, which probably radiosurgeons and radiation oncologists from India should join, or at least think about joining in the future. Specifically, we launched this educational program in stereotactic radiosurgery and stereotactic radiotherapy from December 2016, around 6.5 years before. And by this time, we had 22 courses, so this is a 22nd event, which were held in 12 different countries. But this for the first time we met here in India. And of course, I wish to thank Professor Deb Dutta, who did the main organizational activity here, and his team from Amrita Institute. It's incredible efforts were done to make this event successful. I wish to thank all our speakers who came there for, according to the tradition, for their own expense. So they covered their travel cost of their air tickets by themselves. And of course, for our sponsors who are supporting us here. I wish at the beginning to make few reminders. First, that this course is famous for its truly democratic and friendly atmosphere. So as you can see, after each session, we have a specifically allocated time for discussion. Please join these discussions. Please express your opinions, contradict, disagree. So there is no such a strict barrier here between those who are speaking from this chair and those who are in the audience. So it's our course, and we wish to find, well, if not standards during these coming 3 days, but some truths for the benefits of our patients. I also wish to ask all moderators and session chairs to follow strictly our time regulations, because we have a very tight schedule, so we should be on time. We're already a little bit beyond. And finally, we prepared for all of you very beautiful certificates. If you will leave a little bit earlier, please ask the staff in the reception and get this certificate. And I'm absolutely sure that our event will be successful. So let's probably start. Or Professor Devduta will tell some words also. Thank you.
Next, we'd like to invite Professor Depnarayan Datta, Co-Course Director, the International Stereotactic Radiosurgery Society, Head of Department of Radiology and Oncology, Amrita Institute of Medical Sciences. For a few words on the occasion.
Good morning, and I welcome all of you for this academic fest. Now, I thank all the faculties who have traveled so far to be here, all the Indian faculties who have come here, delegates and the students. Now, it is an educational course. It means that there will be interactions, and you can show your opinions, and we can debate on things and take this opportunity to interact with the faculties and the experts in this field. So welcome all of you for this academic fest. Thank you.
Thank you, everyone. As we delve into the world of radiosurgery, it is crucial to establish a very clear foundation of understanding. We are starting off our academic session with our first plenary lecture on the topic, Radiosurgery, Basic Principles and Correct Terminology. I'd like to invite the moderators for the session onto the dais, Professor Bhaskar Vishwanathan, Professor and HOD of the Department of Radiation Oncology, Amrita Hospitals, Faridabad, and Dr. Mikhail Chernov, Chair of the Educational Committee, ISRS. I now request the moderators to take over the session and to please introduce the speaker for our session.
So the first plenary lecture. So we are inviting for the plenary lecture 1 by Dr. Tejinder Kataria about the radiosurgery basic principle and correct terminologies.
Honorable chairpersons, ladies and gentlemen, good morning. At the outset, I'd like to thank Dr. Datta and his team for inviting me to this educational course. Thank you. So about 2 months ago, I got a call from Datta to come and deliver this lecture, and this is my first time ever at the ISRS, so I'm quite excited to hear the lectures and also interact with the international faculty whose papers and whose courses we've attended earlier and learned from them to start our own radiation radiosurgery at our institute. So the term stereotactic radiosurgery was coined by Lars Lexell in 1951, envisioning a single heavy dose of radiation to destroy any deep brain structure without the risk of bleeding. Coming to stereotaxy, it is a Greek word. Stereo actually means solidity or solid, and tactile meaning touch, and refers to any technique that involves the recording and reproduction of three-dimensional haptic information or creating an illusion of depth to the sense of touch within or otherwise flat surface. The term stereotaxy can be traced back to 3rd and 4th century BC when Plato and Euclid used this, and it was used in a manner that stereotaxy came to be understood as spatial or three-dimensional. And tax is a word derived from tatein with meaning to position. An encephalometer was the first device made by Zernov for localizing the parts of brain in living humans in way back 1892. And the stereotaxis or stereotaxic apparatus was the term introduced by Clark and Horsley in 1908 to denote a method for precise positioning of the electrodes deep into the cerebellar nuclei of apes. And the target in space was defined by 3 distances in relation to 3 orthogonal planes. Although the concept corresponded exactly to x, y, and z coordinates of Cartesian system, Clark never used this concept in this manner. And the definition of present-day stereotactic radiosurgery was finally given by the American Association of Neurological Surgeons Stereotactic Radiosurgery Task Group in discussion with the American Society of Therapeutic Radiation Oncologists as a distinct discipline that utilizes externally generated ionizing radiation in certain cases to inactivate or eradicate defined targets in head or spine without need to make an incision. The target is defined by high-resolution stereotactic imaging. So each word has a meaning, and we'll get to know as we go through the deliberations over the next 3 days. SRS is performed as a single session using a rigidly attached stereotactic guiding device or other immobilization technology or stereotactic image guidance system, but can be performed in a limited number of sessions up to a maximum of 5. So there are certain differences between the conventional radiation and the stereotaxic treatment, and a stereotaxic treatment is by and large non-coplanar, except in certain SBRT conditions where it can be coplanar. It uses multiple arcs and beams, but which is not so true for the conventional law because we're using VMAT there. Positional accuracy of 1 millimeter or less is required. A high dose of 6 to 25 gray is delivered between 1 to 5 fractions. So in 1947, Lars Lexell introduced the arc-based frame consisting of a base frame and a mobile arc with a quadrant headpiece. And the design enabled the operator to place the target at the arc center and allow the target to be assessed at various angles. So a boost to the image guidance stereotactic localization was started by William Oldendorf in 1906, when he introduced the tomographic technique by rotating a radiation source around the axis of constant linear manner to differentiate the tissue density. And then Fourier transformation and back projection to reconstruct these images was developed by Cormack. And using both these techniques, then Hounsfield gave a computed solution to the reconstruction of images based upon the transmission when the X-rays were taken in all directions of the object being transferred. So hallmark of stereotaxic treatment is high precision, high accuracy of less than 1 millimeter, rapid fall-off of dose at the periphery of target, maintaining a high dose conformity. And stereotactic fiducial system is central to the stereotactic method, which requires to the reference markers to be imaged when attached to the stereotactic immobilization system fixed to the patient. These markers are vital to provide accurate geometrical information on the coordinates of planned isocenters. And they can be in the form of various rods configured to the rings, balls, steel balls, or wires stretched between the rigid spaces. So the first one to use was Lexel system, which was used for diagnostic and therapeutic stereotactic neurosurgery, and is compatible both with the Gamma-Knife and LINAC platforms. And I'm grateful to Dr. Aditya Gupta, who's here today, because he'd come from All India Institute of Medical Sciences, had been a user of Gamma-Knife, and then he got our program started on the LINAC radiosurgery with the Lexel frame. Then this is followed by the BRW system, which was developed and has a set of vertical and diagonal rods, creating an N-shape alignment for stereotactic localization and alignment. And all these are fixed systems. The patient is immobilized with the fixation pins. And then the CRW system was developed, which is a simplified and improved system of BRW, which is MR compatible. And then the Telon is the removable head frame system for fractionated SRT. The disadvantages of the invasive cranial frames are that fractionation is not possible, and it's invasive, and the patient has to be fixed in the frame. It's a one-day procedure, needs admission, and the patient has to wear the frame between 6 to 8 hours, depending on how much time it takes to do the imaging, simulation, planning, and then the treatment. So then came the non-invasive and the frameless SRS era. And the systematic error with the frameless SRS should not or does not exceed 0.2 mm for translation and 0.2 degrees for the rotational displacements. So how did the frame-based SRS move into the frameless era? It requires the real-time verification with either a 6 degrees of couch or a real-time verification of the target. And that's done either by the robotic radiosurgery system and along with the hexapod couch or a 6-degree robotic couch. We did our own small study for intrafractional translational shifts on the CyberKnife for the frameless radiosurgery, and we found that most intrafraction shifts were less than 1 mm and maintained within 1 degree. And the equipments that are presently available from Gamma-Knife have moved to Novalis, which came in the 90s, to Edge radiosurgery, which is currently being used. We started with Electa-Axis, and we are currently using CyberKnife robotic radiosurgery system, and we've gone on to Versa HT with the hexapod couch for our LINAC radiotherapy, radiosurgery system. In the other domain, the first proton therapy system was used way back in 1960s by Lars Lexel, and the current day proton units are the best systems for radiosurgery, provided you have the equipment. Zap-X gyroscopic radiosurgery platform is the latest entrant and the youngest kid. And here, the image-guided radiosurgery system self-shields the radiation, so you do not need a LINAC or a bunker to place the machine and treat the patient. We also carried out a dosimetric comparison of robotic versus LINAC-based radiosurgery for small AVMs, and we found that the CyberKnife collimator, iris or fixed, were able to treat the AVMs of any size, even the smallest ones. And LINAC MLC-based SRS had a limitation in terms of conformity index and low dose spillage, although the total MUs that were required to deliver the treatment and the time to deliver the treatment were lesser as compared to the CyberKnife. Coming to simulation, so one first caveat for radiosurgery is that you need a reproducible immobilization, whether with fixed frame or frameless. Imaging should cover the target and all relevant organs at risk. A scan length of 15 centimeter beyond the treatment field borders is a requisite for entry and exit of the non-coplanar beams. And slice thickness, we prefer 1 millimeter, but there are systems that also utilize 1.25 millimeters. So imaging for SRS is the conventional contrast enhanced computed tomography, which provides anatomic as well as geometric accuracy along with electron density for stereotactic targeting and calculation of the dose. MR contrast enhanced T1 and T2 weighted images provide a superior soft tissue contrast relative to CT imaging. And we also understand that Gamma Knife only uses MR system for imaging and dose calculation. For the CyberKnife, besides a contrast-enhanced scan, we use a plain CT scan, non-contrast enhanced for dose calculation, because the contrast is not present at the time of delivery. MR alone for SRS simulation and planning has its merits and demerits. The merit is that it eliminates the systematic errors due to CT-MR co-registration, as well as the radiation exposure to the patient. But the disadvantages are that there can be a possible spatial distortion of MR due to the gradient field nonlinearity and magnetic field inhomogeneities. And also there's a lack of electron density values for dose calculation. There is difficulty in patient setup unless you're using an MR LINAC for treatment. And there can be distortion effects due to the air soft tissue interface, and that can lead to displacement of 1 to 2 mm over a very short distance. So image registration, after the image acquisition, we need to go for image registration and fusion, avoid motion-related artifacts. There has to be a selection of appropriate imaging plane, a proper frequency encoding gradient axis has to be maintained, and metal artifacts have to be avoided, and planning MR or planning PET can be used. If target and radiosensitive critical structures cannot be localized on a sectional imaging modality with sufficient accuracy because of motion and or metal artifacts, SRS or SRT, SBRT should not be the chosen way of treating that patient. This is followed by target delineation, and the image requirements for that for brain are a T1 weighted sequence for contouring, rapid sequence identification of multiple targets is required, a T2 flare for non-enhancing tumors, for trigeminal neuralgia or cerebellopontine tumors, cysternography effect of certain high-resolution T2 sequences is required, and 1.5 versus 3T, that's a debate which I'm not going to get into. For vascular lesions of the brain, abnormal vessels of the nidus versus parenchymal enhancement needs to be delineated. The embolization material, feeding arteries, and the draining veins need to be demarcated. A DSA, anteroposterior and lateral DSA projections, and 2D are converted to 3D with the DynaCT. Limitation of DSA is limited definition of complex 3D shapes, and the cavities cannot be defined. So an MR or a CT can be mapped together and fused to use to delineate these cavities. And the CT and the MR lack the detailed hemodynamic information. So you can use all three, and you have to work very closely with your imaging colleagues, neurosurgery colleagues, and the radiation oncologists and the physicists to delineate and then plan such cases. So then we come to the delivery identification. And a LINAC with frameless SRS or SBRT with a hexapod couch, we used to carry out 4 CBCTs, one at the initial setup for evaluation of the translational and rotational motion, CBCT2 for verification of applied shifts, and then during the first half of the treatment, a CBCT3, and then a CBCT4 during the second half of the treatment before we would complete the treatment. And in a small study from our center, we found that the comparison of parameters with frame and without frame before correction and after correction was not statistically significant. For the CyberKnife, we follow a 6D tracking, skulls tracking system, whereby the patient is set up on the machine. So patient is set up on the machine, and a 2D DRR image is taken with the imaging center in the machine, in-room tracking, and it is aligned and matched to the planned DRR, and the shifts are calculated, which is followed by verification and authentication by the doctor. The technician here is looking at the PDP and then giving a go-ahead, yes, we are okay to go for the treatment, and then the treatment is started. X-site spine for tracking is used for in-room imaging, and the same procedure is followed for the rotational and translational corrections. So for the LINAC, the requirements are that overall mechanical accuracy of less than 1 mm with small field commissioning into the TPS of less than 6 by 6 mm up to 6 by 6 mm. Prescription isodose varies from 70 to 80%, but in certain brain metastatic cases, we may use up to 95% isodose line and closer to 98% also. The beam energy is 6 MB or 6 FFF. Calculation grid size is 1 mm. And there are various calculation algorithms which are available with different systems. But you need to standardize and have your own data configured in the TPS before you start the treatment. For multiple targets, if the difference between the two targets within the brain is more than 3 centimeters, then it's better to apply 2 isocenters. And it can be coplanar or non-coplanar configuration depending upon the treatment unit that you're using. So we use the pedic conformity index, and immobilization devices are configured into the treatment planning system. Volumetric imaging and 2D KV imaging tracking is used. Motion management I'm not going to discuss because I am addressing only the cranial and the spinal area right now. And the QA of treatment machine is following the AAPM task group 142. Pre-treatment QA is done with point dose, and standard guidelines are ICRU 91, task group 101, and Quantic. And third-party credential can also be carried out to see as an external audit whether your SRS system is following the protocols that you have laid out for your department. So it's a highly responsible area where all the task holders have to have their own responsibilities defined. The radiation oncologist has the decision-making and obtaining the informed consent from the patient. He or she oversees the radiation therapy management of the patient, works in concert with the neurosurgeon, neuroradiologist, and other physicians, plus intradepartmental medical physicists and the RTTs, specifies the target volume and relevant critical areas, and follows the patient through the treatment for the disease control and the complications. Equally responsible is the medical physicist for the technical aspects of the radiosurgery, acceptance testing, commissioning of the SRS, implementation and management of the QA program, developing the standard operating procedure, hand-holding for the radiation oncologist as well as for the RTTs, perform and supervise the dosimetric treatment and planning process, and validate the chosen treatment delivery parameters. So the radiotherapy technologists are a key person who is going to finally deliver the treatment. So they need to be trained and brought up to the mark to the level where it's expected that they'll be performing their duties. They prepare the immobilization devices from acquisition of the images for the treatment planning, documentation of the treatment setup, to patient-specific instructions, preparing the treatment room for the delivery of the SRS, positioning the patient, localizing the treatment isocenter, and operating the treatment unit. The commissioning and QA is an elaborate process. Like I alluded to earlier, we use different task group studies which have been published. Accelerator beam data commissioning of the equipment and procedures is taken through the task group 106 of the Therapy Physics Committee of the AAPM. Task group 142 report for quality assurance of medical accelerators. Report of AAPM task group 135 for quality assurance of the robotic radiosurgery system in case you're using. And the task group 155 for megavoltage photon beam dosimetry in small fields and non-equilibrium conditions. And these caveats have to be met with before you can even deliberate thinking of starting a radiosurgery program. So the treatment machine, TPS, and end-to-end testing for delivery have to be commissioned. So there's a very strict linear accelerator SRS daily QA program which pertains to the LINAC and to the imaging system. And there is a monthly program which again pertains to the LINAC and the imaging system, including the X-ray output and the monitor chamber constancy, gantry, the collimator angle indicators, couch position and jaw position indicators, MLC position accuracy. And on the imaging front, the imaging and treatment coordinate coincidence with the 4 cardinal angle, and image quality, its spatial resolution, distortion, Hounsfield unit linearity, uniformity, and noise. And then there is an annual program for flatness and symmetry change from the baseline, output calibration, output factors constancy, monitor unit linearity, output constancy versus dose rate, output constancy versus gantry angle, collimator, gantry, couch rotation isocenter, coincidence of radiation and mechanical isocenter. So similarly for the radiosurgery program with the robot, daily output constancy has to be carried out, which takes about half an hour to 40 minutes in the morning. Treatment manipulator perch, position laser check, automatic quality assurance check, which is done with the AQA Phantom. And monthly QA includes the beam parameters, a linear accelerator because there's a LINAC there, laser and radiation coincidence program, end-to-end test, dose delivery verification, imaging system alignment, and standard treatment couch positioning. And there are quarterly checks for target localization, and the Phantom is used in different positions, which I'm not going to go through. The physics team, I think they're going to discuss it tomorrow and day after. And then there is an end-to-end test, which tests the total targeting accuracy from CT scan to the delivery. And the monthly QA is done with, which is a modified Winston-Lutz test for checking the spatial delivery accuracy along with the tracking modality accuracy. So there are different components to different equipments that you're going to use, so you need to be aware of that. And then there is an annual QA for beam commissioning, spot checks. Do I have the time? Okay. So then there is a beam calibration check which needs to be carried out, and these are international guidelines that need to be followed. And then treatment planning system, treatment planning display, TPS distance measurements, and TPS calculations have to be done annually. And robot couch position indication accuracy also have to be done annually, or if there is any change or a maintenance is carried out, then also the physicist has to carry these out. A patient-specific program QA is required for every delivery before the treatment. So your treatment machine time actually is 2 times the time of the treatment, because you have to carry out the QA for each treatment before the treatment delivery, and all these parameters need to be taken into account. We've also had a third-party IAEA postal dosimetry check for our SRS program and for SBRT with the TROG. These are the volume dose constraints which are specific to the intracranial and the spinal SRS and SRT program, and all these albums and tables are available, widely published. I would recommend, instead of memorizing them, you should put them out before your treatment consoles or treatment planning systems, and then allude to them. And you may need to modify them depending upon each case, or in special cases, in case you cannot meet them, then change your dose. So the delivery instructions have to be under the professional supervision. Pre-treatment QA check details have to be noted down. Image guidance method has to be noted. And intra-treatment image guidance also has to be planned. These are a few of the published sources that we've used: physics and dosimetric principle for SRS and SBRT, AAPM RSS white paper, and the ICRU 91. This is a dosimetric comparison of robotic versus LINAC-based radiosurgery. And this I have already, I think, covered earlier. So I was also asked by Dr. Datta to cover radiobiology, which is in itself a full lecture. So I'm just talking about a little about the pathophysiology of SRS, especially for the AVM obliteration, where we find that the radiosurgery induces a pathologic response to injury model of atherosclerosis. And the injury to the vascular endothelium is believed to be the one that induces the proliferation of smooth muscle cells and the elaboration of extracellular collagen, which leads to progressive stenosis and obliteration of the AVM nidus, thereby eliminating the risk of hemorrhage. And I'm grateful to Dr. V.P. Singh for providing me this slide for a patient that we treated in 2029 with complete obliteration of the nidus after 3 years. And the complete obliteration rates, because the responses asked for, are 70 to 90% after a latency of 2 to 3 years. I went through our own database, and we found that we lost 2 patients to hemorrhage within 6 months. They were deep-seated AVMs, and we could not save them. Rest of them have all been fine. For pituitary adenomas, there's a 93% control rate for a mean of 102 months, ranging from 15 to 230 months, with a median of 90 months, as reported by Kika Salabanda. And we see that there is a latent time period, so you need to hold the patient's hand during that time, and sometimes there may be a pseudo-progression, so we need to be aware of that as well. For the vestibular schwannomas, post-SRS control rates are 95 to 96%, with 4 to 5% regrowth rates, around 36 months, 12 to 36 months, but then this regrowth stops at a median of 22 months once the regrowth is expected. We've had 2 patients who needed surgery because of massive bleed, and they became very symptomatic within 6 months to 12 months after the treatment. Otherwise, we've not seen any major issues with such patients. So these are the indications for SRS. Arteriovenous malformations less than 3 centimeters, intracranial, small meningiomas, small acoustic schwannomas, solitary metastasis, trigeminal neuralgia, trigeminal schwannoma, or glossopharyngeal schwannoma also. We've had a share of that. Recurrent high-grade glioma and localized vertebral metastasis. But FSRT is something which can be extended to larger tumors beyond 3 centimeters. And with the robotic radiosurgery program, maximum tumor size that you can treat, or a benign lesion that you can treat, is 72 mm with the iris collimator. And these numbers are our own cases. We've treated about 3,000 cases of SRS and FSRT in the last 10 years. And 130 were AVMs. 20 patients we had were of trigeminal neuralgia. 326 cases of acoustic neuroma, 402 intracranial metastasis, and 298 vertebral metastasis. So with this, I'd like to acknowledge my team, starting with Dr. Ashu Abhishek, who is presently at Apollo Proton Center, Dr. Besht, Dr. Deepa Gupta, Sushovan. Shikha is here in the audience today, and she's an alumni of Kochi. Hi. And Mr. Karthik, our physicist, Mr. Tamil Silvan, Venkateshan, who assisted me with a lot of the physics part in this presentation. Amit and Lakwinder, Chitra, Abdul, they are our senior radiation technologists with extensive experience and do a lot of hand-holding for us, and especially train our junior staff also. Dr. Aditya Gupta again is here in the audience. Dr. Jha, I'm missing today because he was our head of department when we started the program for neurosurgery at my center. Dr. VP Singh again is in the audience, and Dr. Sudhir Dubey, who is currently not here, but is a very esteemed colleague of ours. And besides this, many unnamed people who've assisted us in this program over the last 10 years. Thank you for your patient hearing. So just one last line. This actually is a picture of a Buddha. It was a multi-headed Buddha displayed in Kathmandu as I was walking down the street. And it's made in brass. So the color was golden, and the sunshine was shining on it. And when I took the picture, I realized it's a rainbow colors which have come because of the reflection through the pane, the glass pane. So that's how SRS is. So you pick and choose. Thank you.
Thank you very much, Professor Katare, for so excellent overview of the stereotactic principles and the basics of radiosurgery and different devices. Before you will get some questions from the audience, can I ask you, now we have a lot of different devices for radiosurgery. I don't know what kind of devices exist in your clinic, but if you will have everything, what would be your criteria for sending patients with some specific pathology to a specific device? For example, some patients should be sent to Gamma Knife, others to CyberKnife. Do you have an answer for this?
Well, that's a very, very difficult question, because as a radiation oncologist, you have all these babies. So they are all excellent. What I would say is that there's no one machine which you would say that can treat everything. Like, we know the limitations of Gamma Knife, right? And we know the limitations of LINAC. We know the limitations of robotic radiosurgery and the Zap thereof, and the proton system. So if you know the limitations of your system, you would pick and choose what you have the best for your patient at that given point. So I think that's an answer which I'm not, the person who can give it to you, because I know the strengths and the weaknesses of both the sides, so I can debate on both sides.
Thank you, madam, for that excellent presentation and the introduction. And actually, it's quite a long journey from the 1950s when Lexel had introduced the concept of SRS and starting off with the AVMs. And it's very exciting. Just the morning I read a paper in which Cincinnati group, they published using ultra high dose rate, more than 60 gray per second of proton beam in the orthotypic mice
so the
lung models.
Yeah,
and
so
it had
flash.
very good local control. And the most important aspect of this is abscopal effect, which is coming around, in which they could migration of the CD8 cells and also the suppression of the TREG cells, which cause immunosuppression. And we also had recently treated a patient of DBCL, diffuse large B-cell lymphoma, around 10 centimeters in size. We gave just 3 gray in 10 fractions as a palliative dose. And maybe it is reflecting, maybe for that tumor set, it could be a high dose rate, ultra high dose rate, or, I mean not ultra high dose, maybe it could be a high dose rate fractionation. And there was a complete regression of the tumor. And she also had a soft tissue mass in the thigh, which almost decreased by 50%, though we treated in the neck, an abscopal effect. So very exciting times. I think we are looking forward to some really good, exciting moments in the future.
So, Dr. Bhaskaran, I'd like to add to that, abscopal effect can explain the malignant tumor and the response thereof to SRS or SRT. But looking at the benign diseases and the functional radiosurgery, abscopal effect is something which we are not looking at because it's a single dose which works, which causes either a lesion which goes away, like for a functional neurosurgery. For the trigeminal neuralgia, the response rates are excellent within the first 1 year. Within the first 12 months, the patient is 90%, 95% of they will say the pain goes away. But at 5 years, only 55% will have pain control. And at 10 years, only 25% will have pain control. So there are other factors which we still probably don't know. And similarly, that's true of the AVMs also. The AVM nidus goes away. But if there's a large nidus and then you have to retreat, there's no abscopal effect there. We don't see it.
What about the vascular malformations and repair of that?
So that's what I'm saying for the
hypoxic-inducing factors which can be given, because there's some trials which show thalidomide when given along with radiation.
Yeah, for hemangiomas, that has worked. For AVMs, that has not worked. For hemangiomas, spinal hemangiomas, for liver hemangiomas, that has worked, thalidomide or giving hypoxia, inducible factors. But I would beg to differ here that for the AVMs that we have thalidomide which can work. No.
Yeah, definitely at present. Plus the well-known basic mechanisms of radiosurgery, cytotoxic effect and vascular effects. Of course, we should consider immunological effect as well. Well, it's not new thing. It's now under investigation. You're right, absolutely, that in benign tumors or vascular malformations, maybe it plays a little bit lower role, but still it should be investigated and considered. Another thing which I had a wish to ask you on the slide with those restrictions. You mentioned that for cochlea you put 9 grays dose restriction. It may be different opinion of radiation oncologists, neurosurgeons. For me, it's 4 gray for better preservation of hearing, but it may depend also on fractionation or multisession. Any questions from the audience? Professor Dutta?
I think for the benefit of the students, but difference in SRS, SBRT, SABR, so much of confusion in that.
So SRS, stereotactic radiosurgery, is defined as a single dose, high dose delivery. And SBRT is, and this is intracranial or spinal. SRS, the term we use is for the cranial, or extracranial only for the spine. And for SBRT is stereotactic body radiotherapy or stereotactic arc body radiotherapy, that is SABR, is used for extracranial lesions, and it can be benign, it can be malignant. And by and large, it's fractionated. And the fraction size can vary from 1 to 3 to 1 to 5. So the number of fractions and the dose. And the prerequisite, if we go back to the studies that were done in the mice and on the cell regrowth, the dose of 8 gray minimum is required to create the effect of SBRT or the stereotactic effect when you're being delivered that. Because besides the vasculopathy, there is intermitotic death. When such a high dose is given, we normally see that in the conventional fractionation, there is death in the mitosis cycle, if we say between M and G2. So not at the S phase. We say S phase is resistant to conventional radiation. But in SRS or in SBRT, there is intermitotic death. So all the cellular cycle, that is S, M, G1, G2, or G0, all cells, they die because of such a high dose. So there's a stunning effect. And besides that, for the AVMs and for the intracranial benign lesions, there is a cascade of sphingomyelidase and all the cytokines and the ceramides which are released. So these cascades are the one which then precipitate the cell death. So once the stroma is gone and one is intermitotic death, then there is the stroma. The stroma which is supporting the cells also gets affected. So that also dies. So the soft tissue dies around that, and there is no support for the tumor to grow back. Now we've gone down to 4 gray, 5 gray, 6 gray. But if we see, then 8 gray is the dose minimum, which will lead to a permanent or a long growth, regrowth delay. So that is what we should know as the basics.
Yeah, and I wish to underline again that it's very important, as Professor Kataria said, that, and it was shown in one of your slides, that now the classical definition of radiosurgery is single session treatment. The current definition of radiosurgery is up to 5 fraction treatment, so it may be 1 fraction, 3 or 5, it will be still radiosurgery. We can do it with novel models of gamma knife, with CyberKnife. And then we have some hyperfractionated radiation therapy, and here is a number of fractions, maybe variable, maybe. For me, it's up to 15 fractions. It's still hyperfractionated radiation therapy, and then conventional fractionation. And we have a question from the audience. Yes, please.
Thank you.
As you told about the abscopal effect, I think we were not aware of the abscopal effect with the SRS because those lesions which were multiple meningiomas, that's the one which has been very commonly reported with an abscopal effect with an SRS. So in those cases, it's been seen that treating one meningioma leads to disappearance of the other meningiomas, and that has been very adequately reported in the recent literature now. And apart from the benign ones, even the gliomas ones, in which we have the T-Rex mutations and with the anti-PDL one, the abscopal effect is coming in a big way with a single session SRS or a hypofractionated SRS, both for the benign and the malignant pathology. Especially for the meningiomas, it's very good.
No, for the meningiomas and the gliomas which are expressing the PDL1, and for the meningiomas that do go away. But if we look back almost 200 years ago, when the SRS, when the abscopal effect was postulated for the lymphomas and for renal cell carcinomas, the results have not been consistent, right? So that is where we are concerned. We know that it works, but only for a small percentage of cases. With the immunotherapy and with the newer trials, probably we'll get wiser. As we understand the radiobiology of radiation, we'll also get wiser there. And the immune mechanisms will be elucidated in a different way, and then we'll be able to apply them to all patients. But even with the patients who are expressing PDL1, right, or who are given PDL1 modifiers and then made to be given radiation, because my medical oncologist will say, ek radiation laga dijiye, just give one single radiation, because they believe so much into it now. So they say, give the radiation, and sometimes we cannot, because there may be a fistulization which can occur, or the patient has already been heavily pre-treated. So there also we don't see all 100% of the patients that the tumors disappear when they are metastatic elsewhere. So there's a lot more to it. We are still trying to understand. We've come a long way in our understanding about radiation and its effects, and also the immunogenic as well as the abscopal effect, but we still are, I think, quite raw in that area.
I think we are losing out on time, so we proceed to the second.
Thank you so much.
Thank you, ma'am. Thank you. A big round of applause.
So, should I introduce our next session? Okay. So we have to proceed to our first session, which will be dedicated to radiosurgery of intracranial meningiomas. And I wish to invite here chairs of the session, Professor Venkatesan Srivasan. I'm sorry if I'm a little bit misspell or mispronounce Indian names, so difficult for me. Sorry. And Professor Adesh Srivastava. Thank you. And also, I will still remain moderator, and I would like to ask Professor Ayudarai Rasenatkom to join us. And I'm very thankful for Professor Ayudaran that he agreed to give the first talk on the short call about surgery of modern surgery of skull-based meningiomas And specifically, I would like to hear what limitations neurosurgeons have now for resection of these tumors.
Good morning to all. I think this is a current connection. Close it open, Go to the next part. I have already loaded the. Yeah. Okay, I think it's working on now. Yeah, it just came. Yes. So good morning to all. Welcome to Kochi. I begin with congratulating our fellow Indians on success of Chandrayaan 3 and thanking Dr. Datta for giving me this opportunity. As I said, like in a very short notice though. So skull-based meningiomas as such, it's a full day topic. Like so, I would be just highlighting few of the interesting points which we think is very important and during in the intricacies of the surgery. So as you all know, the skull base is divided into three: anterior, middle, and posterior fossa. These are the distribution of the skull base meningioma, starting from the anterior skull base, the suprasellar, clinoidal, sphenoid wing, lateral sphenoid wing, cavernous sinus, petroclival, cerebellopontine ankle, cerebellar convexity, and tentorium. It's not going, and foramen magnum meningioma too. It's not going to be cover everything all together. As I said, it's as such, it's an one-day full topic. So I'll try my level best to touch few points which we think are important, and then as a surgeon, which we consider, which we have to consider during each and every skull base surgery. So distribution of the anterior skull base, the skull base meningiomas, more in the anterior, followed by lateral, suprasellar, and rarely in the petroclival and the foramen magnum meningiomas. The farthest slide on towards the right side, like now, which is seen in the red color, those are the meningiomas which lie in the midline, and those are amenable through endoscopic endonasal approaches. So to begin with, anterior skull base meningiomas, like the green color shade is olfactory groove meningioma, followed by plenum sphenoidal in blue, and then small yellowish area, that's the tuberculum cellae meningioma. But I'll start with the olfactory groove meningioma. The meningioma of this size, of late, we had a lot of interest or enthusiasm of getting this tumor out through the endonasal route. I had also tried a few patients, but ultimately, I've moved back to transcranial, transbasal approaches because of the familiar territory, and then the amount of skull base defect which we create from below is humongous, and the reconstruction is very much challenging, and the high rate of CSF rhinorrhea when we do it in endonasal endoscope assisted approaches. So this has to be planned as an anterior skull base approach, transbasal, properly elevated, and then without causing any retraction on the brain. Ligate the anterior superior sagittal sinus, divide it, and then have a good visibility of the tumor in the base, go to the vascularity of the tumor, detach it from the base, cauterize it through and through, if possible, until the posterior margin of the tumor, free it once if it is freed, and then it is very easy to decompress it and then remove it in piecemeal without causing any major deficit to the or major damage to the cortex. And cranialization of the frontal sinus is a very important step in this. Then the tuberculum cellae meningioma. This constitutes of 10% of the meningioma, the anterior skull base. Main presentation is the vision impairment, and there's a lot of debate between the endonasal and the microscopic approaches for particularly this, but then tuberculum cellae meningioma is one meningioma where you would want to go through endonasally and then understanding the neurovascular structures as we see here in this picture, starting from the stalk, the sella, pituitary, the ICA on either sides, the optic canals, optic nerve becomes optic, the nerves. Mostly, it's limited to this level. Very rarely, it goes down, and then beyond that, it's going to be called as dorsum cellae meningiomas if it crosses this level. So Theodore Schwartz from New York, is one of the renowned neurosurgeon. He had coined terms when will I go endonasally and then when will I go transcranially. So what he did was he drew a line along the anterior wall of the sphenoid sinus, and then another line along the anterior cranial fossa. So we see the tumor which lies in the back of behind the line of the anterior sphenoid line. It's definitely an endonasal approach tumor, and then the one which is anterior to that, it is plus or minus. When it is anterior to this anterior sphenoid line, then we have to consider the lateral extension also. Before this is doable, but then the lateral extension will have to be considered too. The other picture which shows the tumor which is small, which is confined to the bilateral intraanal carotid arteries, definitely you go through the endonasal approaches. But then when they go beyond the ICAs, and then when they reach to the anterior clinoid process or the tip, and then when they go beyond 5 millimeters lateral to the laminae papyracea on either side, it is definitely an transcranial approach which we have to choose for. So he coined the terms in such a way that when it goes laterally, definitely beyond the points which I told, it's definitely an transcranial approach, but equally the supraorbital mini craniotomies also play a major role. Most of the tumors can be retrieved through this, particularly the tuberculum cellae meningiomas, through the minimally invasive approach. Then for any neurosurgeon, clinoidal meningioma, particularly the medial sphenoid wing or the clinoidal meningioma, is The challenging one, we see the anterior clinoid here, like it has got 3 attachments. Medially, like it runs over the optic canal superiorly, and then inferiorly it is attached to the optic strut, and laterally to the lesser wing of the sphenoid. So the distribution of this tumor can be from any of these places. Like the type 1, they are true medial sphenoid wing meningiomas, like where they come lateral to the clinoid, like which is much easier to detach and then remove it. The next one, like which involves the optic canal, and then they have extension into the optic canal too. This is much more challenging. They present with more of ophthalmic symptoms. And the third one is the groove, like then the carotid groove, like that becomes much more challenging, and the more of vascular invasion is expected of this, and then the much more challenging than the rest of the other 2 tumors. So there is one more publication which showed, like they coined the terms of approaching the tumor depending on the distribution of the tumor. Like if the tumor is arising from the top of the or the medial attachment of the anterior clinoid, then like we do the anterolateral approach, and then like when it comes postero-medially or postero-laterally, we combine the orbitozygomatic osteotomy approach, and then when it goes further medially and then posteriorly, like we include the both anterior and the middle fossa approaches to address these tumors. This is one such tumor, like I'm here to operate. Like this would be nice to debate also, but then like I just want to tell that like when such tumor comes, like what I want to highlight is this patient. She has no vision in the right eye, left eye severely papilledema. Like she has a Foster Kennedy syndrome. So and then we can see the ICA is running through and through. Like the ICA bifurcation is so much stretched. We did an angiogram to do the balloon occlusion study, tried to do the balloon occlusion study for a cross compression flow, but she failed. Like they couldn't even proceed with the balloon occlusion study also because there's no good cross flow at all. See the way like the ICA is stenosed here. So how would I approach this? Still I'll have to preserve her vision on the left eye. So I still have to operate on her. So we tailor this approach. The purpose will be to go in transbasal approach, like proper anterior or anterolateral the skull base approach. Decompress the tumor as much as possible safely. First thing would be to decompress the left optic nerve so that the existing vision remains the same or improves. We are not very sure about the right side vision, and preserve the vasculature as much as possible. So we detach it from the temporal side, decompress the tumor, reduce the mass effect on the or the stretch of the vessel, and then remaining tumors probably like we'll have to go for the adjuvant therapy. So not all the tumors can be, I can boast myself saying that like I would go and then remove it. It has to be tailored. Cavernous sinus meningiomas, interesting. Like what we see here, the picture here, like this is the lateral wall of the cavernous sinus. Like this is the intercavernous wall. Then the tumors which arise in this plane, pushing the contents of the cranial nerves medially, they are very easy. Like we can come temporally, peel off the dura, and then like it's straightforward. But the cavernous sinus meningiomas, which comes within the cavernous sinus like this. See the shape of the ICA here. The ICA is circle here. Like here it is compressed, and then all the cranial nerves are stuck within that. So in such circumstances, when they present most of the time, like with the cranial nerve palsies, it's a compartment. So you could straight away there was a concept that like cavernous sinus meningioma, go ahead and then like do of the radiation therapy or a stereotactic radiosurgery. But now that at the influence of the better understanding of the endonasal cavernous sinus anatomy, the medial wall can be opened. We reduce the pressure on the effect on the nerves. Like once if this is opened and then like reduce the bulk of the tumor, not to chase all, improve the cranial nerve palsy and then like send for the radiation therapy would be the current concept, which that's what I would do. this is what is these contents of the medial wall of the cavernous sinus, which was derived, which was probably published by Juan Miranda from Stanford. He was in Pittsburgh. He developed this when he was in Pittsburgh. This made a big opening for exposing into the medial wall of the cavernous sinus. This is the endonasal approach. We see the cella, and then we are drilling over the clinoidal ICA there, and we see the optic foramen here, and then the cavernous sinus. Exposing the anterior wall of the cavernous sinus is a major, most important part. Identify the interdural plane, get into the cavernous sinus. Most important thing is identifying the inferior hypophyseal artery, which arises from the paraclavial ICA and then comes into the pituitary gland. So divide them and then start dividing each and every ligaments which are going towards the anterior clinoid. When the medial wall gets opened, if the meningioma is inside there, the compartment is going to be released. Remove the tumor as much as possible safely. If it's a soft tumor, slowly remove them off. Most of the times, you will face if you're bleeding from the inferior petrocell sinus, which we just saw now, coming to join the posterior cavernous sinus. We can use adequate amount of the flowable hemostats. It is possible still to excise the tumors or decompress the medial wall of the cavernous sinus, or remove the medial wall of the cavernous sinus and then decompress the contents, give some breathing space for the cranial nerves, and then send for the radiation therapy instead of straight away sending for the SRS or whatever the adjuvant therapy before when the patient presents with, particularly within cranial nerve deficit. So that's a complete removal of the medial of the cavernous sinus, and then that's the division of the proximal dural ring. From top, when we come here, to get into there itself, it's very difficult. So that's a final cut, and the tumor which is attached to the medial wall is removed, and whatever we are seeing lateral to that is the ICA. That's a cavernous ICA which we see, and then we can get into the compartments. Even some tumors are there. Petroclavial meningiomas, next difficult meningioma for any neurosurgeon. They have a definition, defined as those originating at the upper 2/3 of the clivus, lateral to the midline, at the level of the petroclavial junction, and in correspondence with or medial to the trigeminal nerve. So anyone who knows about the cerebellopontine angle, will understand that the amount of nerves which are there. This is going to, all the nerves are going to look at us when we go through the posterior fossa. The 7th, 8th nerve, it's going to be the complex is going to be stretched in infero-laterally, and then the 5th nerve is going to be on the top. 4th, and then the 6th nerve. Sometimes the 6th nerve can be pushed up also, when they arise medial to the petroclavial junction, and through the Dorellas canal, the nerve comes, and as soon as we open, we see the nerves first. So this has to be coined depending on the growth pattern. Some tumors which grow posteriorly, they remain truly within the clivus. Some they come into the CP angle. Some they go into from the back to the middle fossa. Some they grow from the middle fossa, and then they come into the petroclavial, and then they have multi-compartmental involvement, including the sphenocavernos segments. So each and every tumor will have to be dealt separately. Purely posterior fossa, it will have to be dealt through the retrosigmoid approach, and then further extensions, including the pre-sigmoid and then the retrolabyrinthine approach, can be considered. The middle fossa approach is for the tumors which go anteriorly and to the middle fossa. Anterolateral and then posterior combined approaches for the tumors which involve the sphenocavernos region too. But most important thing is to preserve all the neurovascular structures, remove the tumors without creating any impairment of the quality of the life of the patient, and the rest of the tumors will have to be sent for the adjuvant therapy probably. So the same, whatever I've told, the approaches which have to be termed according to the location of the tumor. Then comes the tentorial meningiomas. This is another difficult thing. The tumors which are present in the tentorium or the cerebellar convexity or in the midline, they are much easy to remove. But then the ones which present in the tentorial hiatus, to go and reach them would be very difficult. So there's something called endoscope-assisted lateral supracerebellar approach. Peter Kelly, he did a cadaveric study of 10 skulls, and either side he tried to see the amount of the surgical freedom. Surgical freedom is like when a surgeon is able to handle with the neurovascular structure in the depth without creating any new trouble. Right. So he found that the endoscopy is much better compared to the microscopic approach. So we have translated the transnasal into the supracerebellar approach. This is how the assistant holds the microscope, and then if you see the picture below, my arms are not very long, and then when I try to do this approach, I have to stretch, and then my dexterity in the depth is not that good. I'll fix up this is what is the opening is required for those patients. And then foramen magnum meningioma, 75-year-old, you can see the amount of compression on the brainstem here at the cervicomedullary junction. We don't almost see the brainstem here. See the medulla here. Majority it is occupied by the tumor. This lady, she was active all this while, developed hypoglossal palsy, and then she has developed just an ataxia. How would we approach this? We have to get her off her symptoms, because she didn't have any other comorbidity illness, a good 75. So we did a CT angiogram. I understood the location of the vertebral artery, and this is how we expose far lateral approach. This is the foramen magnum is opened, subdural, the cervical cord, and then the vertebral artery is exposed there, and short video, I'll run it through fast. So that's the vertebral artery which is going into the dura there. We are keeping it prepared in case if we have to release it to get into the tumor. We are keeping it ready. Opening of the dura. And we continue removing the dura. Not able to run the. So of course, we basic surgical principles, you keep continuing to remove the bone, and then stay within the arachnoid plane. That's we are seeing the nerve to the sternocleidomastoid, the spinal accessory nerve, and then towards the end, we found the hypoglossal nerve. We use the intraoperative cranial nerve EMG monitoring to identify them upfront, and then use the cues judiciously to decompress the tumors, go to the attachment, reduce the size, and then peel them off slowly, and then bring them into your field slowly, and doing a sharp dissection is very important to get the whole of the tumor out. So that's a nerve that's a hypoglossal nerve which is very firmly attached to that. She had the palsy of that. We could preserve that, hopefully I think it should improve. So maintaining the arachnoid plane is very, very important here. If we stay within the arachnoid, then the nerves or whatever the structures beyond that, it is going to be okay. Initially during the surgery, if they, because of the handling, because of the edema, even though if they develop a few paralysis, minimal paralysis post-operatively, they would eventually improve. That's the clivus which we are seeing at the end of the removal of the tumor. That's a amount of bone removal we do, 1/3 of the condyle we have excised here. That's what has facilitated us. And then again, substantiating on the Simpson grading of the better the Simpson grading of the excision, better even that goes with even these skull-based meningiomas too. So it has to be a tailored approach for a skull-based surgeon. It will have to be the bone exposure, each and every millimeter of the bone exposed. You are going to gain a lot of vision into the tumor. And consider multiple corridors and multidisciplinary approaches, the endovascular surgeons, the radiation oncologists, and then good neurologists, and then everybody together will have to discuss and then coin a better treatment for the patient, and particularly the training. You keep continuing to do the training because the whole skull base itself, you learn from microscope from the top and then through the endoscope from below, keep continuously get trained. Thanks a lot.
Thank you, Dr. Ayadurai, for that extensive coverage of the surgical management of skull-based meningiomas. Due to we are already running about 45 to 50 minutes short of time. So we'll have the questions probably at the end of this session. So I would now request our speaker is Dr. Mahadeep Singh Gaur. He is a Senior Consultant Neurosurgeon and Director at Valentis CyberKnife Center in Meerut, Uttar Pradesh. Dr. Mahadeep Gaur is a neurosurgeon and he did his Stereotactic Radiosurgery and Functional Neurosurgery Fellowship from Japan.
It's okay. Good morning, friends. I first thank organizers, Michael and everyone, ISRS for inviting me for this lecture. 25 years, I'm just doing radiosurgery and mostly gamma knife, except for last 6 months where I'm working with Valentis Cancer Hospital in Meerut using CyberKnife. Last lecture, Dr. Haidarai has explained the skull base in very great detail. And somehow I have a feeling that I am getting afraid of seeing such detailed operations. 25 years I have not done any surgery. I am doing only radiosurgery. And very extensive and excellent surgery I saw after many, many, many years. So anyway, my skull base radiosurgery for meningioma, I am trying to restrict myself to the basic treatment of skull base meningioma, not going into much detail of anatomy and everything. So as a neurosurgeon, we all understand that since the days of Harvey Cushing, one of the most challenging neurosurgical treatment is skull base meningiomas. Going back when we used to operate, means 25 years back, there was no endoscopic extensive surgery like we saw in the previous lecture. And everything has to go through the brain and operate, and very severe complications in many of the cases. So if we look at the older studies, we find that any meningioma operated with the result Simpson grade 3 to 5, they have high rate of recurrence, and all these patients need to have a second chance of radiosurgery after the diagnosis and first surgery. So that means we have to counsel the patient right at the start that you will need a second treatment. And this is not the final answer, that it depends totally how much that surgeon is personally skilled and can remove the tumor. But there is very high chance, even in the benign tumors, that you will have a second treatment coming. So another study also for 96, which have shown that there is, even if the gross resection is done, then there is still residual tumors are there and will need second treatment to look up. So nearly 60 to 70% which are grossly removed will need a radiosurgery. Recurrence is 30 to 40% after gross removal and will need radiosurgery. When there is multiple surgeries, then morbidity is high, so we need radiosurgery. And adjuvant, in a planned way, when we do a partial resection and then do the rest with radiosurgery, is also an excellent approach. And recurrences definitely need radiosurgery. So the main indications are small tumors, which can be treated primarily, or the residuals of the subtotal resection in a planned way. Aged and high-risk patients which have other comorbidities, even if the large tumor is there, may be subjected to radiosurgery. And recurrence and second surgery, patient will need. And sometimes patient may advise that you go for full surgery, but you may refuse. This study from 2014, they have made some summary, and we say that patient unfit for surgery and primary treatment is directly advised. Elderly with pre-medication disease, pre-existing disease. Small and residual tumors, small with normal asymptomatic and even symptomatic, less than 3 centimeter, and large with involvement of critical structures where surgery can be disastrous. Cavernous sinus meningiomas visually is better treated with radiosurgery, and recurrent meningiomas, of course, will need radiosurgery. So treatment is very typical. Early lecture we have already seen, Professor Kataria, how the radiosurgery is done. It can be framed or unframed, and we need basically good imaging, a 3D volumetric study like SPGR and Bravo type of and Fiesta type of studies to see the optic nerves and critical structures, and also define the tumor at large. Contrast CT is of very good help even when you are using gamma knife. If you are dealing with a skull-based meningioma, you should do CT contrast to see some of the part of tumor which is not visible and may be going in the bone and may differentiate from the bone also. So another important point is post-surgical effects. So once the surgery is done, we should at least wait 2 months or so that all the edema and the post-surgical effects have gone and you can see the remaining tumor clearly. Then it is important to cover the meningioma 100%. Why it is important is because we know there are tails which are extending into different areas, and we should try as far as possible, although it is absolutely impossible to cover 100%, but our effort should be that we should not leave any part of meningioma because we know the recurrence is so high. So when we use lower isodose, let's say plan at 35, 40, 45 or 50 isodose, then we can give a very high central dose. At the same time, we can deliver low dose to the critical structures like optic nerve. And follow as long as possible, means don't tell patient that now you're okay. Patient will have to come at least once in a year to find out whether tumor is coming back or it is not coming back, because we know the meningioma will come back. This is one of the studies from multicentric paper, Professor Coombe et al., which says that if you do DOTA PET as a part of imaging, you may sometimes find more areas and more better vision for locating some invisible parts of the tumor. In last 25 years, we have treated more than 5,000 patients, and 25% of the whole lot is meningiomas, and 72% of that is skull-based tumors. We have analyzed patients more than 10 years follow-up. So they have been distributed all around the skull base, frontal base, petroclavial, and most of them are cavernous sinus and cellar region, maybe because that is a more difficult part to operate and may need more extensive residual tumors are there and recurrence is high. So in this data, we have most of the patients were female, absolute nearly double of the male patients. And the average mean age was 45 years. Patient come with visual deficits, cerebral signs, seizures, multiple fractures, multiple features, and some of them incidental. 45% were operated before treatment and 5 has received radiotherapy before the treatment. So average volume was 11.28 cc, reaching up to 79 cc's, largest of the tumors. And we have covered about 98.45% on an average, highest going 100% and minimum is 76%. Prescription dose was 12.47 and isodose was 46. So we try to keep as low as possible. We have treated even at 30% isodose so that the central dose escalation is there. This is one of the examples. The patient has been operated and radiotherapy was given, and then a second operation was done, and then she came with residual tumor and treated only 12 grade 50%. So patient was followed. Within 24 months, we start seeing the reduction in size of tumor and continued to remain small. This is the 8-year follow-up, but patient died at 12 years because of ischemic heart disease not related with the tumor, and there was no recurrence. Another patient, 34-year-old female, she refused surgery. There was tumor in the cavernous sinus and the petroclavial region, and we treated with 13 gray at 40%. This is 2-year follow-up, then 4-year follow-up, And at 6 years, a new part of tumor starts appearing in the anterior part of the cavernous sinus. And then there was 6-nerve palsy in the patient. We had to treat second time at 6 years, and we did 14 gray for whole of the tumor. Mostly high dose focused at the anterior part where there was new recurrence. So we followed again 10 years from first treatment, and then 18 years of first treatment, a new tumor starts appearing more anteriorly and lower part of that cavernous sinus. So we have to treat again. And 22 years follow-up, you can see radiation effect can be seen in the new tumor, and the other previous tumors appear shrunken. So the fight of meningioma treatment only starts when we diagnose and the surgery is done. And if you want to control the patient, and you have to continuously follow and call him again and again for further treatments, and keep him mentally prepared that you will need this treatment. Again, a patient of left CP angle meningioma, we treated 12 gray. After 1 year follow-up, 6-year follow-up, tumor is shrinking. But at 10-year follow-up, new progression starts. And then we have to do a second treatment, 12 gray further, 40% in whole of the tumor. Tumor is now more than 20 years follow-up, and tumor has shrunk, but it has not gone, it has not become very small, and we await if it further creates a further new extension. This is a very strange patient. Patient was operated, and diagnosis was benign meningioma. In fact, the biopsy says only meningioma, and there was no further classification and delineation at that time. So we got a small residual close to sigmoid sinus, and we treated with 14 gray. You can see the small tumor and planning over it. 14 gray given, 100% of the tumor visible. Then after 10 years, a second tumor appears, just adjoining to that and more superiorly, and we treated again. Then there was this other nodule, which is quite remote from there, which we treated again, which we treated the second time. Then third treatment was given after further 2 years, and we see 14 years follow-up, and we see a further large tumor coming from various areas around the previous original treatment. Again, 13 gray was delivered to 13 cc, and both parts, the superior part and the previous origin and the tent. So patient was again operated at 17 years, and SRS was done 3 times already. Large recurrence was operated with biopsy was recurrent anaplastic meningioma. So either first it was not diagnosed, or later it transformed because of multiple radiation, and radiotherapy was given to this patient with 54 fractions, and again fourth SRS was given at 15 years. Then 17 years follow-up, patient has next operation and radiotherapy again. Anaplastic grade 3 meningioma was the diagnosis. Then the 18 years follow-up, still there is residual tumor. Patient was last followed till 19 years, and the last biopsy was hemangioblastoma found in nodule in thigh. So we still don't know what is the diagnosis, but we have to treat such patients sometimes. So if we look at our data, that most of the patients remain controlled between 5 to 10 years. And as we go further, many of them reduce in size. But if we look at the small tumors, they remain controlled, most of them, less than 15 cc in this study. And then if we look at the more than 15 cc, they reduce in this 5-year period. Maybe more intratumoral dose of treating of low ISO dose and creating more high internal dose may be effective in large tumor shrinking more faster. And this means what happened to the most of the patients, with 45 patients, where you need a second treatment because of the extensions along the tails of the tumor. and 20% recurrences were on the same site, and 29% increased, but they were never treated. This is again a data from the previous study in 2005, and it shows a lot of maybe good control from 80 to 100%, but there are also many complications in studies. This one female has a strange complication, so I choose to select it for this paper. The patient had a tentorial edge meningioma and treated with 16 gray at 40%. This was the original treatment. And then we continued to follow the patient. And at about 4 years, a small cyst starts appearing along the tumor edge. 6 years, you can see the edge very clearly. And then 8 years, cyst start becoming large. 11 years, you can see a large cyst coming there. We tried to give some Diamox and other treatments, but it did not help. It became larger and then ultimately operated. So 4 patients needed macrosurgery after gamma knife, 23 treated multiple times, 4 new tumors treated at different sites. Second developed new deficit, 2% developed new deficits within 3 months after the treatment, but recovered slowly. 5% of cavernous sinus showed new nerve deficit and mostly recovered slowly. So what we recommend, this is the ISRS clinical group task force guidelines to treat asymptomatic and small with primary. Important is that at least 14 gray dose is very effective in treating meningiomas. And if you are fractionating, then practice is commonly 25 grays per fraction. So in conclusion, radiosurgery is a very safe alternative to surgery, especially in skull base. If possible, we can treat primarily or in secondary treatment adjuvant to the surgery. And all symptom grade 3 to 5 must be told very clearly that you will need second treatment. And recurrence and morbidity is much less than open surgery. Thank you.
Many thanks, Mahip. We will keep all questions up to the end of this session for discussion.
Okay.
And so now we will proceed to the next lecture, which will be given by Professor Abrar al-Shahabi from Egypt, from Cairo. He is neurosurgeon in Ain Shams University and also radiosurgeons in Cairo Gamma Knife Center of Nasser Institute. This is one of the most active centers in, at least in the South Europe and North Africa. I had a chance to visit it to see the job. So Professor al-Shahabi will speak about very unusual thing, radiosurgery for convexity and parasagittal meningiomas. In the majority of centers, such surgeries are performed by residents. So Professor al-Shahabi will highlight why radiosurgeon can be suitable for such cases also.
Thank you, Professor Chernov. Good morning to you all. I'm Dr. Amr al-Shahabi. I work as a professor of neurosurgery at Ain Shams University in Cairo. I also work at the Gamma Knife Center in Cairo. First of all, I would like to thank the organizers for inviting me to this wonderful event. The organization is wonderful, and I'm enjoying my stay here in India. Thank you very much. How do I? This one? Okay, first I want to outline the lecture. I will have a short note about epidemiology. I will discuss the difference between treating basal or skull-based meningiomas and non-basal meningiomas, of which convexity and parasagittal meningiomas are. We'll talk about the radiosurgery of these meningiomas. I will also discuss about incidental convexity and parasagittal meningiomas and when to treat them. And also I will talk about the role of stereotactic fractionated radiotherapy and its various forms in treating these tumors. First of all, we know the meningiomas are the second commonest CNS neoplasm. They compose about 18% of intracranial tumors. According to the US Brain Tumor Registry, the majority are benign. About 80% are grade 1, 18% are grade 2, and 2% are grade 3. Parasagittal and convexity meningiomas each roughly compose about 25% of all meningiomas, and of these, in each of them, about 25% are asymptomatic or incidental. They are among the commonest benign tumors to be treated by radiosurgery. And at our center, we've been doing gamma knife since 2001, about 22 years now. We've treated over 12,000 patients. Meningiomas remain the commonest indication that we treat with gamma knife. These numbers are a bit old, but the main point is that meningiomas are the commonest we treat. Now, skull-based meningiomas are suitable for gamma knife, obviously because of the risks involved with surgical removal. So it is an attractive alternative to surgery. Convexity and parasagittal meningiomas are also suitable. However, most of the patients are usually symptomatic larger tumors that generally undergo craniotomy or resection. And that is when they are eligible for it. The ratio of basal to non-basal meningiomas is 1 to 2. It's more, non-basal meningiomas are commoner. However, when it comes to radiosurgery, the skull-based meningiomas are 3 times as commonly treated by radiosurgery than non-basal meningiomas. The problem with convexity and parasagittal meningiomas is that they are locally compressive, they can invade the brain tissue, they can recur after resection, and they are commonly multiple. So for these meningiomas, there are several treatment options. You can either observe them, or do surgery, or do radiosurgery. The observation is an attractive option for these types of tumors because they are, if they are small or non-symptomatic. The main goal of observation is to monitor the tumor size and monitor the patient symptoms. However, when to intervene when you're doing observation? Do we wait for the symptoms? Growth does not always associated with symptoms. Do we wait for significant volume change? Well, the growth rate is not constant. It can be linear or exponential. It's suggested that the development of the annual volume change at which symptoms start to appear is about 2 cc's per year, but threshold is about 21 cc's. Bigger tumor means higher risk of complication and a greater risk of tumor failure. Also, the common is that the patient don't follow up, and so the patient becomes symptomatic when the tumor is too large. For surgery, the goal is to establish a diagnosis, do a maximum resection to relieve the symptoms, and to avoid recurrence. Recurrence can occur despite complete resection. It is contemplated that the range of recurrence after surgery, after gross total resection, is about 18 to 25%. The eloquent location of some of these tumors at the motor or speech area, the invasion of normal neural tissue and vascular structures, and the higher grade lesions have an aggressive clinical course. As we can see here, a comparison between the meningioma resection and the location, we can see that convexity meningiomas are the commonest tumors to be resected, undergo gross total resection. They are an attractive candidate for gross total resection because they are superficial location and accessible with a low surgical morbidity and mortality. Parasagittal meningiomas less amenable to complete resection because of invasion of the superior sagittal sinus and associated veins around it. However, more according to the location, with anterior location being more amenable to complete resection with a slightly higher morbidity and mortality. When we consider what the radiosurgical considerations are for doing radiosurgery for these tumors, we can address them by the acronym CLASS. First of all, comorbidity, if the patient is unfit for surgery. The location, if it's an eloquent location, the motor or speech area, and the accessibility, if it's more accessible, of course, surgery would be more attractive. The age of the patient, at the younger age, we will be less inclined to observe the patient as one of the options I said earlier. And also for older patients, surgery may be more risky, so maybe he is more amenable to radiosurgery. The size means a larger size, means symptoms, means more likely to have surgery done. And as I said, symptoms means you need symptom relief, so you do craniotomy. Other factors include edema. Some of these tumors have edema before treatment. Is the edema symptomatic? You can consider maybe surgery if the edema is symptomatic. And it has been found that the edema is more liable to progress after radiosurgery if it is present before. The grade also of the meningioma, if you have a histopathological diagnosis or have serial imaging showing a high growth rate, of course we know that grade 1 meningiomas have a higher control rate than grade 2 and 3. Also, the multiplicity, as I said before, that these meningiomas can commonly be multiple. So practically, you cannot do surgery for all of these tumors. You will either do surgery for the symptomatic tumor and then do radiosurgery for the rest, or if they are all small, you can just do radiosurgery for them at different sessions. So basically, the indications for radiosurgery for convexity and parasessional meningiomas is image-diagnosed meningiomas in eloquent locations, image-diagnosed meningiomas in elderly and with comorbidities, recurrence, and residual. A systematic review of convexity and parasessional meningioma radiosurgery includes 600 patients from 5 studies. The majority were grade 1. The mean tumor volume was 3 to 25 cc's. Some were single session, others were multifraction. The overall control rate was up to 85%, and actuarial 5 and 10-year local control rate was 87 and 71% respectively. The overall toxicity was up to 16% and was correlated, of course, with a larger volume, with a parasagittal location, with a pre-existing edema, and with a higher dose. However, in contrary, some cases, 25% who had pre-existing edema had the edema regress after radiosurgery. So in single fraction radiosurgery, the optimal dose is contemplated to be between 12 and 14 grays, depending on the tumor grade, the volume, and the proximity to critical structure or the eloquent area in which it is. The predictors of tumor control are, of course, as I said, the tumor grade, the meningiomatosis, and F2 patients have a slightly worse prognosis. Previous surgery, previous radiotherapy have also lower control rate and larger tumor size. In this study, in which at our center, we published a few years ago about single-session radiosurgery for large benign meningiomas, long-term results. We had meningiomas that were 10 cc's or more in volume. It was 273 patients. 26 of them had parasagittal and convexity meningiomas. Tumor control was 88%. The adverse radiation effects occurred in 5 patients, but only 1 was symptomatic. And we didn't find that the non-basal location was significant for adverse radiation effects. However, we found that worse control was with volumes 20 cc's or more and a dose of less than 12 grays. This is a classic case of a parasagittal meningioma, a 48-year-old female patient. She had a right parietal parasagittal meningioma, recurrent after 10 years. It was operated. 7 months after surgery, there was a residual. It was 70 cc's in volume, treated with 12 grays at 91% cover. 11 years later, it is controlled. This is another case who had a 40-year-old female patient. She had a bilateral parasagittal meningioma presenting with epilepsy. It doesn't look like she was actually a candidate for surgery. So it was a perfect case for radiosurgery. This is a 14 cc tumor treated with 12 grays at 97% cover. This is 10 years after gamma knife. You can see the tumor has shrank. This is another case of an image-diagnosed convexity meningioma, 46-year-old female patient with a frontal convexity meningioma, 17 cc, it was on the larger side, treated with 12 grays, 97% cover, and 3 years later the tumor had also shrunk. However, at 6 months, she developed some edema, which only lasted for about 5 months, and then the edema eventually resolved. So post-treatment edema is more common with non-basal meningiomas, especially the parasagittal type. Non-basal meningiomas have a broader piled interface and more blood supply than basal. When the parenchyma is irradiated, it distorts the blood-brain barrier and causes the edema. Also, there is the vascular endothelial growth factor present in the tissues. It is released. It causes vascular permeability and causes edema. Also, in parasagittal location, the occlusion of the veins, superior sagittal sinus and some bridging veins. Also, it's more common with primary radiosurgery because of the larger tumor size and thus larger pile interface. During surgery, this interface is dissected of the tumor, and so there's lesser pile interface and lesser incidence of edema. Also, in the presence of pre-existing edema, as you said before, in the presence of vascular endothelial growth factor, which is already present in the tissue, it's exacerbated with the effect of radiation. So more common in larger tumors, as we said, because of the pile interface, and also because of the risk of occlusion of the veins. This, another case of large meningioma we did by volume staging. She was 56-year-old female patient. She had a parasagittal meningioma presenting with epilepsy. We did it in 2 parts, 3 months apart, 11 cc's and 7 cc's, treated with 10 grays, with 3 months apart, as I said. 6 months later, you can see the meningioma has regressed. This is 6 months after the second session. And this is an example in which the edema regressed after radiosurgery, after 6 months. This is also the local recurrence after radiosurgery is more common with non-basal meningiomas because of outfield progression. It's difficult to differentiate from the tumor margin and the normal dural tissue or the superior sagittal sinus, especially in parasagittal location. It is more common after prior surgery because of difficulty in differentiating with residual and with gliosis. The residual tumor may be widely spread over the craniotomy, so out-of-field recurrence can occur. So it's more common with larger tumors. In this example, we can see a recurrent or residual tumor, 48-year-old female patient with recurrent right parietal meningioma after 10 years. We can see it's a 17 cc tumor treated with 12 grays at 91% cover. There was a very small area under the craniotomy, which we were skeptical of, this one. As you can see, 11 years later, this area had progressed. The patient did not follow up, and she came with the recurrence. So the follow-up is very important in these cases. Another example, a 60-year-old male patient who had the recurrence of parasagittal meningioma twice. It was about 4 cc tumor volume, 12 grays, 99% cover. We had also a suspicious area close to the tumor. As you can see, 18 months later, this part had progressed. For incidental or asymptomatic meningiomas, do we treat of the convexity and parasagittal location, do we treat them or not? The optimal management would be controversial because the benefit-risk ratio of removing an asymptomatic meningioma has made many prefer conservative management or observation. However, radiosurgery is minimal risk. In this study, this was a multi-center study carried out by the International Radiosurgery Research Foundation, which our center is part of, comparing active surveillance as opposed to stereotactic radiosurgery for parasagittal and parafalcine meningiomas. After correcting for different variables, there were 98 patients. As you can see, the radiosurgery had a superior control rate, 100% as opposed to 61%. Almost similar new deficits in the radiosurgery. It was transient. So compared to active surveillance, upfront radiosurgery is better. The same we did for convexity meningiomas. Also, they were 98 patients. A superior local tumor control of 99% as opposed to 69%. And new deficits, 2%. Also, radiosurgery was transient. In the other, it was due to tumor progression. So upfront radiosurgery was better than active surveillance. Quick note about stereotactic fractionated radiotherapy for meningiomas. Some confusing terminology. As mentioned before, our colleagues, radiosurgery is usually single, but can be up to 5 fractions. Stereotactic radiotherapy, usually more than 5 fractions. Fully fractionated is commonly more than 10 fractions. Hypofractionated stereotactic radiotherapy is commonly 5 to 10 fractions. And hypofractionated radiotherapy can sometimes be used interchangeably with radiosurgery if it's up to 5 fractions. So it can be an attractive indication for large meningiomas to reduce complication and edema. The rationale is to exploit the different recovery rates of normal and pathological tissues to optimize the tumor control and to spare the surrounding structures. However, meningiomas, benign tumors such as meningiomas and the surrounding tissues are both late responding tissues, similar alpha-beta ratio, so the change in fractionation pattern is not expected to preferentially produce more damage in benign tumor or benign lesion than the normal tissue. Volume stage radiosurgery may be advantageous over dose stage radiosurgery, as thought that benign tumors respond better to a greater dose per fraction. Okay. However, you can see in this study the multi-fraction radiosurgery had a better edema outcome. The rate of edema increased with higher dose per fraction from about 3% in 6 grays or less per fraction to 12% in more than 15 grays per fraction. Traditional machines used for hypofractionated stereotactic radiotherapy, the CyberKnife, the LINAC, the Gamma knife now, or recently the Icon or Esprit. So the recommendations are that convexity and parasagittal meningioma radiosurgery can be a primary treatment for asymptomatic or mildly symptomatic meningiomas that should be considered when complete resection is not amenable. After surgery, residual tumors not evident or is minimal, observation is reasonable, and regular follow-up is important. At the time of recurrence or progression, radiosurgery can be considered. Resection should be considered for the treatment of large and symptomatic meningiomas that are amenable to surgery. Single fraction radiosurgery, the dose, recommended dose is about between 12 and 14 grays, and the prescription dose of at least 12 grays should be advisable. The technique of radiosurgery or stereotactic radiotherapy will depend upon the tumor histology, the tumor volume, and the proximity to critical structures or eloquence. Hypofractionated radiotherapy or volume stage radiosurgery can be considered for large or critically located meningiomas, and hypofractionated radiotherapy is the optimal practice yet to be defined. However, 25 grays in 5 fractions is a common approach. Thank you very much.
Thank you so much, Professor Amar Al-Shahabi. So we'll have the discussion at the end of this talk.
So just one announcement.
Yeah.
Just one announcement. Due to, since we are running late, we will not have an official tea break. Tea is being served outside. Those who are interested can please have tea there. So we'll proceed with the session.
Thank you. And now I would like to invite the last speaker for this session, Dr. Oshima Samori, the Director of Center of Advanced Image-Guided Radiotherapy from Shin Yurugao General Hospital, Kawasaki, Japan. Over to you, sir.
It's a great honor to give a presentation here in India. I have some Indian friends, but this is the first time to visit India. Today's my talk is on atypical and anaplastic meningioma radiosurgery. Atypical meningiomas are reported to account for 20 to 25% of all meningiomas. Atypical meningiomas have tendency to relapse. The optimal management of atypical meningiomas after initial resection has yet to be established, though options include observation and adjuvant radiotherapy, including conventional EBRT, IMRT, or SRS-SRT. Anaplastic meningiomas have much worse prognosis than atypical meningiomas. Recurrence rate atypical 29 to 52%, anaplastic 50 to 94%. Anaplastic meningioma account for 1 to 6% of all meningiomas. Role of high precision radiation therapy. SRS and SRT for residual and recurrent after surgical resection is very effective. Target is only the tumor itself. If the tumor is well circumscribed and is not too large, it is very effective and definitely useful. But it is still controversial considering adjuvant following total and subtotal resection of these tumors. This is our data, which was already published. We treated 23 cases of atypical and malignant anaplastic meningioma. Mean volume is 9.8 milliliter. Marginal dose, mean marginal dose of 16.5 gram was delivered, and in 10 patients, local control was continued. Local control rate is 43% in 23 patients. Local control rate at 1 year is 74%, and 2 years 52%, 3 years 34%. Local control rate is not good, but survival was good. Only one patient died from brain tumor 91 months after gamma knife radiosurgery. Another patient died, but it was from lung cancer. So survival was good with additional treatment for local recurrence, marginal recurrence, or distant recurrence. Totally 15 repeated gamma knife radiosurgery was done additionally, and 7 surgical resection was done, and 4 stereotactic radiotherapy by ranaclomycin was done. We don't have difference between atypical and anaplastic meningioma in local tumor recurrence, but the population of anaplastic meningioma is small, only 4, but no difference. I will show you 2 cases. This is a typical case. First gamma knife was done after 4 months after subtotal resection in sagittal, superior sagittal sinus, small tumor. it disappeared. But another small tumor developed in a different portion, and it was also treated effectively by gamma knife, and more than 7 years the tumor was controlled. Another tough case, in this case, the tumor relapse repeatedly occurred. First gamma knife there and second gamma knife after 3 years. And 1.5 years later, third gamma knife for 2 distant recurrence was done, and fourth gamma knife done after a half year. These are marginal recurrence of the first gamma knife site. And then the tumor is stable 1 year. These are reported series of gamma knife for atypical and anaplastic meningioma. Tumor control rate is not high, but survival looks good. Many patients survived long. Next, considering adjuvant radiation therapy following total and subtotal resection, target including maybe prophylactic area following total resection. For example, 5 to 20 millimeter margin along meninges and 5 millimeter towards parenchyma. I use the same protocol. And as for subtotal, after subtotal resection, maybe prophylactic area, including operative field, and with additional tumor boost with a residual tumor after subtotal resection. This paper did not recommend adjuvant radiotherapy because the recurrence rate is not changed. This is a retrospective study, but in overall patient, 22% was recurrence rate. But it is not different after resection and adjuvant radiotherapy. 21% was recurrence rate, and no significant difference in relapse rate in all patients and in subgroups with adjuvant radiotherapy. 25% and 18%. So they did not recommend adjuvant radiation therapy after aggressive total resection. This paper recommends adjuvant radiation therapy. This is by conventional external beam radiation therapy. They treated 45 atypical meningioma. Recurrence rate was much difference between with post-operative radiation and without post-operative radiation, 8% against 41%. Relapse rate was much lower with adjuvant radiation therapy. But though relapse rate was high in without post-operative subgroup, but salvage radiation therapy looks effective in case of relapse among the cases without adjuvant radiation. All 3 patients alive after the salvage therapy with resection and radiotherapy, and 5 among 6 patients survived long after salvage radiation therapy. So observation and timely assessment with radiotherapy would be effective, even if the adjuvant radiotherapy had not been performed. This paper discuss on radiation dose of conventional EBRT. With 15.3 gray or less dose, progression-free survival was 70%, but more than 53 gray, 63% survived. So there are much difference. So they recommend 60 gray for non-benign meningioma recommended. Another paper, they also recommend 60 gray into grafting 2 gray fractions by fractionated stereotactic radiotherapy. They recommend. And they studied recurrence pattern after radiotherapy. Within 2 centimeter, marginal recurrence occurred within 2 centimeter in 64%, and within 3 centimeter, marginal recurrence occurred 91%. So it is difficult to decide how much prophylactic area we treat by conventional EBRT or IMRT, but so it is. I wonder it is good with 2 centimeter margin is good or not. This is a recent paper with adjuvant radiotherapy following total or subtotal resection with proton or photon beam. They use the same protocol, 5 to 20 millimeter margin along meninges and 5 millimeter towards parenchyma. They had good local control rate. 1 year 83%, 2 year 83%, 3 year 61%, 5 year 47%. So 5 year local control rate is 50%, about 50%. But survival was not good. Overall survivors at 3 years, 80%, 5 year, 53%. And among 24 cases, 10 patients dead, and 7 patients, tumor progression was cause of death, 29%. So this is the same slide of the first. So SRS and SRT for residual and recurrent after surgical resection was very effective, but adjuvant following total and subtotal resection is still controversial. And in addition, I will talk a little bit on hemangiopericytoma. We treated 7 cases, 10 tumors. Local control is better than atypical meningioma. 1 year, 100%, 3 year, 92%, 5 year, 67%. And sometimes we did repeated gamma-knife stereotactic radiotherapy for relapse, local or distant metastasis in 3 cases among 7 patients. This is a demonstrable case. After 2-time resection, small tumor was developed, and we treated it, and it was controlled. And later, another tumor, another very small tumor developed, and we treated that. And both are controlled intracranially, but she developed 60.5 years after second craniotomy. Huge multiple liver and lung metastasis occurred with symptom of nausea and vomit. And it was rejected and confirmed to be a metastasis of hemangiopericytoma. This slide shows the hemangiopericytoma, solitary fibrous tumor. Tumor control rate looks good, 70 to 80%, but sometimes the patient had extracranial metastasis, up to 35% of patients. So this is the last slide. Salvage stereotactic radiotherapy for residual and recurrent tumors of atypical and anaplastic meningiomas would be effective in the tumors after well circumscribed and are not too large. Adjuvant radiotherapy following total and subtotal resection might be beneficial, but remains controversial. Close observation and timely assessment for relapse might improve survival. Thank you.
Thank you, Professor. I think the floor is now open for discussion. You can bombard all the 4 speakers with questions.
So the coffee break is started, but I think we should discuss some things. And to put the first point, I would like to ask our neurosurgical colleagues who are here on the podium, what kind of medically fit patient you will send to radiosurgery, to radiation oncology without surgery? You're all brilliant neurosurgeons, but still probably you have some patients whom you don't wish to operate. So let's start.
Medically fit.
Yes.
Yeah.
Medically fit patient with meningioma, whom you will not operate, or you will operate everybody, if a patient can tolerate surgery.
It goes by patient, like now, if they have any deficits, medically fit, like now, though it is situated in like the tumors which I shown during my presentation, even if it is situated in the cavernous sinus, I would want to decompress them and give some breathing space for the nerves to recover, then send them for radiation therapy. Upfront, straight away, symptomatic patient, probably I may not. Like I would still make an attempt to decompress them, try to get them better with their neurological deficit, and then consider giving them adjuvant therapy.
Okay, thank you very much. Amar.
I think the main question here is the clinical status of the patient, whether or not he or she has a neurological deficit. I think this is the main issue here. If the patient has a clear neurological deficit, for example, if we're talking about non-basal meningiomas, then radiosurgery would not be the first choice. We have to relieve the compressive effect of the tumor and then do radiosurgery after that. And for the skull-based meningiomas, it may be slightly different. My conviction is slightly different for skull-based meningiomas. Because skull-based meningiomas, surgery is quite risky and is quite difficult. Risky for the patient, that I mean. Because of this, even if a patient is medically fit, and because we have seen the results after radiosurgery for skull-based meningiomas and how good they are and how comparable they are to surgery, with even some patient or 50 to 60% of patients even improving neurologically after radiosurgery. these are the patients that I can sit down and discuss with them both options. Even if they are medically fit, I will give them the option of radiosurgery. Yes.
Okay, please, your opinion. The same question.
No, there are some questions which has come in WhatsApp. So I would like to ask Professor Mahib. So without surgery in skull-based meningiomas, we don't know the grade or TERT mutation status. What would be the appropriate margin in such cases?
No, no extra margins. We prefer to cover the tumor 100%, but we are not expecting any glioma-like extra margin on that. We try to be close to margin because most of the skull base, when we are talking very close to critical structures, in fact, we have to reduce the coverage sometimes to save the optic nerve and other structures. So there is no question of margin. And also, we know that even if they are histologically chance that doesn't come out to be a benign meningiomas, which can happen, then even then, at that small tumor in the deep cavernous sinus, best approach may be, safer approach may be to give radiosurgery instantly. If it recurs, if it expands, then there are multiple options open.
Okay, thank you, sir. For you, sir, how do we decide between adjuvant radiotherapy or adjuvant SRS in post-op meningioma? When do you decide whether you want to give conventional or you want to give SRS?
It is my opinion. I will do adjuvant radiotherapy for atypical meningioma, but no, anaplastic meningioma. But I don't do it on atypical.
We have here a representative of MD Anderson Cancer Center, Professor McCutcheon. You're working in the cancer center #1 in the world, it is considered so. So what is your strategy for treatment of atypical, not anaplastic, grade 2 meningiomas?
So usually we would watch them and react with adjuvant radiotherapy or radiosurgery if there is some little hint of something happening, because we try to do a fairly comprehensive surgery. We know a number of them actually don't recur, so we want to make them prove that they need it, basically.
Now, the data in grade 2 meningiomas to give a 1 centimeter margin. Then if it is a 3 centimeter tumor and 1 centimeter margin, it becomes 5 or 6 centimeters for radiosurgery. So it is wise to give a fraction radiation in that, or you still consider radiosurgery for that?
You mean single fraction or multiple fractions?
Multiple fractions.
We might consider multiple fractions. We might for the larger volume.
Okay, there's a question here.
Yeah, I think the main, as I said before, the main question here will be the clinical status of the patient. If the patient has some sort of neurological deficit because of this edema. You cannot give a promise to the patient that this edema will improve after radiosurgery. What you will do is that tell him, I will control the tumor, that's what I can promise you, but the edema, it may increase. This is what happens more commonly, and that means that your deficit will increase. So, and of course at the end of the day, it's discussion between you and the patient. If he or she accepts the complication that may occur after radiosurgery, and it is anticipated and will be managed, then okay. The fractionation strategy with radiosurgery that's available with radiosurgery may be, in this case, sometimes preferable as we found in some studies that the edema would be less after fractionation. Maybe you consider doing radiosurgery with fractionation, 3 or 5 fractions for a case like that if the patient refuses surgery, for example.
Amr, can I ask you the related question about edema? You mentioned that in some patients you observed reduction of edema, in others it decrease. Do you have some predictive factors how the edema will behave after stereotactic radiation?
I couldn't find any predictive factors. That's why I was very careful about answering a question about doing radiosurgery with a patient with edema and deficit.
I am Dr. Naren. So my question is Dr. Yasamasa. So what is the idea behind giving the SRS to atypical and anaplastic meningioma? First thing. Second thing is, as you told that the SRS given in recurrent cases, whether these recurrence is after adjuvant conventional fraction radiotherapy or patient has not been given any radiotherapy. The recurrence after surgery, whether it is a complete surgery or subtotal resection. I have waited for having recurrence to give SRS, or patient were given SRS after giving conventional radiotherapy.
For anaplastic meningioma, after total resection, I use BMAT IMRT, the same protocol, 2 centimeter margin and 5 millimeter in parenchyma by BMAT.
So I just want to make one last comment regarding...
Maybe 2 or 2.5 gray of 25 fractions.
So what Dr. Devnarayan had asked about atypical meningiomas and the margin that you require. In fact, both the currently ongoing randomized trials of adjuvant radiotherapy and observation versus observation following GTR of a atypical meningioma use fractionated radiotherapy, the NRG BN003 as well as the UK Rome. So I think Rupesh can talk about the NRG BN003.
Yeah, actually that's what I was going to talk about. You know, this is an ISRS meeting, and so, you know, evidence I think is really key to how we practice. And although we can offer radiosurgery for benign meningiomas, I think for atypical and anaplastic meningiomas, we have to be very careful about the evidence that you have to support that practice. The best data actually for fractionated radiation therapy for atypical meningiomas comes from the RTOG0539 study, and you have an EORTC paired study as well. The current trials looking at the role of radiation therapy after a gross total resection, the Rome study has completed accrual. All of those patients were treated with fractionated external beam radiation therapy. And the NRG trial essentially is all photon radiotherapy. It does allow proton therapy, but they're all fractionated cases. If you look at consensus guidelines, for example, the ANO guidelines were probably the last set of guidelines. They did not recommend SRS or fractionated SRS or SRT for grade 2 and grade 3 meningiomas, given the lack of evidence. And since those guidelines were published, there have not been any prospective trials in that space. So I think in the recurrent setting, especially after fractionated radiation, there's key data. But in the upfront setting, we don't know the margins to use, right? So typically it's either 5 millimeters or up to a centimeter. We don't know the appropriate dose and fractionation schedule, whether it should be single fraction or fractionated. We don't know what to cover as well when you're doing radiosurgery planning. And so there's a lot of intricacies as to how to treat patients in the upfront setting. I think the data, if you look at it, it's not just about survival, because patients are not going to die from that tumor. But if you look at the data carefully, it's about marginal failures or out-of-field failures or even local failures in patients not treated with, you know, the appropriate dose fractionation schedule. So I have to be very careful about patient selection.
Thank you so much. Thank you for wonderful interaction. We'll close this session and
We'll
we'll move on to the next session.
We'll be moving on to our next session on SRS SRT of cellular tumors. I'd like to invite the chairs for the session onto the dais. Dr. Ashok Banaje, Chairman of the Cancer Center, Director and HOD of Department of Neurosurgery, Ruby Hall Clinic, Maharashtra. I'm Professor H.V. Ishwar, Professor and HOD of Neurosurgery Department, Sri Chitra Tirunal Institute of Medical Sciences and Technology, Thiruvananthapuram, Kerala. As a moderator for this session, I'd like to invite Dr. Professor Amiral Shahabi, Professor of Department of Neurosurgery, Ain Shams University, Egypt, onto the stage. I request the moderators to take over the session to please introduce the speaker for the session.
Good afternoon, friends.
Just a minute, sir. Just a small announcement. Refreshments would be being served in the hall across the exit. Please do feel free to use the service. All right, we'll be continuing with the session. Thank you.
Good afternoon, friends. I would like to congratulate the organizers for putting up such a fantastic show. I would now pass on the mic to my co-chairman and to the moderators.
Let's have the first speaker. Yeah. I think we are behind schedule right now, so I think I'll not waste any moment to invite Dr. Pavel Ivanov, Head of Department of Radiosurgery at the Sergei Bensin Medical Institute at St. Petersburg. He'll be speaking on SRS, SRT in the vicinity to anterior optic pathways. Over to you, sir.
Dear colleagues, first of all, I would like to thank local organizing committee for the excellent organization of this meeting, and also our colleagues from the ISRS, and for inviting me as a speaker. My talk will be about some aspects of using stereotactic radiation in close proximity to the anterior optic pathways. I represent the Neuro-Oncological Center of Berezin Medical Institute, which treats patients with CNS pathologies using precise irradiation. And even though it's covered with snow, more than 2,000 patients receive such advanced treatment there every year. In order to provide stereotactic radiation treatments for intracranial tumors, we have at our disposal sophisticated equipment such as Lexel gamma knife, CyberKnife, True beam, and proton beam. Nowadays, stereotactic irradiation is widely used for treatment of different intracranial pathologies, and this treatment means radiation delivery to the target with stereotactic accuracy and precision, and at the same time avoiding critical structures of the brain. One of the most important critical structure is the anterior optic pathways. Normally we use MRI and CT to visualize the anterior optic pathways in detail. In order to make these images reliable, MRI should have high resolution and be distortion-free. Also, it is preferable to optimize MRI sequences in order to reach the best contrast between the optic pathways and the surrounding tissues. Axial 1 millimeter thin slices images can provide us good optic pathway visualization if we orient MRI exquisition parallel to this structure. But we can see only each part of the structure, we can see only on 3 or 4 slices. In this regard, coronal MRI images provide us more detailed information because we can see 10 or 15 we can see each part on this structure on 10 or 15 images, and the nerve can be detected in each image more precisely. Fused MRI and CT images are also very useful. We can easily track the intraorbital part of the optic nerve in the coronal slices. We also can see the part of the nerve where it goes inside the optic canal. The intracranial part of the optic nerve is also well visualized with the help of the coronal slices. We can also see the optic chiasm where the fibers cross partially. And finally, the initial part of the optic tract before it's hidden by thalamus. In our practical activity, we met many situations with different types of tumors which can involve optic pathways with different levels of compromising. In this regard, one of the most important points is the differentiation between optic pathways from the tumor tissues. One of the situations when the tumor touch and displays the chiasm can be visualized with a combination of T1 sequences. T1, where we can identify the chiasm fibers, and the T1 with contrast, where we can see the tumor body very clearly. In more complicated cases, different MRI sequences are required. Sometimes we're not able to identify the chiasm, and so we should consider this when choosing the radiation regime. One interesting point is that we define radiation dose according to how we contour the critical structure. And this study revealed that the location of contours can vary greatly, even in the hands of the experienced practitioners. However, today we cannot do anything about this because there is no standard specialist independent approach to delineate them. Another unpredictable aspect arises from the fact that chiasm has physiological motion and it can move up to 1 millimeter, and this may change the dose by 14%. What dose we consider safe? From the early studies we know that a radiation dose less than 10 gray is safe for radiosurgery. In our practice we consider 8 gray as a safe dose. Studies that are more recent establish the dose for hyperfractionation as 20 gray in 3 fractions and 25 gray in 5 fractions. For radiotherapy, it is recommended to keep the dose to the optic below 55 gray. For radiosurgery, gamma knife is well known as a gold standard, as it allows us to cover the tumor with the prescription dose very conformally. And in this case, the doses which are higher than a prescription dose always will be inside the target with no hot points outside it. And there is a very steep gradient for doses which lower than the prescription dose. The most anterior tumor, which can be in close proximity to optic pathways is uveal melanoma, and we have to apply a high prescription dose for radiosurgery of this tumor. In this case, gamma knife allows us to create a steep gradient by blocking some beams and using composite shots, and it makes it possible to keep a gray away from the optic nerve. I would like to emphasize that total immobilization of the eyeball with the sutures is very important. We always use 3 sutures going in different directions. This is an example of breast cancer metastasis in the left orbit. The tumor also requires high dose, and as you can see, it seated very near to the left optic nerve, but a small distance between them exists. In this situation, we can provide gamma knife radiosurgery with a prescription dose of 18 gray with the help of the dynamic shaping. And the nerve not receive a dose of more than 8 gray. On the right picture, the right picture shows the result of such treatment after 14 months. The tumor completely disappeared. This is another situation with a brain metastasis, when the tumor, which lies in the intracranial part of the nerve before the chiasm, and touch the nerve without any distance between them. In such cases, we use 3-stage radiosurgery, where we use 8 gray as a prescription dose. The yellow shape shows the distribution of our prescription dose. The second radiosurgery was provided after 7 days, and you can see the previous isodose is a blue shape, and current prescription dose 8 gray in yellow. We can clearly see that the tumor volume decreased. And the third stage, after 7 days, the tumor shrank even more, and the dose of 8 gray was delivered with the same level of safety to the optic nerve. And this is the result of the treatment after 4 months. You can see that the tumor completely disappeared, and the ophthalmological examination revealed no deterioration of patient's vision. In those cases when the tumor is located just under the chiasm, gamma knife allows us to perform radiosurgery if there is a small distance between the tumor and the chiasm. This is an example of radiosurgical treatment non-functional pituitary tumor, pituitary adenoma, with a prescription dose of 12 gray, because the high dose falls rapidly outside the tumor. The isodose of 8 gray doesn't touch the chiasm. If we have the same situation but with the functional pituitary adenoma, it requires a higher dose, and we can deliver the prescription dose of 20 gray using dynamic shaping when some directions are blocked. And in this case, we can keep the radiation dose to the chiasm within the tolerable limit of 8 gray. In some cases, the tumor completely includes the optic pathways. This is an example of residual clinoidal meningioma where there is no distance between the tumor and the visual fibers, but they are still visible. The tumor covers the optic nerve, and in this case, hyperfractionation is the best option. 80 gray with 3 fractions was delivered by CyberKnife, and CyberKnife is the best device for such cases because radiation dose can deliver it with different beams directions when the beams are parallel to the critical structure and do not intersect it. That's why we can achieve such good tumor coverage with a steep gradient of both sides of the nerve. This is an example of tumor which completely involves the left optic nerve and the chiasm, but in this case we cannot differentiate the tumor from the optic pathways at all. And the only possible way to deliver course of radiation is the fractionated regime using linear accelerator, because it allows us to achieve homogeneous dose distribution. As I mentioned earlier, modern sophisticated equipment helps us to find many ways to avoid radiation damage to the optic pathways. However, optic neuropathy was described in several publications, and it results from neural and vascular mechanisms which leads to different kinds of visual deterioration. Now I would like to show you a case from our practice. This is a sphenoid meningioma, which should have been removed surgically, of course, but the patient refused to have the operation. We performed CyberKnife treatment in 3 fractions with a prescription dose of 80 gray. All doses to the critical structures, including optic nerve and chiasm, were below the tolerable level. However, 1 year after the treatment, the patient experienced visual deterioration, and the ophthalmological examination revealed this kind of visual impairment. MRI showed an area of hyperintensive signal on T2 in the projection of the left optic tract. The revision of dose distribution revealed that only doses from 6 to 9 gray were received by the left optic nerve. And we think that this complication mostly happened due to the fact that the beams didn't run parallel but across the structure. The patient was described a short course of corticosteroids and her vision improved. After that case, we always try to optimize the directions in which beams travel. And in conclusion, I would like to emphasize firstly that today in a vast majority of cases, modern irradiation techniques may be considered safe for the optic pathways, even when lesions are located in close proximity to them. Secondly, detailed visualization of the optic pathways using all available methods is crucial importance. The only way to ensure treatment safety is to use dedicated equipment. And finally, it is essential to choose the radiation regime SRS, HSRT, SRT, depending on the clinical situation and the ability to differentiate between the tumor and the optic fibers. Thank you very much for your attention.
Thank you very much, Dr. Ivanov, for this wonderful lecture. We will keep the questions to the end of the session, please. Our next speaker will be Dr. Tejpal Gupta. He is General Secretary of the Indian Society of Neuro-Oncology, Mumbai, Maharashtra. Professor, Advanced Center for Treatment Research and Education in Cancer, Tata Memorial Center, Navi Mumbai, Maharashtra, India. His talk will be about the role of stereotactic radiosurgery or stereotactic radiotherapy in the management of non-functioning pituitary adenomas. Please.
So, thank you for the kind introduction. At the outset, I'd like to thank ISRS for bringing this educational course to India, and Devnarayan Datta and his team for organizing this event here. I have been asked to talk on SRS, SRT for non-functioning pituitary adenoma. So, brief about the epidemiology. So, pituitary adenomas are not so uncommon, 10 to 20% of all brain tumors, but large majority are secretory adenomas, and nearly 1/3 are non-secretory. Now, the WHO classification has changed for pituitary adenomas, and now it is for the non-functioning pituitary adenomas, it is based on the immunohistochemical markers and the transcription factors, the nuclear transcription factors. So, essentially, what you get now is that you have to do the IHC staining for non-functioning pituitary adenomas, and the null cell adenoma is now a very small sort of proportion of all adenomas. You essentially would get some transcription factor positive even in non-functioning pituitary adenoma. So the commonest is actually the gonadotroph amongst the non-secretory adenomas, and as you can see, the pointer doesn't work. Only 1% are null cell, true null cell adenomas. Do we need to treat all non-functioning pituitary adenomas? And the answer is definitely not. And this is a natural history of conservatively managed non-functioning pituitary adenomas, nearly 2,000 patients in 30 cohort studies. This is a systematic review and meta-analysis of that with a 4-year mean follow-up. And essentially what it showed was that incidentally detected microadenomas need not be treated. However, if they are macroadenomas, then the risk of progression and needing subsequent intervention is quite high. So, incidentally detected non-functioning pituitary adenoma can be safely observed. So, what are the indications for radiation therapy in pituitary adenoma? A residual tumor which is not amenable for further safe resection. If there are aggressive biological features such as atypical features or invasion, if it's a recurrent and or progressive disease, medically inoperable or patient refusal for surgery, and very rarely if you encounter metastasis in a pituitary adenoma, which is referred to as a pituitary carcinoma. Are there any guidelines for target delineation? Not really. These are not consensus guidelines. This is from the Italian group, Minetti and his group, who defined a few years ago how to delineate the target for non-functioning pituitary adenoma. So, typically, as has been said throughout the day, you need good quality planning imaging and thin slice non-contrast axial planning CT, but you have to use a thin slice volumetric MR sequence, typically T1, the 3D FSPGR, but additional sequences such as the T2 and Fiesta are also useful, particularly if you have to identify the OARs very nicely. For non-functioning pituitary adenoma, GTV is the visible residual lesion on the post-contrast planning MRI. You typically don't need to add any clinical target volume to encompass microscopic disease, but you could consider adding a small, margin for aggressive invasive adenomas, particularly in the intra-cavernous portion. Sometimes it can be difficult to differentiate there. Planning target volume is used to account for setup errors and uncertainty, and as we know, this depends on the immobilization system that you use. If you use an invasive frame-based immobilization, you don't need any PTV margins. The GTV is equal to the CTV is equal to the PTV. However, if you are using a frameless mask-based system or a simple thermoplastic mask, then you need to give planning target volume. Typically, for a frameless mask-based system, 1 millimeter, sometimes occasionally 2 millimeters, and for a simple thermoplastic device, it's of the order of 3 millimeters. So we all know the definition of stereotactic radiosurgery, precise treatment planning and delivery of a large ablative dose of highly focused radiation with multiple beams in a single fraction, and as we heard since the morning, up to 5 fraction is now what the accepted definition is. I'll not go into the pathophysiology, but it does lead to endothelial apoptosis, ischemia, and reperfusion injury, and ASMA's dependent generation of ceramide activation, which leads to cell death and DNA damage. So for pituitary, how do we select patients for pituitary radiosurgery? So typically it should be a small volume disease, less than 30 mm is preferable. Typically, if the smaller the tumor size, the easier and better it is for radiosurgery. Very important, safe distance from the optic pathway. The previous speaker just showed that with gamma knife, actually you are able to sort of restrict the dose to the optic structures, even if there is a very little distance. But I think when we start any radiosurgical program, I think you should try and have at least a couple of millimeters away from the optic pathway. Of course, the patient should be still sedate and cooperative, and typically if you have a well-defined lesion on neuroimaging and non-invading into the adjacent structures, those are the kind of tumors in the pituitary that are more amenable to a safe radiosurgery. The bottom line is if less than 10 gray is not feasible, it is better to treat with fractionated therapy, whether hypofractionated SRS or conventionally fractionated VMAT IMRT. I don't need to show this to this audience. The most popular radiosurgery platform, or the gold standard, is of course the gamma knife. Now a lot of competition from the CyberKnife, and as radiation oncologists, most of us actually use the LINAC-based radiosurgery platform. How does CyberKnife compare with gamma knife? This is a data set on around 40 patients in a single center where they were treated with gamma knife or CyberKnife. And as you can see, the volume in the CyberKnife was significantly larger than the volume in the gamma knife. But if you look at the prescription isodose and the conformity index, of course, the gamma knife outscored the CyberKnife. However, if you look at the progression-free survival, there was no difference between gamma knife or CyberKnife. Both were equally good at achieving tumor control and providing good progression-free survival. How does gamma knife compare to LINAC radiosurgery? Again, this is data from a planning study where they compared a gamma knife with LINAC-based radiosurgery, and as you can see here, the gradient index was much better with gamma knife as opposed to LINAC-based radiosurgery. So no question that gamma knife achieves that fall off much better than either a CyberKnife or a LINAC-based radiosurgery. Amongst the LINAC-based radiosurgery, is there any superior technique? And this was again a planning study that was done 15 years ago, where they planned 10 patients with different techniques of LINAC-based radiosurgery, including conformal beams, arcs, dynamic conformal arc, circular arcs, and IMRT. And essentially, what they showed was that most of the techniques were comparable, but Novalis-based radiosurgery using dynamic conformal arcs was considered to be the most safe and effective treatment option. This is the guideline from the ISRS. Rupesh is here. He's the lead author on the first author on this. So this is a meta-analysis of over 35 full-text articles that have dealt with radiosurgery in non-functioning pituitary adenoma. And as you can see here, that the local control is upwards of 94%, whether you use a fixed effects model or a random effects model. So you get very good local control with stereotactic radiosurgery for non-functioning pituitary adenoma. This is single fraction radiosurgery. What about hypofractionated radiosurgery? Again, not too many studies of hypofractionated radiosurgeries, but essentially again very similar kind of local control in the range of 97%. So one thing that we know from these studies is that the local control is excellent and possibly cannot be improved upon. What the key points from the meta-analysis were that SRS is an effective and safe treatment for patients with non-functioning pituitary adenomas. Single fraction SRS associated with very good long-term disease control. For hypofractionated SRS, the short-term results are encouraging. We have to wait for the 10-year outcomes as far as the hypofractionated radiosurgical treatments are concerned. Now, this is data from Hinduja Hospital, Indian data, long-term hormonal and imaging outcomes of adjunctive gamma knife radiosurgery in non-functioning pituitary adenomas. And as you can see that there was a high risk of developing new onset hormonal deficits, and almost 30% of patients developed hormonal deficits at 10 years. But the local control was also was good, 87%, and endocrinopathy-free survival was 47.4%. So what the authors concluded, this was a series of 60 odd patients, that gamma knife is an good and effective adjunctive treatment modality for non-functioning pituitary adenomas. Now, what about conventionally fractionated radiotherapy? We talked about SRS, single fraction, and hypofractionated. How have we moved from simple to conformal techniques over the years? And we know that larger the number of beams and intensity modulation, that results in much improved high dose conformality and improved organ at-risk sparing. What are the outcomes with conventional radiotherapy in a non-functioning pituitary adenoma? This is again data from Minity and his group, who compiled a systematic review. And as you can see here again, the local control rate at 10 years is upwards of 90%. Of course, there is some toxicity, both visual as well as new onset hypopituitarism. What about the high precision conformal techniques such as the fractionated stereotactic radiotherapy, and now more commonly the IMRT? This is a typical dose wash of a fractionated stereotactic radiotherapy plan on a brain lab system. This is a typical dose wash when we use a rotational IMRT on a helical tomotherapy. So a comparison of advanced photon irradiation techniques actually showed that all techniques are actually comparable with one another, but overall helical tomotherapy provided the best overall indices in terms of target volume coverage, conformity index, and OAR sparing. What are the outcomes with conformal fractionated FSRT IMRT techniques? Again, as you can see, the tumor control rate is upwards of 90-95%, and the late toxicity is also much lesser as opposed to conventional treatments. So no radiotherapy comes without toxicity, and there are several toxicities of pituitary irradiation, not necessarily limited to visual deficits, endocrinopathies, risk of cerebrovascular accidents, second tumors, cognitive impairment, and occasionally brain necrosis as well. So if you look at the effect of pituitary artery on mortality, and you can see here, this is in the purple is the patients who've received radiotherapy, and in the red crimson is the people who have not received radiotherapy. And as you can see, that the mortality, standardized mortality ratio is significantly higher in patients who have received pituitary radiotherapy. So clearly, there is an effect of pituitary RT on mortality. What about the optic injury? And as the previous speaker also showed, the risk of radiation-induced optic neuropathy is very minimal at a Dmax of less than 8 gray, but it increases as the dose increases. and is almost more than 10% in the 12 to 15 Dmax in a single fraction. Of course, when we fractionate for a 3 fraction now, 20 gray is the tolerance dose, and for 5 fraction radiosurgery, it is 25 gray. What is the incidence of hypopit following GKRS in pituitary adenomas? And as you can see, it's variable, but it's not trivial. So new onset hypopituitarism is also common following radiosurgery for pituitary adenomas. What is the risk of ischemic stroke? It's variable, but on an average, around 6 to 7% following radiotherapy for pituitary adenoma. What about a second tumor following pituitary adenoma radiotherapy? There is an increased risk of second tumor following radiotherapy, although it has a very long latency period. If you see here, sometimes of the order of 13, 14, 15 years. But if you are treating a 40, 45-year-old person with a pituitary adenoma, that patient is likely to survive for more than 20, 25, 30 years. So that risk is real. It's not a theoretical risk. What about neuropsychological sequelae? So this has also been reported to be quite significantly high, particularly more in the secretory adenomas, but also in non-secretory adenomas, where nearly 30 to 40% of patients develop some degree of cognitive impairment following radiation for a pituitary adenoma. So can we safely defer radiation therapy till further progression in non-functioning pituitary adenomas with a subtotal resection? And this question has not been prospectively addressed, but this is a data set where they looked at patients who were observed and treated only when the tumors progressed. And the 5-year freedom from progression was 59%, necessitating further treatment either due to regrowth of tumor or symptoms or both. So 40% of patients required treatment following observation. There is a contrarian view. This is a matched cohort analysis of adjuvant versus on progression gamma knife radiosurgery for residual non-functioning pituitary adenomas. And what they showed was that whether you treated them upfront or whether you treated them at progression, you finally achieved similar tumor growth and similar sort of survival. So the jury is still not out on this, whether you should do upfront treatment or wait and irradiate at progression. Can we make pituitary irradiation safe? And the answer is possibly yes. At our institute, we have been using hippocampal sparing radiation therapy for pituitary adenoma in the context of a prospective clinical trial. In the short term, we have not seen any significant worsening of neurocognitive function or deterioration in quality of life. Of course, these are preliminary data. This was presented at ASTRO in 2018, and the manuscript is currently under review with a peer review journal. Also, can we use protons because of their sharp fall off, less dose to normal tissues, and now becoming more widely available? The Apollo Proton Cancer Center in Chennai became functional in 2019. At our institute at Tata Memorial, we've just started the first treatment on protons on 15th of August this year. So can protons be used? This is a comparison of proton versus photon radiosurgery for pituitary adenomas, and essentially neither modality had empirical superior dosimetry, and possibly you have to select and choose your patients, or maybe you have to plan them on both techniques, and depending on where you achieve a better indices, you would select your patient for proton versus photon radiosurgery. So this is the contemporary management algorithm for non-functioning pituitary adenomas. If they are incidentalomas and microadenomas, you just follow them up. If they are symptomatic or if they are incidentally detected but macroadenomas, then you possibly have to intervene. Symptomatic, of course, needs treatment, and the first line treatment does remain transsphenoidal surgery. If there is no residue, you wait and watch. If there is a significant residue, you could either upfront irradiate or irradiate at progression. Any recurrent tumor needs radiation, and patients need to be followed up long term, both for tumor control as well as toxicity of the radiation that we give to these patients. Finally, this is the ISRS practice opinion or guidance document for NFPA management. As you can see at the bottom, a prescription of 14 to 16 gray is recommended in the definitive setting or for the residual recurrent setting. The document says that hypofractionated stereotactic radiotherapy 21 in 3 or 20 in 4 or 25 in 5 can be considered for larger tumors and or closer to the optic pathway, but the long-term data on this is still not available and has to be contextualized. Before I end, I would like to draw your attention to two supplementary issues. One on pituitary adenoma, which Neurology India published a couple of years ago, which has a lot of details regarding not only radiotherapy and radiosurgery for pituitary adenomas, but about the pathology, the WHO classification and endocrinological management, and more recently special supplementary issue on radiosurgery, and this has a good review article on the role of stereotactic radiosurgery for functioning and non-functioning pituitary adenomas. I think this is, so in summary, you have to select your patients well, you have to select the technique that you want to use well. Typical radiotherapy prescription for fractionated is 45 to 50 gray in 25 to 28 fractions. Radiosurgical dose 14 to 16 gray mean marginal dose, and for functioning you actually need slightly higher doses. More than 90% local control at 5 to 10 years, but you do get new onset hypopit, and the late toxicities are not trivial and have to be kept in mind whenever we do pituitary irradiation. Thank you for a patient hearing, and I'm happy to take questions if any.
Thank you, Dr. Tejpal. Loved your clarity of thought and especially the details on the side effects. We'll have questions in the end. I now request Dr. McCushan, Professor of Neurosurgery at MD Anderson, Houston, Texas, to make his presentation on the role of SRS-SRT in the management of hormone-secreting pituitary adenomas. Up to you, Ian.
Aha. Thank you very much. I'm very happy to be here and to be invited to this very nice meeting in a place I've never been. Always nice to come to a new place. Now I have to figure out how to get this thing to go. Let's see. How do we make this? Thank you. So I'm going to talk about the use of stereotactic radiosurgery in managing secretory pituitary adenomas. I'm going to try to not talk about non-functional because that was talked about so well by Professor Gupta. Yeah, let's see. Yes. So, you know, the factors that impede surgical success with pituitary adenomas are the things either that limit the completeness of a resection, and those would be invasion, adhesion of the tumor, vascular encasement, such as within the cavernous sinus, sometimes a fibrous consistency, and certainly large size with a large surface area that then adds to all of those things already mentioned. And also the things that when there is a residual fragment that allow it to grow, and that becomes more a matter of the biology of that tumor, its degree of angiogenesis and its level of proliferation versus apoptosis. And so we do know that non-functional macroadenomas, when you leave some behind, it has consequences. Of course, that's also true for functional tumors, although with non-functional, the issue is more the size of the tumor, the fact that it will compress gland, will hurt the optic chiasm, and so forth. With secretory tumors, it's more what they will do to the hormonal status of the patient. So the radiosurgical considerations, we all know. The anatomy is important, the presence of the chiasm nearby. I'm going to skip through this because that's redundant. The goals of therapy are going to be similar for non-functional and secretory tumors, but notice that one of them in here is the normalization of hormonal hypersecretion. If you control the tumor size but don't control the excess hormone secretion, then you have not succeeded. We also want to minimize the loss of normal hormone secretion and, of course, avoid radiation injury to adjacent structures. So the nuances, we've heard, of course, that you have to protect the chiasm. Dr. Ivanov talked about that very nicely. We usually try to limit our chiasmatic dose to 8 gray or less, and we do like to have, if we can get it, 3 millimeters of distance from the chiasm and the nerves and the tracts. When the tumors have breached the dorsum celli, the limitation of dose to the brainstem is important, since the tumors may reach back to the brainstem, and that becomes an issue. We know that within the cavernous sinus, the cranial nerves are more radioresistant than the optic nerves are above in the suprasellar space. And of course, invasive tumors can have very complex shapes and require many different shots if we're talking about gamma knife. Hormonal normalization usually requires higher doses than you would need for controlling the growth of a non-functional tumor. So typically, with ours, we will give doses between 18 and 25 gray with a sort of prejudice in favor of the higher end of that range, if possible, 22 to 25. Whereas with non-functional, you can get away with smaller doses and still get success with that nice 93 or 94% success rate in, keeping the tumor volume from growing. And I'm going to talk a bit about, in fact, spend a bunch of time here on the hormonal subtype of the secretory tumor and how that affects the rate of success. I'm going to skip through that. It's interesting, target contouring, if you look at, this has been studied a long time ago, if you take a bunch of different people and ask them to contour the same tumor, you get a sort of a spread of volumes that are contoured. It varies by operator, and that's true for pituitary tumors as well as for meningiomas, but of course pituitary is the topic here. We've seen some of these kinds of things here. You can use dynamic shaping. We know this already. One thing that's actually important in discussing the secretory tumors is the fact that there can be cases where the patient's been operated on, tumor has been resected, and there is no visible tumor left behind, but there is still hypersecretion persisting despite the beautiful scan. And so when you gamma knife, you want to target, well, where is the target? Here the target may well be the entire cella. So when we have done that for people with persisting Cushing's disease or acromegaly, say, you get remission rates that are similar to those that are obtained by targeting a clearly defined lesion, as long as when you create your whole cellar target, you really do include the margins, let's say the dural margins, in a comprehensive way. And in fact, you may wish to go a little bit into the cavernous sinus to make sure, in case you have had some tumor that actually escaped through the wall into the cavernous sinus proper. This is a series that was, well, it's kind of a compilation of things by Castanetti. This was for a long time the good paper on secretory tumors and what happens when you use stereotactic radiosurgery against them. At the end of my talk, I will bring in the more modern one that we'll use for the true summary. But here you can see there's growth hormone, ACTH, and prolactin secreting tumors. These are the big three. There are also TSH secreting tumors. They represent 1% or less, and so I've excluded those from the discussion in this talk. And you get a different time to remission, as well as a different ultimate level of success depending on which one you've got. Growth hormone seems to take a little longer, ACTH a little less time, but still there's a lag of what can be as long as 5 years, or even in the case of acromegaly, longer than that, before you ultimately reach the maximum potential for success. And prolactinomas in this compilation seem to mirror relatively well the ACTH producing tumors, although that line for prolactinomas isn't quite as high. So they're actually the ones that have the least degree of perfection in achieving true normalization of hypersecretion. So an example, here's a residual prolactinoma. And typically, Gamma Knife for these cases is being done for residual tumor after an operation was done. And part of that is because we still tend to treat pituitary adenomas that are hypersecretory with surgery because we want to make sure we have histology to classify them, and especially now with the newer WHO guidelines where you're being asked to look at transcription factors. It's not that it's absolutely required, but it is recommended in the guidelines, and that is the wave in which pituitary pathology is heading. So we will tend to operate when we can, and then use Gamma Knife, SRS type procedures. In our institution, it's Gamma Knife in an adjuvant form. So in this case, prolactin was 62, which seems like it could be a little higher than that for a tumor of that size, but that's what it was. It was operated on, and then we have residual tumor in the left cavernous sinus, prolactin of 58. Then about a year and a half goes by after Gamma Knife is given. The prolactin falls to 29, still not quite normalized, and then wait another 2 years and it's down into the normal range at 7, with our definition of normal here being, depending on whom you ask, less than 22, less than 23, less than 25. This is the kind of comprehensive table from Castanetti's paper where they're looking at acromegaly versus Cushing's versus prolactinomas. And it includes the remission rate, the time to remission, and the rate of hypopituitarism. And so I'll get into all of these here in a little bit. What happened? Yes. So with growth hormone, it looks like basically they did a comparison that's not really a fair comparison between Gamma Knife and fractionated radiation, because the cases that you would put into each of those categories are not randomized. This is retrospective, and they're different kinds of cases. The tumor size, of course, affects who goes into fractionated radiotherapy. But you can see here with the solid line that you get a decent amount of remission, up to 70% or so in radiosurgery, and it takes about, according to this, about 2.5 years. So there's been a meta-analysis done recently that shows the tumor control rate, of course, the volume size control rate is much better than the endocrine remission rate. So volume control is achieved in almost all of these tumors, 92 to 97%. But the endocrine remission varies among the subtypes, and you'll notice that prolactinomas are the least successful, in the sense that they only get 28%, and that's over a significant period of time, whereas with Cushing's and acromegaly, you get up in the high 40s, mid 40s to high 40s. The rate of hypopituitarism also varies among these three, with, interestingly, the lowest rate for prolactinomas and higher rates for Cushing's and acromegaly. I suspect that the higher rate for Cushing's may have something to do with the fact that Cushing's is the more likely of these to be treated with a whole cella plan, in which you're not really sparing the gland, because Cushing's can be quite occult. But acromegaly can as well be. Prolactinomas tend to be not so occult and have a more formed target. So back to Castanetti again. They found, depending on whether they looked at growth hormone versus IGF-1, different percents for normalization. Ideally, in the way I would think of it, is you would want to see both of these normalized, but in fact, there are some patients where one normalizes and not the other. The mean delay is 36 months, and one interesting point is that 23% of these cases showed normalization of both on octreotide. This is, say, they have had their surgery, had a residual tumor that still persists with excess growth hormone, had Gamma Knife, and then they're put on octreotide to help minimize the hypersecretion while waiting for the effects of Gamma Knife to kick in. And so 23% of them show normalization at that point from the octreotide, despite the fact that prior to Gamma Knife, octreotide had been tried and didn't work. So that's actually a good point to think of, is that Gamma Knife may actually help to potentiate the effects of these suppressive medical therapies as well. Prolactinomas, they got, in this case, normalization in 47% with a mean time to remission of 29. It didn't seem to make any difference whether they were on or off dopamine agonist. That is to say, the drug that is typically used to treat prolactinomas, and the reason why these people are getting surgery in Gamma Knife is they've failed dopamine agonist. Cushing's disease, they had a 43% remission rate with a mean time to remission of 22 months, but it does extend out to almost 4 years in some. Here the criteria for remission being normal 24-hour urinary free cortisols twice and a normal dexamethasone suppression test. This fails to incorporate the fact that in Cushing's nowadays, salivary cortisols are often measured as well, and so you'd have to sort of, in a sense, redo the study if you were really going to want to modernize those data. I had mentioned Gamma Knife to the whole cella. This is when the functional adenoma is occult. The residual is occult on the MRI, and that comes due to the fact of either microinvasive disease in the dura on the edge of the cella, or multifocal small spots of residual adenoma around the edge of a larger resection cavity, or simply that the tumor is radiographically occult in the first place. And so when they do that, they succeed in half of acromegalics, 44% of Cushing's, and with prolactinoma again being the worst one, the more resistant one to this treatment, only 6%. So it's not a perfect solution by any means. That's a whole cella dose plan. We can skip through that. One thing is useful to consider in Cushing's disease, the concept that, of course, people who have a Cushing's situation who are, operated for a transsphenoidal, they are not cured, and then they go on to bilateral adrenalectomy at the recommendation of the endocrinologists after a non-curative removal of ACTH adenoma, get Nelson syndrome, which is to say an unleashing of the residual tumor, and it starts to grow aggressively within the cella. So Nelson syndrome doesn't happen in everybody who gets an adrenalectomy, but it does in about 22 to 30%, here 22%, with a mean time after the adrenalectomy of 24 months. What this study showed was that if you did radiosurgery to the cella, the whole cella, then before doing the adrenalectomy, the risk of Nelson syndrome was significantly less. And that's the lower line, in the dotted line on the graph there. So there is actually a bit of literature on this where some people have written papers suggesting that it doesn't help. Some have suggested that it does. I think the preponderance at this point leans a bit towards saying that it does. So if somebody is getting an adrenalectomy, bilateral adrenalectomy in Cushing's, you might want to consider doing Gamma Knife or CyberKnife to the cella to try to minimize the chance of a Nelson syndrome. When it happens, it's a real problem. Delayed hypopituitarism is mentioned, of course, in the previous talk. The incidence seems to be less with the stereotactic radiosurgical techniques because presumably they are, when they're not whole cella, but they're targeting a visible target within the cella, they are avoiding radiation of the gland to some extent. So the original, with fractionated radiotherapy, traditional data were that it was 50% at 5 years. Now We get here 16% at 5 years, so that's a decided improvement. It's most commonly going to happen between 3 and 5 years after treatment, and not always going to give pan-hypopituitarism state, but rather focal deficiencies, particularly in TSH and growth hormone, are what are seen. There's a technique called pituitary transposition that has been suggested in the literature by actually my friend Dr. Coldwell, who's the chairman of neurosurgery in Utah, well-known skull base and pituitary person, that you could do an operation to transpose the pituitary, to push it over, to get it out of the way, and that this would somehow be a benefit in reducing its exposure to some gamma knife or CyberKnife that's being done to treat a residual tumor. We don't do that ourselves. We think that it's a bit risky in terms of taking a gland that may be working and converting it into one that isn't perfect anymore in its hormone production. In their paper, 2 out of 34 got a new hormone deficit. I suspect that in the hands of many other surgeons it would be more than that. We don't do it. Preservation of anterior pituitary function over time. We see here the entire cohort, and it kind of gradually sinks down. Look at it even out to 10 years. It gets out to about 8 or 9 years before it levels off. So it can be a very delayed effect. What this paper was showing is that you can figure out factors that will predict to some degree whether pituitary function will persist or not by virtue of the distance between the center of the stalk of the gland and the margin of the tumor target being irradiated. And that distance is supposed to be best at, I think it's 3.5, if I'm remembering right, millimeters. And also tumor volumes matter, where they stratify it out where volumes that are lower do better, of course, than volumes that are higher, with that cutoff being at 2.3 milliliters. This graph is a much easier one to do something with. It is showing us the probability that a given patient will get pituitary hypofunction after stereotactic radiosurgery by dialing in different volumes of tumor, not stalk, different volumes of tumor and distance from the center stalk. So you can figure out your percent chance with the size of tumor and the distance from the stalk. Let's go. The best timing of gamma knife after surgery, basically this was studied for secretory tumors, adjuvant versus at the time of tumor progression. So, do you do it right up front or after surgery, or do you wait until it progresses? It doesn't matter, you get the same results. That's true. I'm going to skip past this because it's already been discussed, the visual dysfunction. Growth control after, well, we've gone through that. I'm going to go all the way to the end. Here we go. This is what I wanted to finish up with. So there is as you've noticed in some of the talks, there's an ISRS meta-analysis for different tumor categories, and that includes, they've done it for secretory pituitary tumors, and I think these are actually the most relevant statistics that you can take home with you on what happens for acromegaly versus Cushing's versus prolactinoma. The tumor control rate is excellent in terms of tumor size for all of them. The endocrine remission rate, which is the thing that matters, is worst for prolactinoma, and acromegaly and Cushing's are probably statistically not too different. They're both in the 45 to 50% range. The rate of new hypopituitarism is worst in Cushing's, as we mentioned earlier, and best in prolactinomas, but it's not bad compared to historical statistics that had much higher rates. So the overall conclusions, the efficacy is about 40 to 50% regardless of secretory status, unless it's a prolactinoma, in which case it's worse. The delay to remission is the longest in acromegaly. You can see this going all the way out to almost to 10 years. So things do take a long time, and if you don't do a long follow-up, you won't get the full results. Hormone normalization takes much longer to achieve than does stabilization of tumor size, so long follow-up needed. And that's what I have. Thank you very much.
Thank you very much, Dr. Ivan Matichion. We move on to complete the picture of cellular supracellular tumors with Professor Selçuk Peker on the role of SRS, SRT in the management of craniopharyngiomas. He hails from the Koç University School of Medicine at Istanbul, Turkey, and he is the Professor, Department of Neurosurgery and Chief of the CyberKnife Radiosurgery Center at there. Over to you, sir.
Thank you so much. And I would like to thank so much to the organizing group for inviting me to this perfect course. So now I will talk about the management of craniopharyngiomas with SRS and SRT. So I will begin with the basic info for the residents and the students, then the treatment choices for these problematic tumors. Craniopharyngiomas are rare histologically benign embryonic neoplasms. They place in the cellular paracellular region. They do see very infrequently. You see here the numbers, but in the children they can be a big problem because we do see craniopharyngiomas mostly in the children. And there are two groups of the age between 5 and 14 and 50 to 74 years. They make a group in those age periods. And most of the craniopharyngiomas are in the chiasmocellular region. So craniopharyngiomas develop from the embryonic remnants of the craniopharyngeal duct, other names Rathke's pouch, and it connecting, Rathke's pouch is connecting primary digestive tract and hypophysis during the process of pituitary gland formation. There are two histopathological types of craniopharyngioma, adamantinomatous and papillary, but for speaking about radiation, mostly we don't see any difference between both of them. But in histopathology, you can see these in different patients. But most of the papillary ones are seen in adult age, and they are mostly solid. So the placement of the, I can do it from here. Yes, it doesn't show. Okay. Here you do see a cross-section of the sagittal section of the pituitary stalk and the hypothalamus chiasm. The placement of the tumor is this area, so it is very close to pituitary gland, pituitary stalk, and the hypothalamus. So because of these neighbor tissues, we do see these kind of symptoms in these patients, and also the treatment may develop problems, side effects about these tissues. When we compare children and adult, mostly in children it is cystic and with some solid components, but in adults it is mostly solid. And when you compare in this table, you can see that in pediatric age, recurrence rate is high, hypothalamic obesity is high, endocrinopathy is high, mortality is high. So if you see a craniopharyngioma in a child, it may bring so much problem to the child. So what is the treatment of craniopharyngioma? In many years in the past, gross total resection is advocated. If you see a craniopharyngioma in a patient, adult or children, you have to operate and remove all the tumor. But this showed us that if you try to remove all the tumor out, you may make a harm to visual tissues there, optic nerves and chiasm. You may make a lot of problem to the pituitary and pituitary stalk, and due to that you may see a lot of hormonal problems after surgery, emotional problems, and the quality of life is not good for the patients who had gross total resection. Of course, it doesn't mean that there is a small tiny tumor there and you are operating the patient and it comes out. Of course, do gross total resection, take the whole tumor out. But if the tumor is adherent to these important structures, don't try to do a gross total resection. Leave some parts of the tumor there. If you try to do gross total resection, you may think that I removed all the tumor out. But because of this histopathology shows us that in craniopharyngioma, in most of the patients with craniopharyngioma, you may see some invasion of the cells into the neural tissue, like fingers there. So you may think that I totally removed, but there would be some residual cells there. So after removal of the craniopharyngioma, we should think about adding radiation to the treatment of the patient, for the treatment of the patient. You see here that if you don't do radiation, if you don't give radiation, the tumoral recurrence rate is high. But if you add radiation to your surgery, you will have a better response. In another article here, they looked for the quality of life, and they saw that if you do gross total resection, the quality of life is low. But if you do partial resection plus radiation, quality of life is high. So, as a neurosurgeon, I'm a neurosurgeon, for us to show the patient that your pre-op MR was like this and your post-op MR is like this. Do you see tumor here? No. Okay? I did my job perfect. This is not true. The patient looks for the quality of life. So it's very important for us also. Another article, they search for the gross total resection, subtotal resection, and the subtotal resection plus radiotherapy. And if you add radiotherapy to subtotal resection patients, you will see the response is better and the progression-free survival is high. In another article, they did upfront adjuvant irradiation after surgery, or they waited for the recurrence. So they saw that to do an upfront radiotherapy, radiation treatment, any kind, is better for the patient. So after surgery for craniopharyngioma, do not wait to irradiate. Do it as much as early. Another article, this is a meta-analysis for 750 patients, almost 750 patients, and they compared gross total resection and subtotal resection radiotherapy, and you can see here that the overall survival and progression-free survival were similar between the two groups, but the current this meta-analysis that gross total resection and subtotal resection with radiotherapy have similar survival outcomes for craniopharyngioma. But today we always think about adding radiation to all patients. And it's very interesting in the history, the first patient who had gamma knife radiosurgery was a craniopharyngioma patient. Craniopharyngioma seen very infrequently. And also I saw this article in the literature when I am preparing this speech. And in this first proton beam therapy for a pediatric patient was also for a craniopharyngioma. So craniopharyngioma has a different effect on our practice. For pediatric craniopharyngiomas, the effect of visual deficits and hormone deficits on the long-term cognitive outcomes, they searched for the 100 or more than 100 patients, and they did conformal radiation therapy for these patients with 54 gray and followed for 10 years. And if the patient treated in younger age, and if the patient had high doses to the hippocampus and temporal lobe, the IQ is lower. If the patient had a treatment for growth hormone deficiency, the response is better. And if the patient has baseline vision is bad, you will see a bad response to the treatment. Another article about proton radiation therapy for pediatric craniopharyngiomas, you will see here that the endocrinopathy rate, you can see that worsened is almost 47%. So if you do proton therapy, I mean in this series, okay? They did proton therapy and you see 47 patients has endocrinopathy. And visual, if you look for the visual problem, 10% of the patients had visual problems. And you see here the response rate for the tumoral size. So proton therapy is not so much, they may get some harm for the patient. So another article, they also looked for the proton therapy, response of proton therapy, and they compared the proton and the photon. You see here from the charts, and here also, they didn't find any difference about the response and about the complications. So for this article, there is an editorial in that journal, and they are asking that craniopharyngiomas and proton beam therapy worth the expense. I don't know. We have to look for it. ESTRO and ECROP guideline for target volume delineation of skull-based tumors also make some recommendations for the craniopharyngioma, and they say that GTV should be seen and targets from the T1 weighted and T2 weighted MR images. For solid portion, contrast enhanced T1. For cystic portion, T2 weighted images. For different kind of T2 weighted images can be used. And historically, GTV was, the PTV is around 10 to 12 millimeters of GTV. But today we are trying to give less doses to the peripheral tissue. And because of that, we do try to use stereotactic radiosurgery or stereotactic radiotherapy for these tumors instead of fractionated radiotherapy. And here in this guideline, they recommend to give single fraction, to give 12 to 18 gray, or for fractionated stereotactic radiosurgery, to give 21 to 25 gray in 2 to 5 fractions. Because if all the speakers said that we try to keep the optic nerves and chiasm healthy, so we have to be careful about the doses which goes to those structures. There's another interesting guideline from England, and they make this guideline for the pediatric craniopharyngioma, and it's a very long paper. I would recommend you to read it, and there is a part about radiotherapy, and they advocate radiation, of course, for these kind of tumors, etc., and they consider fractionated radiotherapy, and they have a lot of question marks in their mind about gamma knife radiosurgery. They wrote gamma knife radiosurgery here, but I think they wanted to say single session radiosurgery. But when you come to single session radiosurgery or hypofractionated radiosurgery, we do see good responses. when you look at the literature, we do see, for example, in this article, 3, 5, and 10-year overall survival rates after gamma knife radiosurgery was 95, 92, and 82%. And progression-free survival rates after gamma knife is 73, 62, and 42%. So if you wait a lot, you will see recurrences after radiation with, in this article after gamma knife radiation. In this article, they compared radiotherapy to radiosurgery, and they saw that if you do radiotherapy, these patients become more obese, because obesity also affects the quality of life. So they advocate to do radiosurgery instead of radiotherapy. So in this article, they saw that there is no difference between radiosurgery and fractionated stereotactic radiotherapy. So there are a lot of articles in the literature about every subject, every subject. If you want to say, this apple is very nice, you can find many articles about it. If you want to say, apple is a terrible fruit, don't eat it, you can find a lot of articles about it. So at the end of the story, you have to look for your experience also. We recently published this article from our center, and we looked for the effects of hypofractionated treatment for these tumors, and at the end you will see that 2-year progression-free survival is 81%, and 4-year progression-free is 61%. And in all patients, when we see progression, it means the cyst expanded or a new cyst developed. So there are many articles in the literature, as I showed you, that about the success. But in some articles, when you look at the literature, you may see that for 10 years, 100% of success. I don't understand this high of success, but I think for the long period, 5 years, 10 years, our success goes down. There are some case examples from our series. This is a 45-year-old male with impaired vision, and he had transcranial surgery. So there was a cystic Craniopharyngioma, and we gave 5 times 4 gray, and the result is here, and we didn't get any complication. This is a young lady, 25-year-old. She had transfemoral surgery, and we also gave for her 5 times 4 gray, and the result is here. This is also a male patient with 66 years old, and the result can be seen here. So in most of the patients, you can see that we do give 5 times 4 gray, because these tumors are very close to optic nerve and chiasm, so we try to keep the optic nerve dose less than 20. So if you do radiation do any kind of radiation treatment for these patients, and this is about radiotherapy, you may see some effects on the hormonal picture of the patients, and mostly you do see some problems with growth hormone and TCH. And in this article, they recommend that reduced target volume margins and radiation dose exposure should be a priority. So go to operation, remove the tumor, remove the cyst as much as you can. Don't harm the neighbor tissue, don't harm pituitary stalk, optic chiasm, nerve, and hypothalamus, and immediately go to radiation. This article also searched for all articles in the literature. This is a large review article you can see, and you see here this algorithm shows you that at the end of everything you should go to radiation. Okay, for craniopharyngioma, it is many patients. It is almost a must. So another another review article, search for the external beam radiation therapy, gamma knife radiosurgery, fractionated things. But you can see here very different results. Somebody says 100% success. Someone says 50-something% success, etc. Of course, the patients are different. The tumor size is different, doses are different, everything. So here, Sheehan's group reported their results for craniopharyngioma, and they say that the margin dose and the maximum dose to the tumor is important for the success. Of course, you should try to give as much as possible. And in this article, the results of CyberKnife, you see the local control rate is 85%, and for the single session, we try to give 13, 14 gray, but for hypofractionation, we try to give 20 or 25 in 5 days. We mostly use 5 days. We seldomly use 3 fractions. Here they compared the results with multi-session gamma knife, and they did it in 3 sessions, and they didn't find any difference between the techniques, single session or 3 session. Here it is an interesting article. In this hospital, there are 2 doctors, 2 physicians working in gamma knife department. One of them does single session to all patients. Other one does hypofractionation to all patients. So they collected all the patients and tried to see the difference between them. So they did find the difference between the BED2. If you can give BED2 more than 80 gray, your success will be high. But in this article, I didn't see how did they count BED in these patients, because it is very important. You all know that. And also from Pittsburgh, they found that if you can give more than 12 gray to more than 85% of the volume of the tumor, your success will be high. Another group said that, okay, if we are going to treat all the patients with radiotherapy after surgery, why we do surgery? Go to radiotherapy immediately. So they search for it, and their 5-year progression-free rate is 100%, and 10-year progression-free rate is 75%. So we have to think about it, at least for some patients. Today, we may see some articles about some oncological treatments for craniopharyngioma. Some medical treatments are done and tried for it, and we have to wait for the results for these studies. And as a conclusion, I would say that do not push for gross total resection. Subtotal resection is acceptable. Radiation treatment should be done after surgery, and we don't recommend to wait a lot. Single session for small tumors, hypofractionated treatment for larger ones, or which is close to organ at risk, for example, chiasm or optic nerve, and fractionated radiotherapy can be used for the large ones, of course, and radiation treatment can be used as a primary treatment for some small group of patients, but I don't know. Thank you so much.
Thank you, Doctor. The session is now open for questions, if there are any. I have one for Dr. Tejpal. You did allude to this during your presentation about incidental findings of pituitary tumor. That might apply to acoustic also. Is there any definite roadmap or policy that you follow? Every patient you follow, or you check whether it's functioning, non-functioning, size? What are the criteria that you follow?
So once you have detected an incidental pitnet on an MR, of course you will want to see whether it is a secretory or a non-secretory. and you would do the endocrine profile. If it is a secretory tumor, then actually you will have to treat it, because the secretory tumors, unless you normalize the hormone, you're not sort of curing the patient. What I showed was the incidental non-functioning pituitary adenomas. There, if it's a microadenoma, actually you can wait and watch. There is no real need to jump into treating them with surgery or radiation therapy. Of course, they have to be on surveillance MRI scans. In the first, what that guideline recommended was, in the first 3 years you do annual surveillance MRI scans, and later on you can actually reduce the frequency of surveillance imaging. As far as acoustics are concerned, now there is a randomized trial actually, the VREX trial, where incidental schwannomas were observed versus upfront treated intervention. And actually the intervention did show a significant improvement in progression-free survival, which is expected. I mean, if you're treating someone, you would expect that arm not to progress so quickly. Whether that holds out for overall survival is anybody's guess. Even the meningioma, the IMPASS study, it did show that the progression-free survival was worse in patients who were observed, but that is expected. If the overall survival doesn't change, one could argue that you can treat them at the time of progression.
Thank you. This is a continuation of this is a question for Dr. Tejpal again. This is a dilemma that we face. You know, when we operate, we leave a residue there in a non-functioning adenoma. You need a safe distance of 6 millimeter from the optic apparatus to deliver a safe radiosurgery or radiotherapy or whatever it is. The question is whether we should follow up or go for upfront radiation.
So I showed you two data sets, one which recommends based on, see, these are retrospective data sets, so very difficult to tease out the bias from them. So I think for most people, as far as, I mean, you said you don't need 6 millimeters. If you're doing radiosurgery, a 3 millimeter distance is enough. Actually, for fractionated radiotherapy, you don't even require that. I mean, you can actually treat quite safely, giving 50 or 54 gray. But the moot point is whether you should irradiate or not. The more recent literature, which Sheehan's group has done a propensity matched analysis, where they showed that there was no real difference. There were 260, 130 in each arm when they did the propensity matching, and they showed that whether you treated them upfront or you gave them a gamma knife at the time of progression, the difference in survival was not there. The previous publication actually showed that treating them upfront is better. So I think there's no straight answer to this. I think it has to be contextualized. Again, if patient is going to be on very close surveillance, understands the potential risks and benefits of surveillance versus upfront treatment, that's how you have to have a dialogue with the patient and decide what is best in best interest of that patient.
Thank you. We have a question from the audience.
Sure, actually, it's probably going to continue off of the answer that you gave. So with the VREX trial, so there's 2 trials now for vestibular schwannomas. This one is published, the other one is actually reported out as well, both showing a benefit and actually no hearing deterioration with upfront radiosurgery. So the question is, you got a benefit, but you didn't have any side effects essentially associated with the treatment. In pituitary adenoma patients who potentially could have morbidity from growth of tumor and other issues, does the VREX data, although in a different disease subsite, change some of the recommendations that you would make for pituitary adenomas that are non-functioning? Because in our clinic, at least, since the data came out, actually was presented at a skull-based meeting, all of the patients that were under observation actually got referred to radiation for consideration. And I'm wondering if this will now apply to the non-functioning pituitary.
So I don't think, I mean, the VREX would directly apply, but in our practice has been for residual non-functioning pituitary adenomas to offer upfront adjuvant treatment. So we certainly will not change that practice, but as you would appreciate that there is no good evidence to support that. I mean, that is something that we have been doing and we have been doing. So.
And then for the functioning pituitary adenomas, one of the topics that didn't get covered, but there's data for high-dose radiosurgery, so potentially for a growth hormone secreting tumors, 35 gray potentially is a minimal marginal dose with a shorter time to endocrine remission. And given the relative radioresistance with that. Would you consider that, or are you still doing 2024?
So we are actually currently planning a randomized trial of not a single fraction 35 gray, a hypofractionated regimen for secretory pituitary adenomas, where we are trying to see whether we can give 30 gray, 25 to 30 gray in 3 to 5 fractions.
Yeah, here is a question from the audience for Professor Ian. What is the dose prescribed when there is no grossly visible disease, especially in Cushing's?
Right. So we would typically give 20, somewhere between 22 and 25 gray for that. It depends on the radiation oncologist assigned to the case. That we have a diverse group that they all cluster within that narrow range. Yeah, and I think Cushing's patients do reasonably well in that range. We have not gone higher, like we were just hearing about in the previous question, but I think it actually kind of makes sense, given that we don't have perfect results in terms of there's room to improve the ultimate hormonal control and the speed to hormonal control, and so I think those studies are very worthwhile.
Just to comment about I'm a neurosurgeon, I'm Dr. Rajshekar. A comment about upfront treatment for incidental vestibular schwannomas. I know we're talking about pituitary adenomas. Although it may not harm, radiation may not harm the hearing, we need to consider the fact that there are studies showing the quality of life worsens in patients with any intervention, including radiation, surgery, microsurgery versus observation. So in other words, patients who are observed have the best quality of life. This is over 4 years. This is a little dated study, but nevertheless, that's a consideration that should be factored into. And just a couple of comments about focused radiation for pituitary adenomas, especially post-op. The target delineation is a very difficult problem. Everybody should realize that, both radiation oncologists and neurosurgeons, because we put in so much of fat and other packing material in there to distinguish the tumor from the fat packing material and other inflammation, the fibrosis that happens after surgery, needs to be really looked at very carefully, and therefore I think the surgeon plays a very important role in the target delineation. So please do not exclude the surgeon when you delineate the target for the radiation. And the second point I want to make is about the inclusion of the medial cavernous sinus wall for all macroadenomas when you radiate them. All macroadenomas need to have the medial cavernous wall dura included in the PTV. Thank you.
Dr. Rajshekar.
I think that's very good comment that neurosurgeons should participate in the dose planning. 100% agree. But I have a question to Professor Piquer actually about cystic craniopharyngiomas. You mentioned that the cyst can enlarge after radiosurgery, and we observed this. And previously we were very concerned about such expansion. But there are recent publications that show that this process of cyst expansion may be self-limiting. Something like temporary expansion of vestibular schwannomas. What do you think about this?
Yes, you are correct. Of course, in the patients who develop cyst in that area, if the cyst is very small, we don't recommend anything else. Okay, we continue to follow the patient. But if the cyst continues to grow and grow, there should be two options: another surgery, or maybe Omaya reservoir implantation. Because of this cyst development, these patients may lose their vision. So we have to be very careful about it.
Right, but initially it is possible just to observe this patient to see the dynamics.
Of course, yes, yes, of course.
So in continuation to this question only, irrespective of the treatment modality, the cystic ones are performing worse in comparison to the solid. So in the same setting as you showed that you treated in the 5 gray, just with the stereotactic cyst aspiration and then the stereotactic radiosurgery in a single session for that solid component, which is the wall which is left behind. So we can just avoid a hypofractionation regime in that case, and the cyst is taken care of.
For cyst, if the cyst wall shows contrast enhancement, we have to add the cyst wall. But if there is no contrast enhancement in the cyst wall, I don't add the cyst to the treatment, to PTV, okay, GTV, whatever you say. So if you think that the cyst has, you see that if the cyst has, wall has contrast enhancement, if you drain the cyst by surgically or with Ommaya reservoir or with aspiration, single aspiration, of course you can irradiate it. Yes, the target will be smaller. Yes, yes, target will be smaller. Yes.
Okay, I have got a question. So many times in the kids, the young adults, we have multi-compartmental cranios. So I have gone for a surgery, I have taken out probably everything, I left a small part behind. So the thing is that those patients have recurrences maybe anywhere. So it is not that it is only going to recur where I have left the tumor. It may be because it may be in the third ventricle, it may be into the paracellular areas, the rectocellular. So my question is that how do we plan a radiosurgery only for the visible tumor in those cases?
Professor Picker.
This is the philosophical question. If we are going to give radiation to an area which doesn't need, you will harm there. So if you think that after surgery, for example, you operated a very large craniopharyngioma and you are the surgeon and you are telling that, I think there are a lot of small remnants around the surgical area, so I will not do radiosurgery or hypofracture. I will send the patient to the classical fractionated radiotherapy, of course.
Professor McCutcheon, I have a question about cabergoline. To give or not to give before radiosurgery?
So, as far as I know, there hasn't been, well, so there was originally suggestion by Landolt long ago that if you took them off cabergoline in advance of radiosurgery by 4 weeks, 6 weeks, 8 weeks, that they would do better. That wasn't really proven by subsequent studies. That there was a statistical association with taking people with Cushing's disease off of ketoconazole, and we actually do that. We follow that. But with cabergoline, it hasn't really been proven. We take them off because we want to know what the hormonal result is.
That's
right?
the second part of my question.
Right. So we want to be able to assess them properly without the influence of interfering medications. So, but we don't necessarily somehow believe in our heart from what we read that it actually matters in terms of the, and that's not a proving statement.
Yes, that's our experience.
It's more like it's in your heart.
Yeah. But the ketoconazole data is compelling, no doubt.
Yeah, it has statistical significance.
Yes, and the second part was about also cabergoline, patient coming to you already taking cabergoline, and he has a mildly elevated prolactin level, and you're not sure if it's actually a prolactinoma or not. It's better to assess him properly, take him off the cabergoline for a month or two, because you know the hormone may be elevated because of stock effect, not because it's a true releasing prolactinoma. So you have to properly assess the prolactinoma patients, particularly that are on cabergoline, before deciding this is a prolactinoma, and because the dose is different for prolactinoma as regards to a non-functioning adenoma.
Right, exactly. We completely agree with that.
So, what do you feel? Let's say only 40-50% is the control rate in secretory tumors. That in the long term, secretory tumors control growth, hormone control rate is endocrine remission rate. Isn't it 40?
That's correct.
How you can improve on it? Any idea on that?
So, I personally have not thus far been able to figure out a way to improve on it. What was mentioned about going to higher doses, as I was saying, that makes some sense to me, because, you know, given that we can focus the treatment, if you can really focus it properly and avoid the chiasm and avoid as much of the gland as you can, then maybe it's worth it. And so I think that might be a future direction that proves fruitful, but we have to see the proof.
Dr. You showed that the data between gamma knife and CyberKnife outcome data, there is not much difference in terms of outcome. But in dosimetry, there's a huge difference in terms of. So now, as a radiation oncologist, you always see the dosimetric benefits, and you see that this is represented in terms of clinical outcome. It is not happening. So how to go about it?
I think whatever machine you have, treat on that. You shouldn't buy a gamma knife just because the dosimetry is superior.
Okay.
I mean, if you're spoiled for choice, then.
Okay, I have one question that came in. Is coverage in pituitary tumors with helical tomotherapy also comparable to LINAC-based SRS and CyberKnife? The question is...
yeah, so in that particular manuscript, the overall, if you looked at gradient index, conformity index, homogeneity index, the best indices were achieved by helical tomotherapy. The newer platform of helical tomotherapy, the Radixact, I think can even do better. I have not worked on that, but we have been using helical tomotherapy for treating pituitary adenomas, and I mean, you achieve very good outcomes as far as dosimetry is concerned.
Okay, just one more question about the waiting for the tumor to grow, a residual tumor to grow, and then do radiosurgery. From the philosophical point of view, if you're going to wait for the tumor to get bigger and then treat it, would that not be riskier and more prone to failure with the radiosurgery? I mean, why don't you treat it when it's more far from the vision and you're able to give it a higher dose?
So I think, as I said, the practice that, I mean, what we follow is to treat upfront treatment, but as radiation oncologists, we have to be aware and cognizant of the fact that there is a lot of delayed complication. No radiation is always better than any radiation, whether it is gamma knife, whether it is CyberKnife, whether it is LINAC. So a significant proportion of patients may not need radiation at all. So I think it's difficult to identify who those are, and that's why everybody ends up getting treatment. I think if you have biomarkers where you can identify that this residual adenoma is likely to grow. So one of the things is the size. If the residual adenoma is very, very small, probably you can safely observe it. But if that residual adenoma is largish, then it's not a good idea to observe. If it is involving the cavernous sinus, you know that you will never be able to go in again and remove it. So I think there are potential indicators where which patients you can select for observation and which patients you can do upfront treatment. But I think, I mean,
that's provided the patient comes for observation.
Of course, of course.
That's the problem.
Coplanar, yes.
That has improving her non-coplanar. So how do you say that?
I think so initially when IMRT was not the standard way treatments were done, it was using only conformal, I mean the 3D plans. I think the non-coplanar beam geometry was definitely required to achieve that high conformality. Having said that, I think there is an advantage of using non-coplanar beams, even more so with a radiosurgical treatment. In a fractionated 45 gray and 25 fraction, I think the benefit of doing a non-coplanar geometry is particularly not there. So Radixact also treats in a coplanar, but it is helical delivery. The couch translates as the beam as the treatment happens, and you achieve at least the high dose conformality is excellent. The gradient that you achieve is also good. I think the problem with the VMAT type of treatment, including the rotational IMRT, is the low dose spillage that you get. I think that you can reduce if you use non-coplanar beam geometry.
Okay, thank you, Dr. Gupta. I think we have to close the session now because we're behind. Thank you very much for the speakers. So, last question. Okay.
So just coming to that primary question which came for adjuvant versus wait and watch. So there are two caveats. One is the tumor control. Second is the secondary hypopituitarism. So tumor control has always been good. and those both IRF studies I read about it, but the only thing which they showed that we are not sure about the dynamics of the tumor growth. There is no marker for that, and that needs a very comprehensive and a regular follow-up. And if we allow the tumor to grow, it goes closer to the pituitary stalk, and once it has already grown, it becomes very difficult to avoid an 8-gray exposure to the pituitary stalk, which is actually a harbinger for your further hypopituitarism. So the length of the follow-up is actually going to decide, because those both studies have a shorter length of the follow-up. So we can't definitely conclude on it whether we should just wait and we should be on an aggressive proactive platform to give a radiosurgery to a residual non-functional adenoma.
So I'm certainly not advocating that you wait or you treat. I think there is no good evidence to support either. I think it's you have to discuss this best with the patient, and if the patient is compliant, understands the risks and benefits, you can wait and watch. But if you feel that the patient is going to be not coming for observation, not compliant, possibly it's best to do the adjunctive upfront treatment.
Thank you very much. Thank you. We conclude the session. Thank you very much for the speakers. Thank you.
With this, we come to the end of our morning session. We'll be briefly adjourning the session for lunch now. Lunch will be served in the common hallway, and we'll be resuming the session back by 2:10 p.m. And just a gentle reminder, we'll be having an official inauguration function at Marriott Hotel at 7 p.m. in the evening. We do request for everyone's presence for the same. Thank you.
Once more reminding we need to reassemble here by 2:10 p.m. so that we can get the sessions back on track. Thank you. Okay. If time permits, please take time to visit the exhibition halls which are behind the this main hall. You can access it through the back door as well or through the side doors here.
It is there already. They have to make some control changes there. I think I have to mail and download it. Mail and download it. It's not getting detected here.
So you just mail it to my mail ID, sir. I'll download it from there.
1 second. Just check now. Pops. ఏమైంది చెప్పు నాన్న చెప్పు నాన్న చెప్పు బిడ్డ నేను కాన్ఫరెన్స్లో ఉన్నాను చెప్పు ఏమైంది సరే ఓకే బాయ్ కంగ్రాచులేషన్స్ కీప్ ఇట్ అప్ I think they have to come and change this. I gave you your pen drive, no?
My pen drive is fine.
He's doing it. Can I
We'll start with the first session, that is a satellite symposium of SAP Surgical, use of wall-free, cobalt-free gyroscopic radiosurgery for intracranial and functional pathologies. The moderator for this session is Dr. Mahib Singh Gaur. He is a senior consultant, neurosurgeon and director, Stereotactic Radiosurgery, Brain and Spine, Valentis CyberKnife Center, Meerut, Uttar Pradesh. So please. And I request you to please introduce the speaker for this session.
Hello. Good afternoon, friends. I think now we have some calories in our brain, so we can listen better. And
this is the wrong talk.
We have been doing radiosurgery in India since 1997, since the start of installation of gamma knife surgery. But there were Linac-based radiosurgery in Apollo in Chennai, and Dr. Ganpati and Dr. Staff doing it earlier, but in an early way. So we have seen over years radiosurgery in India grow by using CyberKnife and X-Knife, Novalis, all type of modalities are almost available with us. Early this year, I could use the Zap-X system in Japan. That was the first time I was exposed to it and realized the high technology it is used to make a gyroscopic system. And beyond gamma knife, only neuro-dedicated system, which can have forward planning also. So we are lucky today to have Mr. David. He has been educated in London and has been involved with radiotherapy since then. And he joined Electa and participated in development of VMAT and CBCT. And later, 2015, he joined, he went to radiosurgery and development of ICON. Since last 3 years, he's a development officer with Zap-X, and he was the European head of business development for Zap-X. And today he will deliberate and bring more knowledge to us regarding this new excellent system, Zap-X. Thank you. Please, Dr.
Thank you for your kind introduction. And thank you very much for your time today, and thank you to the organisers for allowing us this opportunity to introduce the Zap-X to you. So, historically, we've all talked about this morning, you've had the historical systems, you've had the gamma knife with the latest version, the Esprit, and the latest CyberKnife, and then you've got various forms of the Linac. And what we believe we brought is a hybrid solution. So we're combining the best of gamma knife and the practical side of a Linac into a new device dedicated just for intracranial work. And this was really driven by the vision of John Adler, who you probably all recognize as the inventor of the CyberKnife. He has now come up with a new device because he doesn't think enough people around the world get the opportunity to have radiosurgery. And you're talking hundreds of thousands when he thinks it should be millions of people a year should have the opportunity at least to have it as an available treatment. So he thought there were drawbacks to that, and he thought he could fix those drawbacks by designing a new machine. And that's what I hope I'll show to you today. What you might find also interesting is that John Adler was the chief medical officer at Varian, and this product was actually inside Varian. And they decided not to proceed with it. But John Adler believed in it so much, he said, I'll buy it off you. So he bought the rights of it. And from that, we now have Zap Surgical in California. And obviously, I think the need for a dedicated system now is increasing year on year. And one of the big drivers now is brain mets. With brain mets now, with immunotherapy drugs, patients are living much longer, and they're also coming back for retreatments, and you're having multiple mets maybe treated multiple times. And therefore, having a dedicated system can sort of get around some of those issues. And of course, it also means that we're now getting brain mets from primaries that we didn't used to get them from, because they are living much longer. So again, there's a large new cohort of patients that are coming down the road, and as the drugs get more effective, I'm sure those numbers will increase. And of course, there's a lot more data now coming out that whole brain radiotherapy really isn't a primary source of treatment, but more of a salvage type of treatment. So I think people are moving and accepting that treating METs and multiple METs is the way forward. And again, lifetimes and life expectancies, and this was taken from a meeting this year, where you're seeing totally different now life expectancies with patients. When I first joined the industry, which was, afraid, a very long time ago, a lot of melanoma patients would be lucky to live a short time once the disease progressed. And then the other area that is going to be very interesting going forward is its use in functional treatments. And there are many treatments that are being explored. I think some are more readily accepted now. With trigeminal neuralgia, I think is readily accepted around the world. But there's lots of work going on in essential tremor, epilepsy, pain management, etc. And also addiction, which I'll come back to. And this is really from a slide I took a photograph of from the British Radiosurgery Society from Sheffield, who are a well-known centre. And they have now got 14 years follow-up on their trigeminal patients and being pain-free at 14 years, which is a reasonable result. If we then look at essential tremor, this can change people's lives as an option, with patients coming in with debilitating diseases, they can't even feed themselves, and then after a selected patient having radiosurgery, they then have a much more tolerant life. And then substance addiction, this could be millions of patients, and this is the one that John Adler is actually personally involved with. We've just completed trials on pigs in a study, which was very successful. And now he's looking through the ethics committees to look at starting human trials, at looking at radiosurgery for treating addiction. As you can imagine, this would involve millions of patients around the world, should this come to fruition. We then also have the advent of stage radiosurgery. So the bigger targets that now become an option for radiosurgery, so you're using the biological effect. So for the first fraction, in this case it's 10 grays, but there are various formulas currently going on. And you do the treatment, but then you wait 2 weeks and you get shrinkage. You then replan for the smaller volume and deliver another treatment. Again, you wait 2 weeks and it shrinks again. And sometimes it can be 80% less than the original volume, which makes it a very tolerable treatment. And there's a lot more centers around the world doing this. We also, with our machine, is if you've got this wonderful dose gradient that the Zap-X have, why would you not use it for all your head and neck work? We're not ready yet, but on our pipeline of our journey of our machine, we are going to have cone beam CT and dynamic treatments. All the others have already put those into their systems. So we have a lovely journey to go. So what you see in results today is what we have with our existing machine, but we're just going to climb higher. And then I think, obviously, the world is in economic stress as well. So people are going to start to look things more closely. And if a patient is acceptable for radiosurgery, the actual social economic cost to the patient could be a very important factor. And this was from Southampton here, showing it's a substantial cost. And then there was a randomized controlled trial in Marseille, where they actually looked at patients going to their gamma knife and then going to surgery. And it was quite astonishing, the results. Of all the patients that had radiosurgery, only one patient had returned to work after 7 days. On the actual surgical arm, 60% of the patients hadn't returned to work after 3 months. That's a very long time. And Professor Regis told me that 10% of them never returned to work. So this has a huge impact on society, because either they need carers at home or they lost their job and they're not paying their taxes. So again, it really does affect lifestyle. So what we now have, I think, is that hybrid system of the practicality of the gamma knife, of the Linacs, and the dedication of the gamma knife. And one of the first areas that John Adler wanted to do was make it much easier to actually start doing radiosurgery. So we're the only machine in the world that you don't need a bunker. It's actually a bunker itself. I know with the gamma knife that there's a lot less shielding, but it's still a radiation area. And I can tell you the operator will not be sitting in the room with the patient. And we've been doing patient surveys, and there's been some really wonderful feedback, because obviously having a treatment is quite psychologically challenging. And so they've been putting a couch in there so the relative or a friend can sit in the room with them, and they've said it really chills out the treatment. Also, unfortunately, some patients will be ill during the treatment. And with our system, it means the operator with an override can be with the patient in seconds. So we might actually get the sick bowl under them before they actually contaminate the machine, which could be another asset to the department if we can look after the patients in that way. That was the first installation in Lingen. Didn't mean to go forward. In Lingen, and this was really a good one for John Adler, because this was a centre that had no radiotherapy, let alone radiosurgery, and it was like 100 kilometres to actually get radiosurgery. So the neurosurgeons here decided, well, we'll make our own. So they literally just have a Zap. There's no other equipment there. And this has been a very successful project. And then we have the system in Zurich. And this is an interesting story as well, because unfortunately there's no daylight because it's in a bunker, because the bunker was actually designed for a gamma knife. But unfortunately, the licensing authorities in Switzerland would not allow them to import the sources, because the IEA have given out a document where they're asking people now to look at alternatives to using sources. And if there is an equivalent, they believe you should use it rather than sources, and hence the gamma knife in Zurich. And it also shows what a small footprint our machine is. But it actually makes the gamma knife a lightweight. We're probably twice the weight as a gamma knife, so you've got to make sure the floor is very secure for it. Then this is the system in Munich, and this was in the European CyberKnife Centre. It's now the European Radiosurgery Centre, because they have added the Zap-X to their machine. So they've still got their CyberKnife, and obviously that's a wonderful machine. You can do all the extracranial work, and then you've now got a dedicated machine for their intracranial work. And it is really quite nice, because they literally just put it on the end of the building. So it's a very low-cost option to add this. And unfortunately, people are now looking at carbon footprints. A bunker is equivalent to around 300 automobiles. So that's a significant carbon footprint. So by going down our route, and again, there could be reasons when your capacity issues, so you've got larger numbers of patients, you need to add a new machine. By then having a dedicated intracranial machine, you're just tagging it on the end of the building like they did in Munich. This could save a lot of costs and also help with your carbon footprint. And then if we look at the bunker in a little bit more detail, you've got the traditional room on the left, where you've either got a maze or a door, and on the right is the Zap-X, and the light blue here is a virtual bunker. So this is electronically controlled. If you walk in there, it just terminates the beam, and then you then stops the treatment. This is another one that I think is a good feature to show you the idea behind John Adler. This is a hospital in Tokyo that decided to put the Zap-X at the railway station. So the actual Zap-X is on the first story at the railway station, and they said this is much easier then for the patients to access the machine. And I was very fortunate, a physicist from the UK was in Japan on other reasons, and he sent me this video. So he was just literally walking around Tokyo. It takes a little while for him to pan round. But there's our Zap-X actually in use from the street, which I thought was quite intriguing to see radiotherapy or radiosurgery from outside. And you can see it moving there. So how do we do what we do? So we have the same axial gantry that you would have with the traditional Linac, but what we've done is we've added an oblique gantry. This enables the Linac then to spin in many more directions and deliver the beam from many angles. We then have the sphere that contains the radiation, Then we have a rotary shield that comes up once the patient is in the machine, and finally the door closes behind it. We have quite a lot of feedback because obviously the first patients, we have questionnaires, and we were concerned about claustrophobia, but so far, touch wood if you can say that, for luck, we've had really very little feedback on claustrophobia. And one of the comments section I thought was very intriguing, so I'll share it with you. They said after being on the CT and MR, it was like moving from a church to a cathedral when they went in the Zap-X, which I thought was a very good way of sort of saying that it's like a little room. It's very light and airy. Then we have the couch, and like the Gamma Knife, it's integral to the machine, so you get really robust couch with sub-meter accuracy for the rest of its life, we would hope. We then have the imaging system for real-time imaging, so you do your patient setup, and then you do the constant monitoring of the treatment. We then have our linear accelerator and collimator specifically designed for intracranial radiosurgery. We then have a dose panel monitor as well. So we are actually then monitoring the treatment as it progresses, and if it goes outside tolerance, we will terminate that treatment. If we look at it in a little bit more detail, the sort of headlines of the system, and you can see the video there moving. So we have a 3 MV, a high 1500 monitor units, over 260 beams, and I'll come back to that. We have ultra low leakage, because this is really important. A lot of your patients will not have conditions, they might have a benign cancer or functional or vascular, and they could live 60, 70 years after treatment. So keeping that dose low is good. Then we have the 45 centimeter distance, which again is helping with the dosimetry. So here we are, the gantries, and you'll see the video spinning. So we have those 2 gantries, and we have a bore of 83 centimeters, so it's quite a wide bore even when you're going into the machine. And once you're inside, it's 165 centimeters. If you see it spinning, there's a green window when it rotates around, and that's actually, there's 2 leg glass windows in it, so that they could even see out of our machine if they want to. Then the collimator itself, we have 4 millimeters to 25 millimeters, and it's very easy. You can see it just spins round changing, and in the next picture it gives you a better idea of how it works. So it just literally rotates, changing the size of the collimator. And we've designed the 25 millimeter collimator for inserts. So we're just finishing clinical trials, and I'll show you more detail, on a 3 millimeter collimator, and we have in the roadmap a 2 millimeter collimator. And that dose is very important. So we're not quite as good as Gamma Knife, but we're very close. So we really are keeping that dose low. And I've always thought, because I'm an engineer by background, that if radiology cares about the whole body dose, why does not radiotherapy and radiosurgery? So trying to keep that dose as low as possible has to be very practical. Then we have the 45 centimeter distance, because we're just treating the head. We can go much closer to the patient. And this is really comparing it with the Gamma Knife, showing we're very similar in the distance to the patient to the Gamma Knife. Then we have this comparison charts looking at the beam profiles of the CyberKnife, the Gamma Knife, and the Zap-X. I don't know why it's going to the other one, that's not me. And it shows you how good that our dose profiles are. If we then look at the imaging system, we have a KV system, so if you're familiar with the CyberKnife, this would be very familiar to you. We have a frame-based system, so we are using masks, but a number of our new users have actually asked us if we can have a frame, so that's also in clinical testing at the moment and will be available shortly, because I fully understand where they're coming from. When you're delivering 70 grade plus, that solid frame, it's really good for your sort of mental attitude, I think, with the fixed frame. And therefore, we hope by having it on our system, you'll be able to compare with the mask and show that actually it works very well. So we have interfraction movement. You have the DRR comes from the planning system, is compared with the live image for setup. So you do your setup, and then you do sub-millimeter axis during treatment. And you must note here that it's actually in the treatment position. So all of the imaging is actually in the treatment position. Not all are like that. Then we have the online dosimetry, so we have the flat panel checking the delivery. And then just a quick recap, so it's 3 MV, 1500 monitor units, 260 plus beams, low leakage, and 45 centimeters. If we look at the planning system, it is a proprietary system, as you would imagine. We use primary CT, which is different to the Gamma Knife, more familiar for the Linacs, and then we supplement that with MR, CT, and other types of imaging via Diacom. We have isocentric and non-isocentric beam delivery. And we have a very simple, straightforward interface. And the very important point from John Adler, we wanted to make something very difficult simple. So you have that little toggle wheel in the middle, you can pick it up and move it out of the way, but all your tools are there. And you're able to then use it like a Gamma Knife for forward planning. We also have planning tools, image fusion, contouring, planning, and finally approval. And that can be dual signature approval. So somebody can plan it and then somebody can sign it off before it goes to treatment. So again, you've got the videos on the right. So if you're familiar with the Gamma Knife, you'll see you can pick up the shot, you can move it around, you can change the collimeter size, and you can instantaneously see what happens. Then we have inverse planning. So to do it simply, you just draw a target, you hit a button, and it will automatically do the plan for you, working on a zero constraint outside of the target. So it's trying to reduce the dose outside the target to as low as possible. And also you can add to that if you want. If you have a critical structure, you can tell it not to put beams through that critical structure. This is a DBH from a treatment plan. So you can then see the quality of your plan, giving you the number of beams and the conformity index and the dose gradient. And hopefully I'll show you later, the dose gradient is really special on this machine. So obviously I'm going to tell you it's wonderful, but there was a benchmarking plan in 2016 done in the UK, specifically in England. They decided to rationalize their radiosurgery and reduce the number of centers doing it, so they were like regional centers. And part of that, if you wanted to be one of those regional centers, you had to do benchmarking plans. So there were 6 benchmark plans sent out to everybody to plan. And then they analyzed the results, looking at the conformity, the dose gradient, and the accuracy. So if we look at case 1, which was the 3 brain mets case, you have the results here on the right, and you're trying to be in that top right-hand corner. So we replanned these plans using the Zap-X, and you can see once we did the Zap-X results, we were in the premium area, the gold standard area with our results. And then if we just look at the plans in detail, you can see these islands of dose for the first, the second, and the third. So you really are protecting the healthy brain. If we then look at the second case, which was a 7 Mets case, a bit more challenging, we can now see actually the manufacturers here, and this is an open paper to see. And you can see that the dreamed triangles are from the Gamma Knife, and you can see they're out on their own. And putting the Zap-X results in, they were right in there in the heart of the Gamma Knife results. And we believe a lot of this, as you go from right to left, the target size gets smaller and smaller. And this is where the energy makes a difference. And the energy makes a difference because of the Compton effect. So by having targets under 8 millimeters, you're still delivering 100% of the dose into the target. Unfortunately, when you get to 6 MV, you're getting 20% scatter. It's just physics. You can't change that with any software. Then, very recently, I don't know if you've seen it, but it was published last month, I think, they actually decided to revisit this. And they sent out the same plans for them to replan. And it's quite interesting to say how the world evolves. And you can really see that they've also added a 14 Met case as well. That the linear accelerators and the CyberKnife have really improved their systems over that period and have actually better conformity than the Zap at the moment. But what they don't have is the actual dose gradient. They haven't really managed to improve the dose gradient. And this is a chart from the paper, and you can see that both the Zap and the Gamma Knife have a really good dose gradient. And with our product, of course, we've got all the innovation that the CyberKnife and the linear accelerators have already put in that we're going to be putting in. So our conformity is only going to improve, and our treatment times are also going to reduce. And talking about that, this is a graph from it. Because everybody looks at the beam on time, maybe they should look at the whole process. And in this map, you can see from start to finish that the Zap and the Gamma Knife are pretty close together. And going forward, we're just going to get shorter. Some of the improvements are, these are coming through the roadmap, is a lot of what we do is actually moving the machine. It's not beam on time. So it's learning how to actually treat faster. Also, we've learned from the initial installations on where collisions are. So as I said at the beginning, the current machine has 260 beams. Our new machine, our new iteration of the machine, because it's just software, will have over 320 beams. So this is going to increase your conformity and your dose gradient. And then this is really showing you from a graphical point of view, with this extended attack, you're now looking at much more angles of attack with the Zap. This is our 3mm collimator that is just finishing clinical trials, and that really has a significant difference if you're doing functional work in protecting the brain, the healthy tissue. You can see here there's a significant advantage, and we are working on the 2mm, as I said. We also have been working on our mask as well, because it needed improvement. So we have a different couch top now and better masks. And this, again, is not to do with the accuracy, it's the delivery time. Because if people move, it stops treating. So if you can immobilize the patient, it makes the treatment much faster. So some other cases that were in there. On the right is the Zap-X, on the left was the best LINAC plans that were submitted to NHS England. And you can see we really have those islands of dose. And then when you look at the actual plots with the equipment, you can see the green triangles of the Gamma Knife and the Zap-X right in that gold standard area. And again, if you just a little bit more detail, and look at the dose gradient here, 2.24. That's pretty good, and we think it's going to get better. So a little bit about us. We were founded, as I said, by John Adler out of Varian, and they're actually still shareholders in the company. But unfortunately, some of you might not be too aware of us, because one of the conditions of sale is we're not allowed to go to Astro, or any oncology meeting as an exhibitor, and we're not allowed to go to physics meetings. So we have to do to meetings like this to do one-to-ones. We hope that will change as we go forward. And we're headquartered in Silicon Valley. These are our installs around the world, and we're now up to 20 systems in clinical use, but we have 55 orders. And what you have to remember, we, unfortunately, in the COVID tragedy, that's when we launched the company. So we literally, at the very start, was when the first system went in. So you can imagine it was a difficult time for a brand new company, but I think we've done very well considering the circumstances. So these are the 18 sites, 20 to be soon, the number of fractions. And again, John Adler learned from his previous experience, we did a lot more testing on this machine before it became a clinical machine. And I challenge you to doing any of our sites. Our reliability is superb. It really is. You're talking single numbers of patients a year having to be replanned their treatment. So it's quite astonishing. And again, this is a picture here because it's very important that our customers are the driver of us going forward. We have a lot of innovation to bring into this machine. And this was at Estro, because we're allowed to attend Estro, but not allowed to be in Estro. So we had a restaurant so we could talk to our users and show them the system. But we do have groups now with our engineers and our customers talking about our system, what they like, what they don't like, and trying to drive it going forward. It's really important to have that relationship with the customers going forward. So I believe that we have a new dedicated intracranial system, a gold standard, and I'm very happy to take some questions. And from this morning, I hope there'll be a few. Thank you.
Thank you, David, for an excellent presentation. Now we have some time for discussion. If any questions or anyone want to have any query? Yes, please, Dr. Lal.
Very nice presentation.
Thank you.
This is actually the second presentation. I saw one last week, in just 1 week. As you probably know, I'm from Apollo Hospital, so we are at the moment installing one in Delhi, and hopefully in November, I think, we should probably have the first patient in India. I just wonder, is it just the 3 MV energy which is limiting from the extracranial sites, or are there some technical challenges as well?
The 3 MV is specifically chosen because it gives you the maximum power without the scatter, and that's how we came at that figure of 3 MV. Because we are a dedicated intracranial machine, and you're now seeing with immunotherapy a lot more those seed-like tumors. And again, you want that ability just to pick them off, and that's what our machine will give you. Because you've got the closer difference as well, you've got the collimation. Really gives us a wonderful dose gradient. And I know from Ian Paddock, he's a famous physicist, I think one of his patients in London with a gamma knife has had an 887 METs treated. If you don't have a system that can protect that healthy brain, that's not reality, and this is what we give you. What we're trying to do is give you a tool that it's a clinical decision whether you treat, not a practical decision. If you think it's worth doing, our machine will do it. That's how I see it.
Yes, please, you can have a question. Yes.
As of now, what is the treatment modality? Is it just the conformal beams, or it's arc?
At the moment, we're like the gamma knife, it's step and shoot with collimators. But as I said, we have a wonderful roadmap. I've probably got a very cheeky slide, actually. I could show it. Oh, they've turned it off. But I have a picture of the Himalayas and Everest and K2 next to it, and I feel the others have got to the top of K2, and we're equal with K2. But we're going to climb to the top of Everest because we've got the cone beam key coming. We've got dynamic treatment. We've got Monte Carlo all coming. And you buy a piece of equipment not for tomorrow. You're going to have it 10 years. And I think we've got a wonderful piece of kit that we can hopefully evolve with our customers.
You were talking about the lower treatment time. So what will be the treatment time like?
It's very similar to gamma knife at the moment, but without the kicker that with 5 years' time, our treatment time for exactly the same thing will be less, but with the gamma knife it will be double. And in my time at Zap, we have now reduced the treatment time by 30%, and the engineers have assured me that it will be down another 50%. And this is in its current format. This is without dynamic treatment, just in the step and shoot, because it's moving more intelligently. As I said, a lot of the treatment time is actually it moving between the shots. So it's learning to do that in a more efficient way.
So regarding the regulatory requirement, I think this is totally a new machine without a bunker. So how is it in different countries? When you install
so far, again, touch wood, we've had no problem. And we've really done some challenging places, if you think about it. Germany, Switzerland, and Japan. And it's amazing. The one we recently did in Spain was quite hilarious, really. We had 16 experts come from the national organisation because everybody just wanted to see a bunkerless machine from a physics point of view. They couldn't believe it. But again, the one in Switzerland, they're much more physics-led there, and you wouldn't believe the number of TLDs they had around the room at the beginning, just to make sure everything was okay. And now it's literally back to the operator. They're so convinced that it's just not an issue. It's an extremely solid piece of kit. Well, it weighs 27 tons, so it has to be quite solid.
Excellent overview you have given. Few quick questions. One is about the record and verification.
Sorry?
The treatment record and verification.
Yeah. Again, this is roadmap. At the moment, it's quite simple. But in the next version, we will be able to connect with ARIA and Mosaic. Again, we already have wonderful capability with Diacom. So a lot of centers, especially if we sell a Zap into a larger center, they've already got their contouring tools. Why get another one? So they can do their contouring in their existing tool they're very happy with and just export it to us. And we can then do the treatment planning. Or even better, you could export it to us and export to something else they've got and then compare the two and see, do you want to put it on the Zap or something else? Because again, you know, the Linacs are still really good machines and they've improved immensely. Their treatment times we're never going to compete with. So in clinical cases, it could be sensible to go to the Linac or it could be sensible to go to the Zap.
Generating the 3 MV beam, any failures in the generator or anything you have experienced?
It's just, again, it's an advantage with being at 3 MV as well. From an engineering point of view, it's working less hard. So again, I think it really improves our reliability as well. And I don't think we're going to change that. It is the perfect energy to do what we need to do intracranially. We go down to C7, I didn't mention that.
No, I'm not, the question is not towards increasing the MV beam. Any failures in the generator part?
Not yet.
You experience any time?
No.
Okay, thank you.
No, as I said, you know, the reliability has been quite astonishing. But again, don't take my word for it, just call somebody that's got it. Obviously, with our first system, I think we had some issues, but the ones that we've had in Europe, because that's the ones I'm really familiar with, it's been wonderful reliability.
And last question, how deep you need to go into the pit? Because there must be the ring gantry. It's almost like how deep you go down for an installation.
For installation, I think it's about 2 meters into the ground. The one I showed you from Japan is on the first story, so they had to actually put an artificial floor in to take it. So that's why there were steps in there, because it's a little bit more awkward. But yeah, we would hope. But again, you know, we just put a machine into Paris, which is a wonderful installation in Saint-Pitier. But unfortunately, it's a bunker that was in a Linac, and that's really not the idea. And we know that space is a problem in cities, but if you really can put it outside in the daylight, you know, just come and see patients being treated. It's a total different feeling for them, because you don't get set up and then everybody leaves the room. You know, it's light, airy, it's psychologically very different. And it's something we didn't really pick up at Zap until we kept getting that feedback that, you know, for small children, if you've got their mum and dad sitting on a couch, it really relaxes them. Maybe you don't need to do anesthesia or things like that.
Any more questions?
David, may I just have one, sir? So David, you were earlier with Electra, now you are with Zap. I think as far as the radiosurgery is concerned, you have seen the best of both the worlds. And you are still striving to make your sniper shot still more accurate. I'm closely looking and wishing that you get a 3 millimeter collimator and then it becomes more and more accurate. But as far as your new study which you quoted about, that's a benchmark study, updated one from the 2016, only the half of the results are presented. I still agree that your Linac has become much more accurate than 2016 when we had the first benchmark study in the UK. But still the 12 gray and the extracranial dose
absolutely,
is
but that's
still
more
best
the dose gradient as well, I think.
That's still best with the gamma knife. Rest of the parameters are trying to reach up to that gold standard. Is still trying to reach that. But the 12 gray and the safety parameter, that's still with the gamma knife, that remains the best.
I agree with you totally, and I think more and more people are really coming round to the 12 gray volume being very important. I saw a paper recently between Accuray and Avarian Linac, you know, so both Zap and Gamma Knife weren't involved. They're showing really that the importance of the 12 gray volume is getting, you know, imperative that you reduce it.
Hi David, nice talk, enjoyed it. So my question is for the frameless application, which is the default as of right now.
It is.
What is your imaging interval for a patient who's moving? How frequently can you image?
You set it. It's 5 seconds to 15 seconds. But you can decide that in the system.
So actually every 5 seconds you could
Every
image.
5 seconds it's taking an image, yeah. But again, you know, our roadmap is to have cone beam CD eventually as well. Because you imagine, it's always moving anyway, so you're just really taking advantage of that.
So I think, you know, and discussion of the paper for 2023, I think it's acknowledged the way that the paper is written that those cases are clinical cases that were treated at NHS centers. The Zap-X plans were actually done theoretically, and they're done by the company and not by actually a clinical center.
That is very true, but the time we did it, we couldn't really do that. But I decided to wait until we had the new version, and I am going to do it the way you said, because if we do it now, in a very short time, we're going to change that. It's much better if we do it for the next situation where we've got many more angles of attack, and therefore we'll have even better results. So if you wouldn't mind, we just wait a little bit longer and we will do that. But when I did it originally, I had no other way of doing it, because I wanted to show how well we were at performing, because we had no other way of doing it. But now we will have customers who can replicate that.
Yeah, so I definitely think that clinical plans are going to be key. I mean, we see these theoretical papers come out. There's a comparison paper of a LINAC-based radiosurgery with 26 VMAT arcs showing that it has a better conformality and gradient index than a Gamma Knife plan.
Yeah.
That's not something that anybody would clinically actually treat itself.
We see all that a lot of the time. But what I say is, if people are in doubt, we say to them, give us one of your most difficult cases and we'll replan it for you. And then you can see how the Zap-X performs. And we now have a library of those plans. So if you go on the Zap-X website, you can see a large variation of plans we've done showing you the performance of the system. So you have to register, but if you register, you can look at how we treat AVMs, trigeminal. There's a library of plans there. But what I did was, I did it now because I want you to see when we have the next iteration. We will replan all of those plans, and it will show you the difference between our first version and the second version and how well we've improved, and hopefully entice you to thinking they're only going to get better.
I think we close this session now. Thank you, Mr. David.
Thank you.
Thank you, sir, for the very informative session. Now we move to the next session, that is the Satellite Symposium of Robotic Radiosurgery. The moderators for this session are Dr. Bhujan Sade, Consultant Radiation Oncologist, Ruby Hall Clinic, Pune, Maharashtra. I welcome you, sir. And Professor V.P. Singh, Neurosurgeon, Chairman, Institute of Neurosciences, Vedanta Medicity, Gurugram, New Delhi. I welcome you, sir. I request the moderators to please introduce the speakers of this session.
Thank you. So we just changed the gears from Zap to CyberKnife and from neoplastic to non-neoplastic indications of radiosurgery. So I would like to call upon Dr. Shankar Vangipuram. He's a senior consultant from Apollo Institute, Apollo Cancer Center, Chennai. Dr. Shankar, oh, he's here.
Yeah, thanks. So how do I scroll? How do I scroll? Okay, so okay, thank you. So over the next 20 minutes, what we'll be doing is thinking more about the functional indications of the brain that we commonly practice in our clinic. Before I go into the depth of it, I would like to set the stage by drawing your attention to a adage from WashU neurosurgeon Ernest Sanchez, who felt in 1949 that much of the lesions would be successfully, if not removed, could be very well be treated by some sort of destruction. And to enable this particular treatment, there are several commercial delivery platforms which are available in the marketplace to play the games of sub-millimeter accuracy and precision, which includes the Gamma Knife, photons, and protons. So I had chance to work on almost all the systems that I mentioned, but just I want to draw your attention that protons are never used in the functional radiosurgery, despite the advantage the Bragg peak gives. That is actually offset by the lateral penumbra and the beam range estimation uncertainties. Now, we have actually transitioned from the technologies, frame-based technologies to frameless technologies, as you can see, and every technology has its own pros and cons. We need to really appreciate where one particular technology can be used in the best possible clinical situation. So I'm very lucky to have practiced on all the frameless technologies. And the secondary collimators that we use in all these patients include the stereotactic cones and the MLCs. Now, when we were thinking about MLCs in clinical practice, we were kind of worried, can we really use MLCs? Okay, what I'm speaking is micro MLC, not the regular MLC, micro MLCs of 2 millimeters dimensions. So when I was discussing way back in 2004, we were first trying to evaluate the leaf positioning accuracy and the penumbra, and we found it is very much comparable to what you get from cones. The next homework which we did is compare the immobilization, different immobilization gadgets which were available with us, which includes for the frameless tools. And we found that the positioning errors was almost less than 1 centimeter. So with this basic understanding, we jumped into practicing functional radiosurgery. We are hitting the targets properly. So again, we have treated a range of indications across neuralgias, epilepsies, and tremors. Psychoradiosurgery I haven't really started yet, but I'm planning to. So out of thousands of cases, we have done majority of the functional radiosurgeries that we have practiced are neuralgias, and around the first 5 years, starting 2004, we have done probably on LINAC with micro MLC, and 101 probably LINAC with cones, and nearly 133 on CyberKnife. And majority of these cases were TG, and around 268 we started the first case 19 years back, and 5 cluster headaches and 6 glossopharyngeal neuralgias. We have a good number of papers and research articles in this particular area as well. So our basic selection criteria initially was around any patient more than 60 years with medical comorbidities. All of us know the target is situated in the prepontine cisternal component, and typically I use around 81 to 85 gray. I don't rush to push 90 gray because there is enough evidence where bothersome dissesthesia and permanent dysfunction increases. All of us really do know that early SRS is something which is associated with much faster, better, and longer pain relief when compared to late SRS. And as I said earlier, our target typically is distal or proximal, that Marshall point or OR point. So all the patients, typically we do imaging, which is standard. In addition to this, in post-op setting, we do CT cysternography and trigeminal tractography to understand the anatomy of the nerve fibers in a much better way. And we have actually found this much more, cysternography much more useful in post-MVD settings where MRI is really contraindicated, and whenever we are treating lesions like close to left pontine cavernomas. So when we shoot around 80-85 gray, what really happens on the nerve? That is something which was quite intriguing for me since last couple of decades. So interestingly, this was a very good paper which has come from Pittsburgh group in 2010, wherein, you know, with a dose of 80 gray, there is actually a histologic evidence of partial collapse of myelin sheath and some vacuolation in the mitochondria. And this is a study done on the rhesus monkey. Well, around 100 gray, yes, there is a noticeable structural derangement which is happening. So this is something which was, you know, which is a histopathology, a histological evidence you look into. But what we thought is, let us just analyze what happens in the first 3 months. So we have done serial MRI scans of all these patients whom we have treated 80 gray. And as you can see here, the first scan was done after 72 hours, 1 week, 1 month, and 3 months. What you could see there is some focal enhancement immediately at 72 hours. At 1 week, there was some amount of brainstem edema and enhancement you could see at 1 month and 3 months. So we are pretty sure that at 3 months we are getting some enhancement. So that begs the question, how accurate our system is treating. So we have actually fused the post-contrast MR with the initial MR and calculated the variations in the Euclidean space. And this was precisely subcentimetric and very much clinically acceptable. This has actually increased our confidence that even a Linac-based system is much better in getting the driving the points rightly. Now, the third important thing which we were kind of always worried about is the motion. Now, we have actually analyzed the motion of the frame which is used, the extension support system that we have used. I would like to draw your attention to the leftmost part. There is a small subtle motion which is happening in that particular. These are actually the intrafraction cone beam CT images which are kind of seam looped. And that subtle motion is happening more because of the swallowing motion, which is normal. You know, you swallow at least 3 to 4 times a minute. Now we are wondering what is the impact of that particular sub-millimeter motion which you are seeing because of swallowing on the extension board which is being used from the frameless unit. So we deformed our planning system plans from the treatment planning system to the cone beam CT after applying the electron density corrections, and we could see that not much variation was there with regards to the doses to the brainstem, and it was precisely the same. So this was interestingly the time when we have seen a paper from Rupesh Kotecha group where a higher dose rate gamma knife has actually given better rates with regards to the longer lasting outcomes. Now this was somewhere in 2014, 14 or 15, yeah, I remember. So that was the time when FFF came into the picture, and we started looking into we did a dosimetric study comparing FFF versus the flat and flat beams. We found it pretty compatible, but the only great thing that I have seen is the time which has decreased from 28 to just 12 minutes. Sorry, yeah. Okay, so again, as I said, we have seen, because I've used the different technologies there, Linac-based, flat plus MLC, the response lag time was around 3 months. With flat cones, it was around 1.5 months. With unflat and cones, 1 day to 2 weeks. Now, this is really something which is surprising. This is something correlating with what Rupesh has done in gamma knife, you know, what observation they have done. So we actually looked into the other side of it, where sorry about it. Oh, sorry, it's just scrolling. What's happening? Can you use the mouse for scrolling? I'm sorry, yeah. So we have looked into the response lag time of different technologies that we are using. What I found is using a FFF beam has actually given us a better pain relief as compared to a newer source, the gamma knife. And we next wondered what could be the reason for this. You know, there is something which is different which is happening right there. I'm sorry, what is happening? Okay, let me go back. Yeah, this is something which has actually, yeah, now I got it. Okay, so we were wondering how accurate our shots are. So every neurosurgeon agrees with me that brain actually shows some motion. So we have actually done equiplanar phase-based amplified cine MRI, and you can see that a lot of motion is there in the central brain. And that is something which is really relevant for us because this particular paper has actually given us impetus because trigeminal neuralgia is a disease of elderly, and where you see atrophy of the brain, and therefore the prepontine space actually enlarges. So this small subtle motion actually gets accentuated. Now when you are doing the treatment, for say around 30 minutes, your targeting accuracy is much more superior compared to what you're getting with a treatment of older gamma source, older cobalt source. So probably this could be one of the reasons why we could see the difference. The other important thing which we actually do for all our patients includes the trigeminal tactography, the diffusion signatures, extracts the FA-RD-MD values, and what we realized is once the FA drop happens significantly, around 30%, they have a very good long-term control rate. So this particular parameter, it's a default imaging parameter in our institute, and all the patients, we are pretty comfortable with this particular thing because as I said, the FA, this is actually, we have done in a very large number of patients, nearly around 65, 70 patients. We have a median follow-up of around 8 years with this particular value. And we have seen how the pain outcomes are okay. So the other important thing which I use this diffusion signatures includes whenever we are doing radiosurgery, you can actually differentiate at which point you need to place the shots, and that gives us greater confidence with regards to the doses which are getting pushed. We need to think beyond the neurovascular conflict about the central trigeminal pain pathway because sometimes patients do really fail. Now when they fail, we need to understand before we do this patients, the imaging, it's always better to do the imaging even in the pons, trigeminal lemniscus and thalamus using voxel-based morphometry and see if there are any FA changes happening here, as these patients are getting adapted because of longer duration of treatment. So therefore, understanding the brain plastic changes also would make sense. This happens even in the white matter plasticity, which are concerned with pain perception, modulation and motor function. So this actually could respond to this particular imaging parameters could probably explain that why radiosurgery, early radiosurgery would give a better outcome compared to what you are seeing with late radiosurgery because the brain plastic changes really take a hit there. We have done some interesting cases of Moog antibody where there is T2 hyperintensity in the pons. We thought initially as herpes simplex, herpes zoster. Again, as I said, this patient was negative for this, and we have done Moog antibody positive, and the patient was actually put on rituximab in the follow-up. We have done few patients of bilateral trigeminal neuralgia. This is one of a patient who had a complex kyphoscoliosis. And this was a big challenge for me because this patient actually came from a gamma knife center. They couldn't do it. CyberKnife, we have a problem because the safety zones get compromised. So finally, we have done it on a LINAC using simple head and neck immobilization. This was pretty challenging case for us. We really enjoyed this. If you ask me, out of this 268, this is one patient which I could really never ever forget, and this patient is doing absolutely fine. We have done hemifacial spasms with TG, and you can see we have done dual targeting of the VCO bundle and the breast. Very good result, glossopharyngeal neuralgias as well. As I said, these are the patients who have consulted multiple neurosurgeons, and they were reluctant to undergo any surgery, and we have done in nearly around 6 to 7 glossopharyngeal neuralgias. And we had some fantastic result as what you see. And we have done for cluster headache as well. And of course, trigeminal schwannomas, the secondary neuralgias, all those are pretty common which are seen. So of course, this comes into TAC, and we have seen in TAC also some good results. We are planning to initiate a study because neuralgic pain is always associated with depression and insomnia, which increases the limbic activity, and therefore we look at the several neurochemical correlates. I'm writing this paper, hopefully I should be able to complete it. So interestingly, with the available evidence, our cumulative pain control rate was around 84%, and dysesthesia hypoesthesia rate was something around 17%, and we are pretty happy with all the technologies that we are using. in short, thank you so very much for your patient listening.
Excellent presentation. May I invite some questions from the audience?
Yeah, table.
Excellent, Shankar. Nothing else expected from you. So my comment is, you said early radiosurgery is better than late radiosurgery for trigeminal. No, early MVD is better than late MVD.
I definitely
early
do
RFA
accept.
is better than late RFA for trigeminals. That's true of the disease.
I
any
definitely
virgin
agree. Any early intervention is better.
is better than late intervention.
Exactly. I do agree.
that
I
does
agree
not-
for that.
no, that does not
In fact,
mean-
I was suggesting the neurologist, if you want to refer it before
that
this
doesn't mean
period,
that
before
SRS
plastic
has
changes
to be
kick
the
off.
way,
Yeah.
yeah.
That is what I
That
was
should
telling.
be,
Yeah.
Yeah, excellent talk. See now, two things. Like if you talk about trigeminal neuralgia, 1 year pain control rate is around say 70-80%. But if you 3 years or 5 years, it is around 20-25%.
That is not my experience. Unfortunately, that is not my experience.
Experiences like that, what I understand.
Oh.
So now how you explain that? That is one. Second is,
We are getting around see, basically the kind of series which have been practicing for the last 19 years. When I came back from Pittsburgh after the fellowship, it was in 2004, I have actually given doses between 65 to 70 gray. Right, that was my learning curve because I was I've seen everything in gamma knife. Suddenly I'm having a gadget which is having the potential to deliver. But again, I was not confident because my team was not confident. So at that time I have seen some results which are getting skewed, right, because of underdose. That was way back in 2003 and 4. But once I have got the confidence after we did all the homework and treating around 20-25 cases, we escalated it directly to 80 gray. I have gone up to 86 gray in all the patients, and in fact the longest follow-up I have is 19 years and treated on LINAC.
Another,
And pain-free. And pain-free.
Yeah, Manju, another thing.
17%, and that is good prognosis.
Throughout the world in trigeminal, they are reducing the dose.
It gets more when you deliver more than 90 gray.
Earlier it was 80 gray. Now I think people are thinking that only maybe 40 gray marginal dose also should be sufficient if you are prescribing a 60-60% isodose.
But this is what is internationally practiced, and we are pretty happy with it.
So the prescribed dose is 70 to 90 gray. So we are not going below 70 gray. That's in the study which you have shown on from the Lunsford group, which showed the autopsy specimen and all those. So below 70, it doesn't have any effect.
Yeah.
A disease where you are bargaining with your sensory complications.
Exactly.
And then you have to bargain with the patient with that technology also. So it's whichever is the technique, LINAC versus gamma knife versus whatever it is, the pain control is nearly the same, but the sensory complications are more in the LINAC based ones. So the sensory hypoesthesia, dysesthesia, but most of the times patient remembers that earlier pain and then he says that, okay, this is the numbness, I bargain it, I am okay with this numbness, my pain shouldn't be there. But as far as the long-term pain control is concerned, Sir Chief, the moment in the natural history of the disease when you are targeting the nerve, that makes a huge difference to the patient.
Exactly.
If you are treating it before it being labeled a medically refractory disease within 2 years of its onset, the results are definitely good. And then,
but it's definitely not 20%.
The long term? Chief, by the 5 years, nearly 40 to 50% patients have to escalate their drugs. So they do not remain a BNI 1 or 2. They fall into the category of the BNI 3, which we want to avoid. And overall, once they are in BNI 3, their Tegretol hits 600, 800, carbamazepine, then they start getting the drug-related complications, and then you again hit it. There are groups which have targeted 3 times, 4 times, so they make it an over-the-counter treatment like the pain John ad, that you get a pain, you come again, we give a second round of the radiosurgery or the third round of the radiosurgery. I do not think that we are doing a justice to the natural history of the disease in that way. When we have a gold standard method in which very safely we can treat the patient with an MVD and making a patient in BNI 1, That's the aim actually. The aim is not to make a BNI 3. The aim is to make a BNI 1 with a long-term pain relief, and then we should talk in the decades because the patient has to live with that pain.
We'll discuss
So-
on this later on. I think the other
So not for
speakers
2 or
will-
3 years. I think we should.
Thank you, Shankar, for your presentation. We now move on to the second talk on CyberKnife and management of recurrent gliomas. And we have Dr. Sridhar Sushila talking about this.
Thank you. At the outset, I really congratulate Datta and Shruti and ISRS for a wonderful conference and to share my experience. So we had a benign tumors, functional radiosurgery. So now moving on to malignant, especially the real indications, what we have seen in SRS, SRT is recurrent malignant tumors. I'm going to talk about 15 minutes. So classically we know that it's the management-wise investigations like role of imaging and biology of biopsy and genomics, and treatment-wise we know that surgery, radiotherapy and chemotherapy and targeted therapy. So we're going to touch upon those things. And radiation, what is the current evidence and where we stand, and our experience with CyberKnife. So recurrent gliomas, when you see that over a period of time, say we know that 12 to 14 months is the standard response rate in case of GBM, and eventually every patient is going to recur over a period of time. That is what the literature says. It may be local, or it may be marginal or regional, or it may be in a new lesion which is coming up in a different place. There is no standard of care for recurrent gliomas as for now. So it's actually the options what we have is the surgery, the total versus the subtotal excision, and we know that it has an high morbidity. Chemotherapy wise, we have the alkylating agents, irinotecan, bevacizumab, and now immunotherapy is also pitching into the places. Radiotherapy conventionally, in terms of radiotherapy is concerned, we have conventional radiation, hyperfractionation, and the SRS or SRT. Best supportive care should not be forgotten at any time, so we have to make sure that is to be there. Overall survival, whatever we have done, we have seen only 6 to 12 months even after re-irradiation. So re-irradiation in recurrent gliomas, specifically what all the points we should remember is optimal patient selection. That is one of the key factors what we are looking at. And technique of treatment, hyperfractionation versus the conventional, and the dose and the fractionation schedule what we want to use. Normal tissue tolerance, this is what always debated. We always cared about the necrotic part, in terms of margins and the central. What are the types of chemotherapy or biologicals also have a major role in this? Oncological outcomes, yes, it makes a difference. We are still stick up with 12 maximum of 8 to 12 months of survival. In the toxicity wise, the treatment related toxicities of necrosis and short term and long term complications of neurocognitive functions. Functional aspects also has to be kept in mind. So in terms of re-irradiation settings, we have all the gadgets, we have gamma knife to protons. So all the things can be used. I've used all the things except for the protons. The CyberKnife, I don't know, there's a small video. I think you all know about that. I don't want to go into this. So actually this is one of the articles we come across. Whenever we talk about recurrent gliomas, I'm talking about the challenges with high-grade gliomas, that is especially with GBMs. So current status and recent advances. So in terms of fractionation is concerned, if you see there is a meta-analysis, if you see in terms of stereotactic radiosurgery is concerned, the dose, the volume and the dose is important. So the dose is in the range of, usually it's around 15 to 18 gray single fractions. And some people have gone up to 20 gray single fraction also. And the volumes is in the range of around 4 to 10 cc, or it may be more than that. And the volume of the diseases increases, especially if there is a huge recurrences. But survival, if the median survival when you're seeing, so it's in the range of 6 to 12 months, it is not increased by any means. And same with the case of hyperfractionation. So on a LINAC based, the dose usually is between 25 to 35 gray. People have gone up to 40 gray. Usually I range between 30 to 35 gray. If the volume of the disease is more, I usually use for 5 fractions, 25 in 5 fractions. And the ear, especially with the CyberKnife, the volume can be, even if they increase in the volume, we can use. And this, in terms of survival, it is reached maximum of 12 to 14 months, not much of a difference, even with the help of the bevacizumab standard treatment of temozolomide or the anaticon or with the addition of bevacizumab. Conventional fractionation, anything less than 35 is actually has not shown a benefit. 41 gray should be the ideal one. Modification in terms of 15 to 18 fractions in 35 is the one actually everybody recommends. And what makes a difference in case of the CyberKnife or the other one, the margins. A lot of places we are given a margin of 2 to 5 millimeters. So probably the dose escalation is one of the areas where we can still look at in case of the CyberKnife. So our experience is almost around 14.5 years. We have done around 5,000 odd cases. So my contribution is around 3,200 cases. So 60 skull, we have around 2,000, and majority of the things is brain, the gliomas, and the metastasis. So how we do is, yes, there is no shortcut. The neurocognitive and brain lab functions before the patient is starting the re-radiation of any of the brain cases. That's important. And biopsy, immunohistochemistry, and genomics, especially if there is a possibility of going for a second biopsy in these cases, will definitely helpful. We routinely do DOPA PET CT scan and the MRI for radiotherapy planning, and functional brain functional scans as and when required. So MDT is essential in these cases, and follow-up is necessary. So we have around 87 cases for the past 14.5 years. So the median age is around 40 years, age range from 6 to 84 years. Infield recurrences is actually around 78 cases, and low grade is around 6, high grade is 76, and brainstem is around 5. So especially these are one of the prognostic factor. Age is one of the good prognostic factor, and the grade of the tumor, and the performance status, and the duration between the disease-free interval from the first to second recurrence. So around 42 patients were analyzed, and median time of recurrence is around 22 months. Median survival is around 18 months, which is usually like what we saw is around only 12 to 14 months. So we are able to achieve around 18 months. So 2-year survival is around 61%, and 3 years is around 25%. So this is the Kaplan-Meier curve. And number of patients, what we have in our series actually primarily initially dose escalated. So for GBMs and high-grade gliomas, we already studied, we have already published our, we have presented our data with simultaneous integrated boost with CK, with CyberKnife boost. We have achieved around 28 months of median survival. In those patients, when you are seeing the primary dose, disease-free interval is around 24 months. The primary conventional dose radiation, when we have done, it's around 20 months. So in 11 patients. So let me show some of our patients. This is one of the patients presented in 2013 with weakness and diagnosed to have a brainstem glioma. We always encourage to get a biopsy, but as usual, they usually, considering all the points, they refuse. We have done the methionine PET scan and the MRI-based radiation. Usually, the dose escalation with SIB followed by CyberKnife boost. So usually the BED reached around 85 to 90 grays. And this is you can see the plan. So all the three, the 30% dose is the outermost. This is on follow-up. This is I'm sure that this is what you see in your practice as well. So you can see the central necrosis over a period of time, and patient is followed up. And after 3 years, actually it developed one more tumor, and it is the biopsy was done. It turned out to be an high-grade glioma, the anaplastic astrocytoma, which is treated with same protocol in the other side after 3 years. And the patient was added on temozolomide continuously. Along with that, patient developed the edema and the necrosis, which is 100 milligram bevacizumab added, and is on a serial follow-up. So this is the DOPA PET scan and the DOPA PET scan also, and the MRI. You can see that there is decrease in both the activities. And these patients definitely has to be followed up. You can always have a probably treatment-related sequelae, and this has to be accepted versus the survival. and he has a speech disturbance also. Usually at the end of after 3 years, you can start seeing the calcification. The moment if you see calcification, definitely there is a dystrophic calcification. The chances of disease recurrence is less. So another patient of like brainstem glioma in a kid. So there is a huge brainstem glioma. Same protocol is followed, and after 3 years, actually he has developed a recurrence in the same site, and which is treated with CyberKnife alone. And the chemotherapy was started, but after 4 months, actually he has a extensive metastasis, dural metastasis, and succumbed to the disease. So another recurrent glioma which is treated outside, recurrent GBM, and within 4 to 5 months itself, he had a massive recurrence, which is the Doppler PET scan showing the activity, with and which is treated with CyberKnife 5 fractions. That is around, this is one of the patients where I gave 7 into 5, 35 gray in 5 fractions, and the serial scans which shows the almost metabolically complete response with treatment related changes. This is what I was talking about. The calcification which occurs is definitely a good indicator that the disease is not there, which is followed up, and this was also added with the bevacizumab to decrease the treatment related necrosis, which is one of the desired effect according to me, as long as it is within the area of treatment. And these are the post-treatment changes. He developed the sequelae as well. You can see that calcification. This is where actually the neurological deficit starts increasing. And the thought process is that can we include, since it's almost around 8 years, we tried all the factors, and actually mesenchymal cells also tried in this case. But unfortunately, he died in 2021 because of the COVID. So another brainstem glioma treated outside, he came to us after 2 years with local recurrence and also the dural metastasis. We treated with 5 fractions. This is the planning. And both the areas were treated for 5, like he survived for around 7 months, but like developed dural metastasis, extensive dural metastasis. So we routinely use, so the re-radiation of the re-radiation for brainstem glioma, we had around 7 cases, which is published. Now almost around 13 we had to revise. On this basis, actually, the PubMed gave subject expert in radiation oncology as one of the certificate to add on. So we use routinely the bevacizumab even the moment after the SBRT is done, so along with the temozolomide on the 6th day. So this is a small paper which is accepted. We are going to present in this ESMO in Milan. So to conclude, CyberKnife re-radiation is effective and safe, and DOPA, PET scan and MRI based planning probably helps in defining your targets easily. The addition of the chemotherapy and bevacizumab, even at the low dose of 100 milligram, definitely makes a difference. Follow-up is important because there is definitely a sequelae which is maybe involved as the patient starts surviving for more. I appreciate your patience hearing.
Thank you, Sridhar. Any questions? So at what stage would you give the CyberKnife for the brainstem? I mean, not for the brainstem, but supratentorial. Like the case you showed, would you ask for a surgical decompression before you give it, or
yes.
Would you just give it straight away?
No, the surgical decompression is definitely, we have a neurosurgery team also, so if we always take the opinion from the neurosurgeons. If the patient agrees for surgery, we always consider for surgery. The considering for surgery is very important now, especially the newer molecular markers and all coming, we always ask for surgical opinion.
I have a question, like when you have a recurrence at a marginal recurrence, it's an infield recurrence, you have a volume which is very conservative. But when you have a liberty of going little, because that area is not really treated with the prescription acidosis, so do we take a little liberal approach, or you still conserve your volume to the area of enhancing disease only?
See, the moment if it is a marginal recurrence, like you are still thinking that there is one more marginal recurrence occurs. First of all, with the margins, what you are talking about, 2 centimeter margins, in that the recurrence has occurred. I always take it. So if it is 100% isodose, I prefer to still, the moment if it is recurred, I prefer to go ahead and treat only with the like tight margins. So these actually the recurrent settings, if you go and check it out, actually the pattern of recurrences even in this is, it becomes like you can always go for, probably in going forward, you don't have to go for a full 1 centimeter, 2 centimeter margin. So 5 fractions, like you can, even in GBM, you can give 5 fractions and add on the other modes of treatment rather than waiting for 5 weeks of treatment. Thank you.
With that, we end this session. Thank you for the speakers for the nice session.
Thank you, sir, for the very informative talk. Now we move to the plenary lecture 2, radiosurgery of cavernous sinus tumors. The moderators of this session are Dr. Ramesh Shivaramakrishnan, Professor, Department of Neurosurgery, Jubilee Medical Mission, Medical College and Research Center, Thrissur, Kerala, and Professor Selçuk Peker, Chief of Gamma Knife Radiosurgery, Koç University of Medicine, Istanbul, Turkey. I welcome you both to the stage and to please introduce the speaker of this session. Thank you.
Thank you. So now we are beginning our plenary session, plenary lecture 2. And our speaker in this lecture will be Dr. Cherno. I think no one needs to he doesn't need something to say about him because all of us know him. He is the chair of Educational Committee of ISRS, and now he is working in Tokyo Women's Medical University as an assistant professor. And his lecture will be about radiosurgery of cavernous sinus tumors. Please, Dr. Cherno.
Thank you very much, Professor Peker, for this kind introduction. And usually at the beginning of all my presentations, I'm showing this slide just to demonstrate where I'm from. So I came here from Tokyo via Vietnam. And so it's the same, nearly the same distances from the capital of Japan to my native St. Petersburg. Once again, I pretty much appreciate all efforts which are done by local organizers with this course. And so definitely the efforts will result in success of this event. Speaking about radiosurgery of cavernous sinus, of course, we should consider that it's extremely complex anatomical structure with a lot of cranial nerves, vessels, and neuronal tissue, which is extremely functionally important. And this, of course, complicates any treatment of the lesions located in this area. Another thing which complicates, for example, treatment of tumors is that great variety from the pathological point of view and also from the point of view of the grading, maybe benign lesions, low-grade malignancy and high-grade malignancy, and also non-neoplastic masses which actually behave in an aggressive way. Another thing that these tumors can have different patterns of growth, either it's inside the cell in cavernous sinus, or with some expandable growth as in the middle, or highly invasive growth as in the left side. So all these parameters and characteristics should be taken into consideration when we are trying to treat these patients. Surgery of cavernous sinus tumors is definitely possible, and it was established a long time ago, and Laleham Sekhar, who is famous neurosurgeon of his time, probably of Indian origin, who used to work in US, he published one of the first series of surgery for cavernous sinus tumors in 1986, with total removal of 86%, with improvement of pre-existing cranial nerve deficit of 43% of patients and zero mortality. Considering that it was done more than 40 years ago, it's really brilliant results. But later on, the Almefti, Franco De Monte at this time used to work together with Sam Almefti. They published their series dedicated specifically for meningiomas, and the results were a little bit worse. The total removal was 76%. Improvement of pre-existing cranial nerve deficit was only in 14% of patients, and there was 7% mortality rate in the hands of Almefti. You can say that this old series, okay, look on the series published by Gozal as the first author, but this series from William Caldwell Clinic, published in 2019. In all the cases of meningiomas, they did only subtotal removal. Of course, it was intentional. Ideal radiation was needed in 50% of cases. Improvement of pre-existing cranial nerve deficit was found in 52% of cases, with great variety among different nerves, from 0 to 81%. And in each fifth patient had new cranial neuropathy, and half of these patients had permanent neuropathy. 12% recurrence. Other morbidity was in 12% of patients, and recurrence rate in 10% of patients. And if we're speaking about pituitary adenomas with the invasion of cavernous sinus, so from the University of Tokyo, in 2 series, they had postoperative neuropathy in 27 to 50% of cases. In the majority of these patients, I should, of course, accept it. It was temporary neuropathy, but still it was a complication of the surgery. Of course, we have now alternative modalities, radiosurgery, which by itself did a great progress from the beginning of this of routine application of this technique in 1968 up to this time. And now we have not only advanced gamma knife unit, but different variability of great variability of radiosurgical modalities. My own experience is limited to gamma knife, but we have now linear accelerators, CyberKnife, proton beam, gyroscopic radiosurgery, and Navalis. And if we are speaking about lesional pathology, in my personal opinion, the results of, for example, control of tumors, intracranial tumors, using with all these modalities are more or less the same. Of course, treatment planning is different. There are different gradient indexes, different radiation of the surrounding structures, surrounding brain, which can result in different rate of complications. But from the point of view of tumor control, practically all of these modalities provide similar results. When we started to use at first with Model C gamma knife unit with automatic positioning system, we developed this concept which called as robotic gamma knife microradiosurgery. It is based on the same principles as microsurgery when we are attacking the target and with maximum preservation of the surrounding tissues. For this purpose, we use high resolution MRI. We always use fusion of MRI with bone CT. For avoidance of mislocalization errors, in particular on MRI, and also for simultaneous visualization of osseous and soft tissues on one display. We create a conformal and selective dose plan with multi-isocenter techniques. We put special attention on the homogeneous high dose distribution within the lesion. Of course, according to definition, gamma knife provides non-homogeneous treatment, but we're trying to put wide 80% is a dose area within the lesion. And also, of course, we control for radiation of adjacent structures within the recommended safe dose ranges. So this is the sequence which we like very much for MRI. It's called constructive interference and steady state imaging. It's one variant of T2 heavy images. Fiesta is another variant. So, but we always added gadolinium to this. So on the left side is this image without gadolinium, on the right side with gadolinium. You can see incorporation of gadolinium and the tumor increased signal. And so it became much better for visualization of surrounding structures. This is an example of, on the top there is contrast enhanced T1 weighted MRI, and the bottom 3 images are shown contrast enhanced CIS images. And of course, contrast enhanced T1 weighted MRI can be still useful, but it provides, from our experience, much wider lesion enhancement, and contrast enhanced CIS provides better opportunity for delineation of structures within the cavernous sinus. So we believe that for selective treatment it's much better. These just examples of MRI, so we can see now very well anatomy of cavernous sinus and also fusion of MRI and CT. This is typical dose planning, how we do it, how we're doing it with multiple isocenters located within the lesion, which results in a very small area of radiation of surrounding structures. This is our safe dose range. It may be variable from one clinic to another. In particular, for cranial nerves within the lateral wall of the cavernous sinus, we're trying to use not more than 20 gray. We know that they can tolerate even higher doses of radiation, but still we're trying to restrict it. For optic pathways, different cutoffs were suggested. We use 10 gray at present. So our results were published before. We analyzed 120 cases of benign tumors, meningiomas, pituitary adenomas, hemangiomas, schwannomas. Mean marginal dose was nearly 16 gray, but it was a little bit higher than usually because we included some patients with hormone-secreting pituitary adenomas in this series, so these patients required a little bit higher dose. So within the follow-up, mean follow-up of 47 months, we had tumor growth control of 98% among all these tumors overall. And in quarter of patients, we had more than 50% shrinkage of the tumor, which can be considered clinically significant. And morbidity rate was 7%, but in only one patient, we saw major morbidity. I will tell a few minutes later about this patient. So our experience at that time with cavernous sinus meningiomas was not just 19 cases in this series. Had 19 patients with cavernous sinus meningiomas were included in this series. And we had 100% tumor control rate, 68% shrinkage rate, and 5% symptomatic morbidity in these patients, which is generally comparable with all other series which were published around the same time in the literature, with from 90 to 98% tumor control, and from 1/3 to 50% to 2/3 of patients had demonstrated shrinkage of the tumor. It should be noted that symptomatic improvement, which is also can be observed up to 50% of patients, is not correlated with tumor shrinkage. We can observe symptomatic improvement even without shrinkage of the tumor. This is one of our patients, 45-year-old lady with diplopia. She was treated with marginal dose of 12 gray, and she had full resolution of diplopia within 4 months, and at 3 years follow-up we saw tumor shrinkage, and the patient is asymptomatic. Of course, probably this patient can be operated and this tumor can be somehow removed, but I have a little bit doubts that functional results would be the same. How we can compare radiosurgery with surgery? There was a good meta-analysis published already a long time ago. They did a systematic review of published literature and included more than 3,000 patients treated for cavernous sinus meningiomas with gross total resection, subtotal resection, or radiosurgery alone. And the authors found that patients treated with radiosurgery experienced improved rates of recurrence in comparison to both gross total resection and subtotal resection. And the rate of cranial neuropathy was markedly higher in patients undergoing resection than after radiosurgery. So radiosurgery provides at least not worse tumor control and much better functional results for cavernous sinus meningiomas. Speaking about prognostic factors, symptomatic improvement is encountered significantly more often if radiosurgery is performed as primary treatment, whereas previous surgery negatively affects recovery from cranial nerve deficits. It's obvious because if cranial nerve is damaged during surgery, there is very low probability of its recovery after radiosurgery. Smaller tumor volume is associated with better tumor growth control and better functional results, whereas larger treatment volume is associated with complication rate after single dose radiosurgery. At that moment, multifractional radiosurgery was not so popular. And volumetric and functional results after single-stage radiosurgery, fractionated radiosurgery, and stereotactic fractionated radiotherapy were comparable at that time, once again. But this is not a randomized study, and of course, we can expect that for larger tumors, fractionated treatment was applicable more often than, was applied more often than single-stage radiosurgery. Actually, all these results are reflected in the ISRS guideline for treatment of benign cavernous sinus meningiomas. The authors of this guidelines analyzed 49 retrospective studies, and with level 3 evidence, they said that progression-free survival in these studies range from 86 to 99% at 5 years and from 69 to 97% at 10 years, which seemingly is comparable with surgery. Neurological preservation rate after radiosurgery varied from 80 to 100%, which in my opinion better than with surgery. Resection can be considered, according to the authors of these guidelines, for the treatment of larger tumors and symptomatic cavernous sinus meningiomas in medically eligible patients. But once again, we should consider that symptoms, specifically cranial neuropathy, can degrade after radiosurgery as well. And they consider that adjuvant and salvage radiosurgery for residual recurrent tumor can be utilized in suitable cases. We also saw today this illustration, but it can be interpreted in different ways. Of course, for large extracavernous tumors located not involving cranial nerves of the lateral wall of the cavernous sinus, surgical debulking can be considered. But as second stage, still we should think about radiosurgery for primary intracavernous neoplasms, which involve carotid artery and cranial nerves and surround these structures. I think radiosurgery or hyperfractionated radiation therapy may be better. So we are going to pituitary adenomas. In our experience, is the most common type of tumors in the cavernous sinus. So we treated how many patients? Sorry, I forgot how many patients did we treat, but it's the most common tumor with cavernous sinus invasion, which we have in our practice. Of course, initial treatment should be surgical resection, but now our neurosurgeons usually leave tumor within the cavernous sinus for radiosurgery. In such cases, we observe tumor growth control in 97%, and the shrinkage, once again, is the same as with meningiomas. In around a quarter of patients, shrinkage was 50%. In 39 of hormone-secreting neoplasms, normalization of the excess pituitary hormone production was noted after radiosurgery, which is lower than in other series. And this lower rate probably reflects our wish to perform more selective treatment of the tumor, not so aggressive radiosurgery. And morbidity rate was 2%, just 2 cases of transient cranial neuropathy were observed. If you look on different series, specifically with pituitary adenomas with cavernous sinus invasion, we can put attention on hormonal deficit after radiosurgery, which is usually not so high. We heard today that generally for pituitary adenomas, the hormonal deficit after radiation may be up to 40%, but in these cases, it is in some series it was 0% or occasionally up to 6%. Probably it depends on the location of the tumor a little bit laterally from the pituitary stalk and the pituitary gland. This is the only one explanation which can be given for good preservation and the gynecological results of the treatment of pituitary adenomas with cavernous sinus invasion. Probably now I came to the most important part of this talk. I'm not visiting India not first time. I was already in Mumbai, attended a very good conference organized by Professor Secretory, who is a prominent figure here in India in neurosurgery. And I saw a video presentation when the surgeon showed such kind of tumor and how he operated it. And the surgeon showed heavy bleeding during surgery and said that it was a complication. I believe it was not complication actually. It was natural course of surgery in such case of tumor. The complication was during selection of the treatment strategy, because these tumors, which are called cavernous sinus hemangiomas, they shouldn't be operated. There is a large amount of data now. This review was published 11 years ago by the group from Shanghai. At that time, they studied 59 cases. They treated of these cavernous sinus hemangiomas. They treated them with vaginal dose from 10 to 19 gray with gamma knife, and they found remarkable shrinkage of 67.98% and partial shrinkage of 25%. Recently, the group of Professor Tripathi published another review on the same topic in Neurology India in the supplement, and they found even better remarkable shrinkage, I think in 75% of cases, or around 75% of cases. So nearly 100% of these patients respond to radiosurgery. And according to this Chinese data, neither tumor volume nor previous surgical removal was associated with the volumetric response of cavernous sinus hemangiomas after irradiation, which suggests that radiosurgery may be considered as a method of choice for their management. Moreover, it's also not depends on size. This is another paper of the same group from Shanghai. They evaluated only giant cavernous sinus meningioma. They treated them with CyberKnife at this moment with 3 to 4 fractions, and you can see dynamics of the tumor after treatment with complete shrinkage. And this is not exceptional case. On this graph, they demonstrate volumetric reduction in all their cases which they investigated. So a very typical clinical course. In this kind of tumors, definitely it's my address to neurosurgeons. If you see something which looks like says cavernous sinus meningioma, but has an extremely high signal intensity on titulated MRI, there is no need to operate these patients. Send them to radiosurgeons, and radiosurgery is very effective. Speaking about not so frequent tumors, cavernous sinus schwannomas, we treated a few patients, well, it's not so often, and we found in this patient significantly higher rate of temporary cranial neuropathy in comparison with other tumors, which mainly affected the nerve or tumoral region. But it was temporary in nearly in all cases. Speaking about malignant tumors, usually malignant tumors of the cavernous sinus, it's either metastasis or extension of the local cancer on the cavernous sinus. Usually these patients are coming to radiosurgery being heavily pretreated. So this is a series from Pittsburgh. They studied 37 patients with cavernous sinus metastasis or invasion from adjacent skull-based tumors. And overall survival, of course, these patients are dying. Overall survival was 36% at 1 year and 19% at 2 years. But what is the main thing? That 35% of patients demonstrated improvement of neurological symptoms after radiosurgery. So we probably cannot provide extension of survival on these patients, but we can definitely improve their quality of life during the residual months. This is an example. This is a case of Professor McCutcheon, who is here from MD Anderson Cancer Center, metastasis of renal cell carcinoma into the cavernous sinus. The patient complained on the decrease of vision. She was treated with radiosurgery, and until death 11 months later, 16 months later, she had preservation of vision, so definitely the quality of life was improved. There is another case of malignant tumor, case of Dr. Ivanov from St. Petersburg. When we saw these images on the left side of a 78 years old lady with facial pain, we consider this as meningioma. And I checked literature thereafter. There is no possibility to make differential diagnosis between exact histological diagnosis of this tumor and meningioma. So we treated, the patient was treated with a rather low marginal dose of 10 gray. And as you can see, in 6 months, the tumor gone completely. And probably you already understand diagnosis. It was Meckel's cave lymphoma, and we know the diagnosis because 16 months later we had this recurrence, parenchymal recurrence. Actually, there was no recurrent primary tumor, and at that time biopsy was done, and it was confirmed that this is lymphoma. So another malignant tumor which was effectively treated with radiosurgery. So now I'm going to complications. Visual neuropathy we already discussed today. Incidence is up to 4% of patients after single session SRS. Latency period is in median 48 months. There are different safe doses we proposed for optic nerves and chiasm. 8 gray, 10 gray, 10 gray is our cutoff. 12 gray was proposed, but the main thing that it should be applied with consideration of other risk factors as previous radiation, nerve compression, visual function before treatment. And unfortunately, at least maybe I'm wrong, maybe correct me, but I don't know any guideline how we should adjust those to the optic nerves considering these other risk factors. We can discuss it later. This is our one case of major complication. This was abducens nerve schwannoma with extension, both intracranial and intraorbital extension, and we treated it without complication. The dose to the optic nerve was, I don't know, can you see it or not, but we delineated it clearly. It was, I think, even less than 8 gray. But at the time when this schwannoma expanded, just in the middle, on the right column expanded, which is also a typical course of schwannomas, any schwannomas after radiosurgery, the patient, the vision of patient deteriorated. probably there was direct compression of the optic nerve or interruption of its blood supply. Fortunately, when later tumor shrunk, the vision returned. But I think that if we would treat such a patient now, I would think that at first stage we should do surgical decompression. And if the schwannoma is located in some constrained area, probably we should consider that this expansion, temporary expansion after radiosurgery may result in some complications. Cyst formation, we observed also one case, another case of abducens nerve schwannoma, which is located in the cavernous sinus with extension in the prepontine cistern. And within several months, there was cystic degeneration of the part of the tumor within the cistern. It was asymptomatic, and we didn't treat these patients in any way. Carotid occlusion was described in a few case reports, but it's possible. Usually it's asymptomatic because of probably very slow development of carotid occlusion in these cases. But of course, stroke can happen occasionally. Aneurysm formation is also a very rare complication. We had these patients with Ewing sarcoma with the skull base who was operated, and then he received 3 courses of IMRT during 42 months because of several recurrences of the tumor, with a total biological effective dose to internal carotid artery of 220 gray, which is extremely high. And the rupture of aneurysm has happened 7 months after the last course of radiation. Definitely this radiation-induced aneurysm. There was a review of such cases, and the colleagues from China found 58 reported cases of aneurysm formation after radiosurgery or high-dose radiation therapy. And they found that actually this is a dangerous complication. 75% of these aneurysms presented with rupture, and 25% died soon after rupture, so it should be considered. Fortunately, it's not so common. And finally, formation of malignant tumors. Also, there is a probability of 0.001%, but it's also very rare complication of radiosurgery for cavernous sinus tumors. So this conclusion that now we have, with the help of radiosurgery, we can treat patients highly selectively, conformally, and it provides safe management of cavernous sinus tumors, which may be effectively used as a sole treatment modality or as part of combined management after initial surgical resection. Thank you very much, and if you have some questions, let's discuss it.
Very nice paper, Dr. Chernow. If somebody asked me which sort of brain tumor you would not like to have, I would say any skull-based tumors. And of course, a cavernous sinus tumor, not due to the mortality as such, it's due to the morbidity. So I would not like to live with the morbidity. So this is what I would definitely extend towards my patients also. So especially possibly the working class people, they would not like to have any sort of morbidity as such, because I myself personally have had a Miller-Fisher syndrome possibly 20 years back, which changed my life as a doctor, because I was with cranial nerve palsy, especially a third nerve palsy. I had it for 3 to 4 months. I was not able to work. So this is a sort of disability, as even the smallest deficits, as Rajshekhar sir said, even post radiotherapy, all these small sorts of deficits, I think we'll have to think of when we look to treat patients. So the topic is open for discussion. And one thing which I would like to ask you is, who assesses all these cranial nerve palsies? Because we as neurologists or neurosurgeons, we are so used to handling all these stuff. So especially in patients treated with radiosurgery, especially of cavernous sinus tumors, who assesses the cranial nerve deficits? Is it a neurologist or a neurosurgeon? Who does that?
Actually, you know, it depends on society, of course, and I understand that in India it may be difficult, the same as according to the size, because of size in my native Russia. But in Japan, you know, the people are very well organized, and there are many radiosurgical facilities. So usually all this follow-up is performed by the same neurosurgeon who is doing treatment. And treatment with gamma knife in Japan is usually performed by neurosurgeons, not by radiation oncologists. So the patients usually followed by the same doctor.
Yeah, that's wonderful. So I think possibly we'll have to think of that also, because when a neurosurgeon, and especially in these days where technology, even with radiosurgery, it has also advanced as far as surgical specialties are concerned, and people are more adept to doing surgeries, or even of the cavernous sinus, which was once considered the pinnacle of neurosurgery. So either ways, we'll have to look at it sort of very pragmatically to assess the results. Neurosurgeons, being neurosurgeons, I think we do assess it, we do look at it more critically, especially a deficit which we create. That's why I just asked the question. The topic is open for discussion.
One more thing I want to add on is that the imaging diagnosis is very important in cavernous sinus tumors, because when we see around 2 to 3 centimeter tumors, it's very common for people to mistake a schwannoma as hemangioma or hemangioma as meningioma or something like that. So we recently have advocated delayed contrast enhancement as one of the markers to definitely diagnose especially cavernous sinus hemangiomas, because if we do early contrast scans, most of them have non-enhancing areas, which people often confuse as schwannomas because they are non-enhancing or internal necrosis may be there. So delayed contrast enhancement gives proper delayed, fully enhancing tumor in a hemangioma, like we can expect a good response, because patient counseling is also important. Like hemangiomas completely give a very good response, but the same cannot be expected with meningioma and schwannomas.
Yeah, absolutely, very good comment. We use usually delayed contrast enhancement for pituitary adenomas just to better delineate the tumor, especially in recurrent cases. Yes.
The funny thing is, most of the cavernous sinus tumors that we do radiosurgery are meningiomas, schwannomas, and pituitary adenomas, non-active pituitary adenomas. And all of them respond to 12 gray, 13 gray, something like that. So if we may misunderstand the tumor, for example, if we diagnose wrongly to a cavernous sinus hemangioma to a meningioma, for example, nothing changes. They respond well. But when in a meeting you see that we irradiated a cavernous sinus meningioma and we took an MR 6 months later, we didn't see the tumor, it was not meningioma, it is hemangioma. So then you can say it. So it is not a big problem for us, but the big problem for us is the lymphoma in that area, lymphoma, other skull-based tumors infiltrating the sinus tumors, infiltrating the cavernous sinus, and also Tolosa-Hunt syndrome. They can be understood as a tumor, I mean a benign tumor there, but they can be make a big problem for the patient. I think these are very important for us as a diagnosis.
Right, it's very good comment. Another thing, yes, of course, I absolutely agree with you. You mentioned lymphomas, but you know, there are some series, for example, they published series on meningiomas, when there is a complete response of meningioma to radiosurgery, it is considered as complete response of meningioma to radiosurgery within like several months. But in my opinion, it is impossible. So probably in these cases, it was just different tumor, but the authors of the study considered it still as meningioma because of radiological features.
Mm-hmm. And can I ask you that, do you believe that cavernous sinus is, carotid artery is obliterated due to radiation, or is it because of the tumoral effect?
Yeah, it's you know, it's a very difficult question. There are no proofs. It may be obliterated because of radiation. It may be obliterated. Some authors say that it's obliterated because of tumor. Yes, but you know, the number of these cases, I tried to check it, it's really few. Sometimes even, but occasionally the tumor shrunk, but still we see obliteration of the carotid artery. So it might be a double effect of the tumor and the radiation.
Can I ask one last question? Yeah. So here, Dr. Chernow, interesting presentation, really liked it. it has been our experience also in those patients who had ophthalmic palsies, the symptomatic response has been fast compared to radiologic response. What could be the reason?
The best explanation of this is, despite volumetric changes of the tumor, which can be checked with MRI, there is improvement of blood supply to the nerves, and it results in improvement of the function of nerves. We also observe these patients. So improvement of the, usually it's about cranial of neuropathy of the nerves of the lateral wall of the cavernous sinus. So without changes of the tumor volume, we can see improvement.
But there is no change. Without any meaningful, significant change in the volume, the symptom regression is fast in few of the patients.
Yes, so this is the thing, that we cannot capture the changes of tumor metabolism, let's say, of some small compression of small vessels. What is your explanation? This is...
No, I tried a lot, I boggled, but I couldn't give a logical...
I believe this
but
only...
that has been the experience which I...
Yes, we also observed it.
Not many people also.
I believe that this is some minimal changes of the blood supply which may be critical for improvement of function.
Another question, especially for cavernous sinus, because the major vessels are there. So I can recall in my experience one case, acromegaly with pituitary macroadenoma extending into the cavernous sinus, operated elsewhere, giving the full external beam radiation therapy elsewhere, a residual tumor, and the tumor never responded functionally. It shrank in size, but the growth hormone secretion never settled down. We gave gamma knife full dose from 24 grays, and patient responded. But over a period of time, tumor shrank in size, but one fine day, the patient presented with a major stroke. So there was a complete occlusion of the ICA. So I just want to know how commonly it is there in your experience, and the cavernous sinus has already been irradiated previously. So do you do some sort of changes to take into factor so that the ICA is not going to get affected?
So you mean how to treat recurrent tumors within cavernous sinus? So it depends on tumor, on extension. Occasionally we try even to avoid high dose radiation for the carotid artery, intercavernous carotid artery. But sometimes it's unavoidable. Usually, you know, the number of cases with stroke after gamma knife radiosurgery for cavernous sinus tumors and obliteration of the intercavernous carotid artery are so small, you know, it's few cases reported in the literature. And as Professor Pecker mentioned, it's not so clear whether radiation-induced actual obliteration or tumor-induced obliteration. So if possible, we are trying to perform selective treatment without inclusion of carotid artery into the high-dose radiation area. If it is not possible, we are treating tumor as usual.
May I answer this question? So vessel stenosis after gamma knife, the Sheehan group published their experience after, so they first evaluated that ICA, whether it was encased or it was engulfed. So then they tried to find out if there was a hotspot over there. If there were hotspot, because there is no definite definition of the radiation tolerance of the major vessels. So they tried to point that if there is a hotspot of a 50 gray, then in those cases, there were chances of the vessel stenosis. But the radiological occlusion happened in somewhere around 20 patients, but the clinical presentation happened in only 4 to 5 patients, and they did a literature review with their own experience that also showed only 5 patients. So in those cases, the clinical presentation of the stroke rarely happened because it happened in a chronic way, so probably there was some collateralization happening, and that didn't translate into a clinical stroke, rather just a radiological occlusion of the ICA. So probably the hotspot is the one which is responsible for that one. So if you, while planning, if we can avoid the hotspot over the vessel over a length, then probably that's going to save us from a vessel stenosis.
Yeah, what you call as hotspot, I call as high dose radiation area. It's practically the same idea. But still, you know, occasionally it is possible, occasionally it's not possible. So if it is not possible, in our practice, we're trying to treat tumor in the usual way without any caring about the intercarotid artery once again, because the risk is, the risk exist, but it's rather low.
So it was more common vessel was engulfed in those cases rather than hemangiomas where it was just over the periphery and the lumen was not compromised because of the tumor. So the chances were more in pituitary adenomas followed by meningiomas and last in the hemangiomas. There was practically no case of stenosis in cases of the hemangiomas in their series. And as you showed that Cavernous sinus hemangioma, Sheehan had the maximum number of cases of somewhere around 738. So that's a huge number for the lesions in the cavernous sinus, and still he didn't find any stenosis. Then probably it's something related to the primary pathology and the hotspot both.
Okay, thank you so much, Dr. Cherno.
Thank you, sir, for the very informative talk. Now we move on to the discussion on real clinical cases, the neurosurgical indications. The moderators of this session are Dr. Amitabh Ray, Consultant Radiation Oncologist at CG Echo Cancer Center, Kolkata, West Bengal. I welcome you to the stage, sir. And Professor Selçuk Peker, Chief of Gamma Knife Radiosurgery, Koç University School of Medicine, Istanbul, Turkey. So I welcome you both to the stage, and please introduce the speakers of this session.
I think Dr. Jin Yu Yang is not here. Okay. Now we are going to begin our case discussion for real clinical cases, session. So the first speaker will be Dr. Deb Dutta. Yes, he is here. Okay, please, doctor.
Yeah. Good evening. Now, what I'm going to do is I'm going to just open up how we treat, and then I try to find out that how we can put some inputs and your comments, and it is like a panel discussion kind, and all of you are in the as expert there, and I'm going to just present the cases. Now, this is our cases, what we do. So, see, around 400 patients per year, and 50% are intracranial, and if you see brain metastasis, it is around 25% of the patients are brain metastasis, and 30% of our patients are benign brain tumors, which collected together. And if you see the prostate, it is around 2%. I just wanted to ask our people that what is your experience? How many patients, Manjul, how many patients benign you treat? How many metastases, brain metastasis you treat? Can you give the mics, please? I just wanted to see that how is the difference in terms of presentations in different countries.
Sir, at our center, we are treating close to 1,000 plus cases per year now. And nearly 75% are the benign disorders, which mainly include vestibular schwannomas, followed by meningiomas, residual pituitary adenomas, sometimes the primary, the glomus tumors. Then comes the vascular malformations, so that takes care of around 10% of the patients, majority AVMs, and the deep-seated cavernomas. Followed by the functional indications, and the functional is mostly limited only to the trigeminal neuralgia. And last comes the metastasis. So metastasis takes care of somewhere around 2 to 3% of our total tumor load.
Yeah. Dr. Rupesh, what is your experience in that?
Probably going to be the opposite. So at our center, about 85% of the cases are actually metastasis. And the rest are going to be benign brain tumors across the different indications. I think a majority of dedicated cancer centers, it's going to be brain mets. It's going to be a majority of the volume itself. Majority of those are going to be lung cancer. Nationally, it's about 50%. At our cancer center, it's about 65%. Secondly, it's breast cancer. Nationally, it's about 25%. At our center, it's about 30-35%.
Now, Dr. Mikhail, it's go with you. Your practice also the same kind of presentations? Professor Parker? Professor Parker, you also same kind of 20%? Almost same, yeah. So it is then the presentation is almost same, like brain metastasis, maybe little plus minus depending on the situations here. Now, in our we have done a very interesting work. We see the 85% of the patients are within 100-kilometer radius. Now, how is Rupesh, how is in your case?
Yeah, so
And only 5% are international patients.
Yeah, So in general, about 80% of our patients are from our area, just in the South Florida region. And then we have about 10 to 15% of patients are going to be outside of that region, and then about 5% are going to be
Almost
international.
same. Yeah, Professor Parker, you feel that's it is same, or you see most of the patients from very close, within 100 kilometers?
From all over Turkey and also from international.
And Manjul, what is your?
Two centers in nearly 250 kilometers area, New Delhi and Chandigarh. So
Yeah.
Chandigarh takes care of nearly 80 million patient population drainage area because there are 5 adjoining states, right from the Jammu Kashmir to some eastern part of the UP, Punjab, Haryana. So that's our catchment area, 80 million patient population. And sometimes we get patients from the South India also, rarely from Bangladesh and Nepal.
Yeah. So mostly from within 100 kilometers, 150 kilometers. So this is standard for most of the places. Within 100, yeah. Now, this is the number of brain metastasis patients we have seen for last 15 years. If you see, in last 7-8 years, there is a significant surge in the number of brain metastasis patients treated whole brain RT as well as radiosurgery. Now, is it case for you also, Dr. Vinita, Dr. Manjul? So the same trend is there for everyone. You also, that Rupesh, you also the same thing you are saying? There's a significant surge in number of brain metastasis. Or, see, now what actually in our case, we got the radiosurgery facility in 2018. And I was wondering that whether we are getting more number of patients because we have the facility here or because we are doing more MRI.
So say for example, HER2 positive breast cancer. So even if they are on anti-HER2 new therapy, it takes care of the extracranial disease well. Yeah. So that is why we see more brain metastasis. Yeah. Similarly in lung cancer. So we are all seeing this increase in the number of brain metastasis. Same number of brain metastasis.
Now what about the cases treated with whole brain radiations and treated with radiosurgery? Now if you see, now till 2018, the whole brain radiation was the treatment. There's nothing called radiosurgery there in our hospital. But in last 2-3 years, you can see there's a significant surge in number of radiosurgery cases. It is happening with your cases also?
Yes, sir. That's definitely happening, and especially for the RCC and prostate, which are usually considered the resistant ones for the conventional radiation. Yeah. So those cases are primarily with the oligometastatic node. They are being referred to the radiation.
Rupesh, how is your practice changing? How many patients you are? If you 100 patients brain metastasis you see, how many are radiosurgery done in that?
Yes, so the majority.
And good performance status?
Yeah, the majority of patients are receiving radiosurgery. We typically will treat upfront radiosurgery for up to 15 brain mets, but if younger patients, if they have specific molecular profiles, we'll go up to 20 or 25 lesions in a single session. So really the whole brain patients are going down and down. And really, you're just using it for the lepto patients, essentially, or for innumerable brain mets, but now the lepto patients are getting proton CSI. So really, the number of whole brain patients alone is going down significantly.
Dr. Rupesh is mentioning that he's treating up to 15 metastases also. I think most of us are not comfortable beyond 5. What do you
think? It is different. I mean, in the United States, we will routinely treat 15, 20, 25, but
so in our hospital we treat up to 5. Most 80% of the patients are up to 3. I'll show you the data.
Just to add on, we with Manjul we have treated up to 38. 38 lesions by gamma knife. So that one thing is, I agree with Dr. Rupesh. If the total volume is less, then the number doesn't matter. If you are comfortable, you can treat.
I had one of your papers there, which showed that if you treat more number of patients, then ultimately there is the dose distribution, because dose spill-off will be there.
Yes.
So there will be no difference in terms of whole brain RT and doing radiosurgery.
If you look at the dosimetry, especially for modern radiosurgery platforms, I mean, it'll be Zap or gamma knife. Essentially, if you treat about 20 lesions at a reasonable size, anywhere that is less than a centimeter, then your dose to the whole brain is about 1 to 1.2 gray for every 20 lesions that you treat. In general, that means you could treat about 100 lesions and still be under 5 gray to the brain. So as opposed to doing, for example, 20 gray and 5 fractions whole brain, you can treat a decent number of lesions.
So we are still treating 5 lesions with brain metastasis. I said, now that is what we will come to come. So you like this, you are seeing the same trend, what we are seeing, that lung and breast is the primary site. So is it same for all places? Now, what I understand from Indian subcontinent, that most of the breast cancer patients are young. They may have different kind of hormones receptor positivity. Lung cancer, their target receptors may not be mutated to be targetable. So whole brain RT may be more because they have a more chance of metastasis. Do you buy that, or it is something which you are postulating and it may not be appropriately true? Dr. Vinita, what do you feel?
When you're choosing between SRS versus whole brain RT, you have to take into account the whole picture. You know,
No,
age
so
of
young
the patient,
patients,
life
see,
expectancy.
35-year-old breast
You will
cancer
think
patient.
10 times before giving whole brain radiation therapy. I'll be
So
very hesitant.
what is now? They are saying they are triple negative, and their probability of having a new lesions are very high. And you are treating with radiosurgery and
You have
omitting
to-
the whole brain.
Recently, I treated one 35 years old with triple negative with 3 brain metastases. She failed very quickly after her loco-regional treatment. But then this treatment of SRS is done after a proper counseling of regular MRIs and be prepared for any requirement for whole brain radiation therapy.
Yeah. Anyone?
Again, in the decision making, the pictures come is prognostic assessment indices. So, what is the more detrimental for the patients? There is definitely difference in the local control, but whether that is leading to the benefit in survival, there is no data suggestive of survival benefit. But definitely, neurocognitive function is hampered by the whole brain. So, if the patient is going to suffer more detrimental problem of neurocognitive definition, then better to avoid whole brain radiotherapy.
So what you feel? Rupesh, you in a 35-year-old with triple negative, the probability of new lesion coming is very high. And
So in the United States, if you're a 35-year-old, I think it doesn't matter how many lesions they have, they're going to get radiosurgery.
Okay.
But I think the key things in the triple negative population is that, number one is those patients now receive immune checkpoint inhibitor therapy because there's data that there's some benefit in that patient population. And then secondly is actually finding out the patients that are truly triple negative, because they're patients which are technically HER2 low, which were usually called HER2 negative in the past, but now actually can benefit from HER2 directed therapies that have intracranial penetration. So really that triple negative, we're excluding out the patients who cannot get immunotherapy or who do not qualify as HER2 low. Those are the select patients that I think are going to do poorly, unfortunately, regardless of what you do in the brain. But if you can select out those other patients, they can get access to therapies, both of which actually penetrate the brain.
Okay.
The only, I mean, I agree with everything is said, and we have moved to radiosurgery. The only cases I struggle are the HER2 positive cases with a very short DFI and largest lesion post-op, SRS cavity. That the target delineation and the dose fractionation and the dural invasion is quite challenging.
See, just continuing the sir's question, if it is a post-op cavity and you can't give more than 25 in 5, we know that the control rate is around 56, 57%, 60%, not more than that. You can't give more than 25 gray in a large post-op cavity. What do you do in that?
So it depends. If the cavity is very large and we can't give a significant dose, and essentially we will always give 30 and 5. Again, 25 and 5 is too low, probably in the postoperative setting. I would give 30 gray and 5 fractions. If I could not, then I would give hippocampal avoidance whole brain radiation therapy in that patient population, and then potentially do a simultaneous integrated boost to the actual resection cavity itself. So you can get 40 and 10 to that resection cavity and 30 and 10 to the rest of the brain. So that's how I address those patients.
Could you tell us the current update on the pre-operative SRS? Any update on that? Data?
So right now, I mean, we've essentially transitioned to preoperative radiosurgery for the majority of the patients, specifically for breast cancer patients with dural-based enhancement who have very large lesions, and in the posterior fossa, those are very, very high risk for leptomeningeal disease failure. So we offer preoperative radiosurgery for those patients. There are 3 trials in the United States that are ongoing, one at MD Anderson, which is still ongoing, one at Mayo Clinic is still ongoing, and then a national energy study which has opened to accrual, which is randomizing patients between pre-op and post-op, which has just started the accrual process itself.
Do you add memantine with SRS?
Yeah, we don't add memantine right now for patients who are receiving stereotactic radiosurgery. I think that's a good question.
So now if this is large AVMs, and most of, yeah.
So who are the patients whom you will refer for surgery after
Yeah, so there are some patients who are potentially borderline patients, and you could do pre-op SRS and actually do a 4-week exam, and then if essentially you can do a boost dose of radiosurgery, or you can decide on surgery at that point. There's some data in the pre-op SRS or in the staged SRS that show that patients who do not respond by that 4-week mark, those patients probably are going to need surgery afterwards. So you can use that as a test of faith, basically.
This is a large AVM. Most had a bleed. Now, can you treat in two? We treated this patient in two stages, and 18 gray upper part, and then again 18 gray after 6 months lower part. And if you see as per the Flickinger's model, 18 gray will give 80% control, and if 25 cc is the 12 gray volume. If you combine together, then the toxicity rate is less than 5%. So how you work on that? Do you do that? Like that, a large AVMs who has a bleed need to be treated. You treat like that?
No, sir, I won't treat in that way because it's a blood AVM. I wouldn't volume fractionate until I know the complete angio architecture for
Yes. DSA is done, and this is planned in the base of DSA only.
But I would like to do a dose fractionation rather than doing a volume fractionation because the chances of interval bleed that gets completely obliterated are much higher than volume fractionation compared to the dose.
But dose fractionation, the obliteration rate also comes down significantly.
It's not much difference. If you look on the statistical parameters, the literature doesn't suggest much difference. And we at our center, we were the first ones which started a dose fractionation with the Vilaxil frame in situ. In 2 or 3 fractions, and then we could. So it depends on the grade of your of an AVM. If it is a grade 4 and 5, then the obliteration achieved by the end of 4 to 5 years is somewhere around 50 to 60%. It's not 100%. Grade 1 and 2, it's more than 95% obliteration. Grade 3 is a mixed bag. So their obliteration is somewhere around 70 to 80%. Sometimes you need to wait a little longer. Beyond 3 years, you need to follow these patients angiographically, and sometimes, very rarely, you need to give a second round of the radiosurgery as well. But I'm not a big fan of a volume fractionation in that way.
We have treated good number of patients.
It's close to... Ma'am, that depends on the tumor volume and its location. If it is a deep-seated one, we are little conservative in our dose, and we fractionate it in a more number of fractions. But if it is on a periphery or something like a motor cortex, we can treat it in 2 to 3 fractions with a good dose. 9 gray into 3 fractions or 8.7 into 3 fractions in that way.
So you don't, then you are going away from this Flickinger's model of 18 gray, because that is a predicted model, already is established, and for last so many years we are using that.
Then if you need to look at not on the V12, you look at the V8, you look at the V10, and then you predict it on that way. Because again, you are giving the normal brain a time for the recovery. That's the reason for the fractionation we are doing.
Now, this is a very interesting, actually, we have documented it, that patient came and had a bad order when they are getting the radiation done. So have you seen patients like that? The patient is complaining that they are having a bad odor during the treatment. Huh? Bad odor means there's like a rotten egg smell. Yeah.
So we have 2 cases we have seen in the proton therapy, and both were young people. Both had nasopharyngeal carcinomas, and it is known. And it may not be necessarily a bad odor; it can be a different odor. And people are trying to use it as a organ at risk structure now.
Yes.
At near the ethmoid area. So it is known. Very, very rare, but known.
Yeah. So now, the very interesting thing is, if you have a FFF, triple F free you give, and or you give proton, then there is an ionization of oxygen and become ozone, and that ozone can also cause bad odor. So there is some hypothesis on that, and another hypothesis, you're giving the olfactory bulb, and that is stimulating and causing disorder. So there is something interesting, and that need to be taken into account when you are doing radiosurgery, because these kind of things can be seen. Okay. Thank you very much for this patient hearing.
Thank you. We will move to next speaker, Professor Amr Al-Shehabi, and he will present his case. Thank you.
Okay. Good afternoon. Now, I believe radiosurgery has opened the door for new indications and approaches. Many guidelines, when they were developed, they did not have radiosurgery in them because radiosurgery was not that advanced at the time. So I think that some cases that were not traditionally treated by radiosurgery or by gamma knife can benefit from gamma knife. And this is one such case that I would like to present. This was an 18-year-old female patient. She presented with obstructive hydrocephalus. As a life-saving procedure, a right VP shunt was inserted. We did an MRI, and the MRI showed an intensely enhancing pineal lesion. So, what do we do next? Any suggestions? Tumor markers. Okay. Anything else? We did tumor markers. Negative. We'll take it step by step. Oncoproteins are negative.
In such cases, if neurosurgeons refuse to perform operation, we do PET with methionine.
Yeah.
And after that, we make a consideration about radiosurgery or radiotherapy.
What do you look for in the PET? And you look for the activity of the tumor?
Yes.
Or,
metabolic activity.
High or low? That's what you mean? Malignant or benign lesion? You mean, or a tumor or a non-tumor?
Firstly, we have to prove that it is a tumor, not.
Okay.
And then according to PET data, we couldn't definitely understand benign it's or malignant, but the rate of metabolic activity, I think it's also important in further consideration.
Yeah, so basically you want to first make sure it is a tumor.
Yes.
That's it. Okay. Okay.
Anyone wants to see the histopathology of this lesion there?
Okay.
So why don't you do stereotactic biopsy, for example?
Okay. There are two invasive options: surgery and stereotactic. Okay. I'm a neurosurgeon. I do both surgery and stereotactic. Okay. The patient refused both. But why? The pineal gland is closely surrounded by a group of veins. We have the internal cerebral vein, the basal vein of Rodentale, we have the vein of Galen, we have the posterior choroidal artery, all around this small structure. And when you have a tumor in this gland, the tumor also displaces these vessels beyond their anatomic location, so you don't know where they are. So even a biopsy would be risky for these patients. Microsurgery has reported mortality rate of 4%, morbidity of 3 to 12%, and even biopsy has a morbidity and mortality associated with it, including a hemorrhage inside the tumor, a swelling of the tumor causing acute hydrocephalus, or hydrocephalus if the patient does not have one. And even it has been reported that metastatic seedling can occur along the biopsy tract in malignant tumors. So we did the oncoproteins, they were negative. We considered the possibilities that may occur in this region, either germ cell tumors or parenchymal tumors or melanoma. Our way of thinking was, first of all, consider the age of the patient. The patient is 18 years old, she's a young patient. We probably would exclude pineocytoma from the differential diagnosis. The CSF evidence was not there. If we had a supracellular, associated supracellular tumor, we would definitely find a diagnosis of a germ cell tumor. And if there was CSF seedling, we would find it's probably a metastasis. So we excluded pineocytoma and melanoma. We had basically two choices, either germ cell tumor or a pineoblastoma. This is what was our thinking. We decided to do an MRS in hope that it would help us to reach the diagnosis. The MRS found a mildly elevated choline and markedly reduced NAA. It was suggestive of a pineoblastoma, but I think the data is inconclusive. I probably used looking at the age of the patient. We did an MRI of the whole spine. It was negative. So we know that germinomas, they melt with radiation, even conventional radiation. So we thought that maybe, sorry, please. It could be any sort of germ cell tumor. That's, yeah, of course. So we thought that if it is a germinoma, we'll treat it with a low dose, and after a month or two, if it disappears, then it's probably a germinoma. And after that, we will send it for radiation, whole brain radiation, to continue the treatment. So we did a 13 gray to the 7.1 cc tumor at 98% cover. And at 4 months, we can see complete response. The tumor has disappeared. So this is not definitely a pineoblastoma. It is most probably a germinoma. We wanted to send the patient for continuation of radiation, of ventriculospinal radiation, but the radiation oncologist refused. So we continued follow-up the patient. 7 months later, developed a hypothalamic tumor. Hypothalamic tumor, a pineal tumor, is probably a germinoma. It's definitely a germinoma. So we recommended, again, ventriculospinal radiation. At 13 months, the patient did not also receive ventriculospinal radiation. The hypothalamic tumor continued to grow. So eventually he received radiotherapy, 50 grays in 25 sessions, and a complete response. The tumor had disappeared. So we know that the conventional management of germinomas is, first of all, or pineal tumor is obtaining a histopathology. And if it is a germinoma, we do radiotherapy and chemotherapy in some cases in which there's dissemination or recurrence. The newer management strategies would suggest SRS as a boost. This study by the International Radiosurgery Research Foundation, they did a review of the cases treated by pineal lesions treated by radiosurgery. As we can see, the germinomas and pineoblastomas, the radiosurgery was given as a boost, followed by radiotherapy, and in pineocytomas, it was given as a primary treatment. And even after recurrence, it was given, radiosurgery was considered for recurrent cases. In Japan, where germinomas are common among primary brain tumors, the proposed strategy there, it's published in a paper. We do radiosurgery in 10 to 12 grays, followed by ventriculospinal radiation, 24 grays in 2 gray sessions. Cranial radiation, of course, is necessary to avoid CSF dissemination. So our proposed strategy is do a pre-radiotherapy radiosurgery. Advantage of this is a diagnostic dose. If the tumor melts, then this is a germinoma. Also a boost for the radiotherapy that will be given after that. It's cost effective and is safe. There is no surgery or biopsy. So this was my case.
Any comment or question? Please. Yes.
I'm quite disturbed after listening to this case. Germinomas have a very high cure potential. we think of curing them, and we want to avoid craniospinal irradiation in these children as much as possible because of the long-term side effects of this large field of radiation. The standard of care for germinomas would be chemotherapy along with cranial RT, which also means total ventricular irradiation. In today's day and age, when the safety of biopsies and surgeries have increased to such a large extent, I agree that there is a figure of 4% mortality and morbidity. But I think overall, the safety of these procedures have markedly increased. So I cannot imagine in my own practice or in my own setup doing this kind of radiation therapy to come to a conclusion about likely pathology that I'm dealing with.
But in any case, you will
And
you
in
will
this
give
patient
radiotherapy.
it worked. In this patient it worked. What if it did not work? I mean, she showed response to radiation therapy.
Yes. My question, what would you do for this case?
I would insist on biopsy. I would insist on biopsy.
A patient will not do a biopsy.
Sir.
And I want to ask you, would you, I know that chemotherapy, some people give radiotherapy or ventriculospinal before chemotherapy, and some give chemotherapy and then follow up. So would you consider giving radiotherapy for this patient, ventriculospinal?
Only if I'm absolutely pushed to the wall, only in an exceptional circumstances. But you said that why not use this as a tool? I would not consider this this approach for pineal tumor.
But I mean
if suppose the patient is living in a country where the facility of biopsy is not available, or that kind of dire situation I would think of. I would request more radiation oncologists to give an opinion.
Thank you. Yes, please.
So one alternative, I think if in the first scan, if hydrocephalus was there and patient underwent a ventriculoperitoneal shunt, probably we could have attempted ETV and biopsy.
Sorry, again.
In the first scan, if the patient was having hydrocephalus, then endoscopic third ventriculostomy with biopsy would have been an alternative. Because in our setup, in all the pineal region tumor, if the patient is presenting with hydrocephalus, we are trying our best to get some biopsy. Because it is the histological, like the diagnosis will be the best. If we do not have the histological diagnosis, then only we'll try for some other alternative. Probably with endoscopic biopsy or with flexible endoscope, an attempt should be made.
Yeah, but what I demonstrated is that eventually this patient will need radiosurgery. There is disagreement about this. This tumor will eventually need radiosurgery.
Why radiosurgery?
If it is a germ cell tumor, I don't think there is an indication for radiosurgery. Whole ventricular RT will suffice.
If it is, sorry?
If it is a germ cell tumor,
yeah.
the germinoma, the role for radiosurgery is not there.
They are very radiosensitive, radiosensitive.
That's what I mentioned at the beginning.
Yeah.
Guidelines, when they were developed, radiosurgery was not that advanced at the time. And that's what I mean.
It's one of the most
a tool.
Very sensitive tumor to radiation, very sensitive to chemotherapy. If it is a germ cell tumor, usually you start with chemotherapy.
I agree with you, but we need a diagnosis.
No, but you are treating in the line of germ cell tumor. If you have already accepted that we are treating in the line of germ cell tumor, then you have to accept that it is very radiosensitive tumor. Once it is very radiosensitive tumor, then why you are giving hyperfractionated or high dose? Yes.
Yes.
And I fully agree with
yes,
that.
But I mean, in this case, it was used as a diagnosis.
Any other question or comment?
So if you just go back,
please. Yes.
Can you just go back 2 slides to what you had before? Can you just go back?
Which slide? Pre-treatment, post-treatment.
There. Yep. The algorithm. So this is the IGKRF or IRF algorithm.
Yeah.
If you see here, specifically for germinomas, radiosurgery actually does not have a role. It is only used for patients who do not respond to radiation and chemotherapy, which is extremely rare, or for patients who have isolated disease progression. No, SRS boost or at progression. Those are as a boost for patients who are poor responsive, to chemotherapy or radiotherapy.
Yeah,
That
I mean,
patient
it's
population
here-
is getting
it's suggested
extremely,
as a boost here.
no, but it's getting extremely smaller and smaller. And the first box, though, is chemotherapy and or radiotherapy.
Yeah,
So it is not
I'm
radiosurgery as a
debating
first-line
that.
treatment.
I'm not debating that.
No, no, and although historically you would say with radiosurgery, technology maybe could not have been used, since then, although there's been improvements in radiosurgery technology and radiosurgery practice, radiosurgery has still not become into any guideline for germinoma through any of the SIOP guidelines, any of the American guidelines as well. So I think it is a little bit, I think it's very controversial and probably it has to be very, very considerate about any germinoma patient receiving radiosurgery. I think in our center, and we have 8 different children's hospitals, we would never give a patient like this.
One more thing I would like to add, because perhaps you have considered this for the size of the tumor. So here, if you are considering it a germ cell tumor, then size doesn't matter, because you have to take total ventricular radiation. If you are planning for total ventricular radiation by conventional low dose perfection, then where the size matter for deciding to give radiosurgery?
Okay, thank you. My friend asked my opinion about this patient. I would push for stereotactic biopsy first, then decide about the treatment. But thank you so much, and thanks so much for everyone for their valuable additive to this session.
Thank you so much, sir, for supporting the radiation oncology community in the hall. So we'll move on to our next speaker for today's session, and it's Dr. Pavel Ivanov from St. Petersburg, Russia, giving us the next case.
Yes, the next, please. Dear colleagues, I would like to present a clinical case of a young woman with HER2 positive breast cancer after complex therapy. She experienced some deterioration in her sensitivity and coordination, and MRI with contrast revealed large metastasis in the brain stem. We had several treatment options for considerations. Maybe there is somebody wants to say your opinion. Yes.
No extracranial metastasis?
She had metastasis in the regional lymph nodes only.
I would like to go with an adaptive radiosurgery in this case.
But the volume of the tumor volume was 10 cubic centimeters, and it's in a brain stem.
That's the reason I am not going for a surgery. So
Not for radiosurgery.
Not for surgery, conventional surgery. One of the options you kept is an
conventional surgery.
Yes, surgery, surgical excision. I am not going for that because of its location. I would like to go with a first. I'll just treat it with an 18 gray in the first, and then I'll see the response after 1 month, and would like to have, if there is any volumetric reduction, I would like to give a boost radiosurgery again after 1 month.
No, that's too much.
You are talking. No.
I would think of.
I will not refer this patient to you. Definitely. I will, if this patient will come, and being a radiation oncology to see, I will not allow even to prescribe this dose.
So,
decompress? If there is some decompressive symptoms?
Because it is coming up to the surface. Yeah, I can understand. I can understand because the central necrosis is there. It is coming up to the brain surface, keeping with the all the monitoring system. We can also calculate the safe area. If we just puncture it, the cyst will decompress, and we will get some tissue also. And once it is decompressed, it will convert into a the volume will reduce, and it will help for all the radiation modalities.
But again, if you look at the large picture.
So, sir, this is one option.
I agree with you.
See, but you have to remember, Shankar, she's 27.
Exactly.
And she's HER2 new positive. She has a lot of anti-HER2 new therapies available to her. So we have to think of long term. I thought of two things. First thing is, I think single fraction is out. Absolutely no. So in my mind, there are two options. Either we give 25 in 5, or we do staged SRS, 8 grade today, 8 grade after 1 week, something like that. 7 into 3 weekly.
My answer was your second answer.
25 in 5. Let's ask Rupesh.
Yeah, so a couple things. I mean, it's a young patient, and so you do have to be aggressive. Brainstem metastasis, a solitary site, is going to be morbid if it does not get controlled long term. And as Ruth mentioned, with patient who has access to multiple HER2-directed therapies. Essentially, I would have our surgeons look at this, especially with the left side approach. They may be able to at least partially resect this up front, and we've had some that are true gross total resections, even with just looking just like this, especially with the oncologic surgeon, especially somebody who actually treats pediatrics almost a little bit, who has that experience because they're used to resecting tumors in this location. After the surgery part, or whether we do not do surgery, essentially from a radiotherapy perspective, you can do either fractionated radiosurgery or you can do staged radiosurgery. I would actually do fractionated radiation in this case, and essentially either 25 and 5 or 27, 5 and 5. I don't think you'd be able to meet some of the volumetric constraints with 30 and 5, just given the size of this lesion. If it's less than 10 cc's, then you can do 30 and 5. But right at 10 cc's is actually where you see issues, especially with brainstem involvement. And so that's what I would do. I normally actually do staged radiosurgery, and we have a trial for this. Brainstem metastasis are excluded from that because, number one, they have not been treated in the previous staged radiosurgery experiences that have come out of either Japan, Pittsburgh, North Carolina, or Cleveland Clinic. So brainstem was excluded from those. And number two is that you don't know the dose constraints with staged radiosurgery compared to fractionated radiation therapy. So in my practice, we would give this 25 to 27, 5 and 5 fractions.
Okay, thank you. So we opted for CyberKnife treatment with 3 fractions, 24 gray as prescription dose. In this case, the dose to the brainstem exceeded the tolerable level, but only within 2 millimeters from the tumor. After 3 months, MRI revealed considerable tumor shrinkage. However, the next follow-up in 2 months after the treatment shown the appearance of a solid component in the right part of the tumor. In 7 months after the treatment, the tumor reached its initial size, and MRI shown the intensive edema around the tumor in the brain stem. Also, this is the point where we have to consider some treatment options.
So it's a very surprising. Did this patient took any anti-HER2 or any other systemic treatment?
Yes, she received target.
So what is the extracranial disease burden?
The extracranial, she did not progress.
So it's a very unusual situation. Usually, like probably 18-3 is one of the things. Maybe you might have underdosed that area to avoid the brainstem. So the area where it is there, so probably they underdosed. They dosed maybe not 18-3 that side. And re-irradiation is a possibility. So
Perfusion MRI?
Fusion?
Perfusion to see whether the vascularity is increased or not. Hyperperfused?
Yes, you are right. We performed a PET with methionine in order to confirm the tumor recurrence, and it revealed an area of intensive pathological hypermetabolism, which corresponded to the solid part of the tumor.
So bevacizumab is one of the options in this case. Bevacizumab and re-irradiation, both are the options.
But I do not think that bevacizumab is good option, because it's a real tumor growth.
Can you go back to the previous image? If you look at the second sequence, the T2 sequence, the whole pons, it looks edematous and ballooned up. It is showing quite a lot of radiation-induced and tumor-induced changes also. So I don't think re-radiation after 7 months would be possible.
So, see, here actually the tumor versus the tumor necrosis, there is no tumor necrosis at all which is there. Whatever the edema, what you are seeing is actually tumor-related edema. So I prefer, like, if bevacizumab is definitely as a therapeutic, not as an anti-edema. So the second option is, yes, re-irradiation for only that is as an option to be considered. Otherwise, if anybody wants to do surgery, that is also. Patient progress हो जाएगा तब तक के लिए.
Thank you very much for your opinion. We decided to perform the second HSRT with the same prescription dose, but a specific feature of this treatment was that we concentrated higher doses on the metabolically active tumor part. In 2 months after the second treatment, the tumor decreased significantly, and in 14 months after the second hyperfractionation, the tumor disappeared almost completely. And we have been following these patients up to date. 6 years have passed after the initial treatment. She is in good condition, and the MRI with contrast shows no evidence of recurrence of the tumor, and PET with methionine revealed the absence of pathological metabolic activity, and MRI tractography demonstrated full integrity of the corticospinal tracts. Thank you very much for your attention. What? What? After second MRI, T2.
So there may be a little bit of treatment-related changes in
you
T2,
mean
it
that
does not matter.
Cranial nerve palsies. Cranial nerve palsies.
Neurological status here.
I agree, but we just want to understand anew.
Clinically, there are no signs of some damage of the brainstem.
Thank you, Dr. Ivanov. The last speaker for today's session is Professor Rajesh Balakrishnan from Vellore, CMC Vellore. He'll be presenting the last case for the day.
So I thank the organizers for giving me an opportunity to have a presentation here. Today I'm going to present an interesting case. It's a 21-year-old adolescent girl who presented with progressive hearing loss, tinnitus, giddiness and vertigo for 1 year. She also had decreased vision in both eyes for the past 6 months. She didn't have any swallowing difficulty or nasal regurgitation or seizures or loss of consciousness. On examination, the language and cognition was normal. Visual acuity was 6/9. Visual fields was normal, but it was not correlating with the complaints. She had some nystagmus. Hearing was better in right side than the left side. Impairment in the left finger-nose test, finger-nose-finger test, and tandem walking test involving suggesting brainstem involvement. Spine and skull were normal. So this is the MRI sequences. You can see on the left side there is a large lesion in the vestibule and the CP angle, left CP angle near about having both an extraclavicular and intraclavicular component. There is significant mass effect on the pons, cerebellar peduncles and the fourth ventricle. On the right side you can see there is a small lesion present which is also intracanaliculaar and extracanaliculaar, both components are seen. It's almost a size of 1.6 centimeters. And she also has a posterior forms meningioma, which is in the upper part. Her spine imaging was normal, I just not put it here. Her audiogram, it showed definitely hearing impairment on both sides, on the left side more than the right side. For the sake of juniors here, if there is bilateral vestibular schwannoma, you can brand it as NF2. This is the diagnostic criteria. So what will be a treatment plan now? So whether you will do surgery for both lesions or do surgery for the left and observe the right, or you need to have a multimodality treatment, or no surgery, no RT, as she has NF2 because NF2 you try to avoid, or you offer bevacizumab therapy for this patient. Surgery for the symptomatic side, and you want to treat the other lesion with gamma knife. Okay.
It's an NF2, it has a growth potential, and we would need to treat the disease before he loses the hearing.
I don't agree. I don't think the guidelines are very clear. You should be treating a symptomatic or a growing tumor in NF2. I mean, this patient probably has 4 or 5 tumors, but patients might have 20 tumors, 30 tumors. The spine is generally studded with schwannomas. I don't think it is a good thing to tell that you should treat whatever you see. If it is not growing, it is not required to be treated. Yes, yes. So the left side is a large tumor causing symptoms, mass effect on the brainstem. Certainly should be treated with surgery, microsurgical decompression, and subsequently you can wait and watch and offer treatment as and when required.
Dr. Narendra?
See.
Can you show the images?
Severely lost hearing loss, while on the left side there is a prism. So further by progression of disease there may hearing loss there.
The natural history of NF2 associated schwannomas is very variable. It is not like a sporadic schwannoma. Even sporadic schwannomas, the growth potential is very, very variable. And you can get periods where the tumor doesn't grow for several years. And you can get periods where the tumor grows.
What happens if you treat? What is the contraindication to treat in this case?
With radiation. any radiation that you give, the patient has to bear the consequence of that radiation several years and decades later.
Sir, in this, we are not talking to, may not treat to the meningioma, which is outside the periphery of the brain, but the left side, this sonoma can be treated to prevent
You
further
can
hearing.
treat even the meningioma. It is not about what you can treat. You have gadgets now to treat everything. That does not mean that you should treat everything. NF2 associated tumors, if the other tumor is small, what is the size of the tumor on the right?
1.6.
It is not a very large tumor. I mean,
Hearing is reduced on both sides. So left was more than the right.
So, but the thing is to avoid further deterioration, whether we could treat or not, that is the issue.
you can treat. I mean, I am not debating that you can't treat. You have the gadget, you can treat. But whether it is really...
No, not about gadget, sir. I mean is to prevent further deterioration of the hearing from the, yes.
So, you should treat after, if a follow-up MRI is showing either increase in the size or deterioration of hearing, then certainly you should consider treatment.
Already
But
there is deterioration of hearing, sir. Already there is deterioration of hearing on both sides. One side is very severely and...
But I think he's trying to say that that might remain as the same hearing loss. Unless there is more hearing loss,
there is no compelling reason to treat immediately just because you have seen it on an MRI.
My point is, sir, if it was normal, absolutely normal, versus deteriorated, if it is a slightest deterioration is there, so why you are waiting for to more deterioration? My issue is this: if there was normal, absolutely normal, then perhaps you are right. We can wait if there is a start of deterioration of the hearing.
If it was completely normal, then there is absolutely no reason to
Yeah,
treat
yeah,
immediately.
that is the question, sir.
It is a small lesion and you can actually wait. It may not grow for the next 5 years, 7 years, 10 years. We don't know that.
So, but the hearing loss is not proportional to the tumor growth. There are n number of other reasons when you see that the tumor remains stable in the volume for that particular period of time. There are vascular factors, mechanical factors, immunogenic factors with the vestibular sonoma, especially with an NF2. So the patient who is already having a graph on the downward turn, I do not like
We have only one audiometry. We don't have two audiometries for even comparing that.
The opposite side has got a huge volume. So probably he is having that same genetic factors which are going to...
Then why both are not growing at the same rate? I don't think it is so simple, straightforward. I think for benign tumors, particularly with NF2 associated tumors, you have to be careful and you don't need to rush or jump into treating whatever you see. That's what I'm trying to say. I'm not trying to say that you cannot, I mean, if this in a 6-month later scan, if you see a increase either in the size of the right-sided lesion or any deterioration on the hearing on the right side, of course you should treat. Just at the first instance, if you identify lesion, it is not entirely necessary to treat upfront. That is what I'm trying to say. And if hearing was completely preserved on the right side, there is absolutely no reason to treat whatsoever.
Can I give you our experience in a case like this? We can see that the left side is already compromised, the hearing at the large tumor. There's no debate that requires surgery first. What we're debating is the right side. The right side, the hearing appears to be what we call non-serviceable. It's not very good hearing. And as we know from previous papers and from literature, that if the hearing is already compromised, non-serviceable or less than grade 1, then the probability of preserving hearing after radiosurgery is much less. So in these cases, what we propose, there is still some hearing in the right ear. We propose the patient learn some lip reading, and we follow up the right side. It's small intracanalicular until he eventually loses it by himself. But at least at that time he will be able to communicate, because he's lost one ear. The other ear is already very poor. There's no rush in treating it, so we can wait and follow it up, and he can invest the time he has with his hearing to learn a new way to communicate, because he will eventually lose his other ear. That's our...
Okay, so what I'll do is, what we discussed
I
in our
couldn't-
MDT...
Is there any role of bevacizumab in this case? Just for curiosity.
No, I just put a
Just
question
for-
so that for
Okay,
discussion
after
part.
looking at it.
Yeah, okay. Huh? Okay. Okay. So what we planned was in our MDT we discussed and we opted for a resection of the left side with facial nerve preservation and radiosurgery at a later point of date to the both vestibular schwannomas and up to observe the Fox meningioma. So as said, she had surgery in October 28, 2018. She had a subtotal excision of the left vestibular schwannoma with facial nerve preservation. A small bit of residual was left on the brainstem from the 5th nerve superiorly to the 7th nerve inferiorly. The histopath came as schwannoma grade 1 left CP angle. So this is the post-surgery scan. So you can see, she still had residual hearing with speech discrimination on the right side. Post-op MRI, it showed still there is a residual tumor, which is around 1.7 centimeters into 1.13 centimeter. Brainstem compression is reduced. On the right side, you can see that the schwannoma was almost the same size, but there was some marginal increase in the cisternal component when compared to the previous MRI. And the Fox meningioma was stable in size. So what is the next treatment plan? Like you want to do SRS for left vestibular schwannoma followed by right, or you want to treat both simultaneously, or you treat only the left and keep the right on follow-up, or observe both, or offer bevacizumab now. Hearing is still the same. So the management for bilateral vestibular schwannoma, there are 3 options. One is staged radiosurgery, where you like first on the lesion with the hearing loss, and then on the other lesion when the tumor grows or hearing loss appears during the follow-up or observation. Bilateral simultaneous radiosurgery, there has been some publication which has come up now saying like we can do radiosurgery for both lesions simultaneously if the patient suffers bilateral hearing loss. Vestibular schwannoma in NF2 has the characteristic of infiltrating the surrounding cranial nerves also. So you should keep that also into mind. What we did was we did simultaneous radiosurgery to both the lesions. We gave a dose of 12 gray to both lesions to 80% isodose with X-knife what we have in institute. We try to prefer bilateral because there was some increase in the other side also. And that's one reason. Another thing is this patient, we thought that she might not come back for follow-up later. That was another reason. And because the cost for both the radiosurgeries can be taken up in one because of financial constraints, that's also another reason. So this is a follow-up scan in December 2020, that is 2 years after the radiosurgery. And this is in December 2022. Showing reduction in both the lesions. Meningioma is growing, correct. So she had another treatment for that. I just, for the sake of this thing, I didn't put that here. So the question was like, what is the take on RT in a patient with NF2? I think Dr. Tejpal has already started the discussion before. Hearing is already lost. It's on the left side it's lost, on the right side it's persistingly better. It's better. No, it's improved on the right side. On the left side it is not. So for a patient who's having a small lesion or something, then as Dr. Tejpal said, observation is the take. You observe till the patient becomes symptomatic, or offer RT whenever it is necessary. There is a lot of publications about bevacizumab in NF2. I think Dr. Manjul had a big review paper on that. Maybe sir can give his opinion on role of bevacizumab in NF2 patients.
So it's just a review. I couldn't administer it to any patient because of the financial constraints. So, but I was just looking at the other options what are available to us, right from rapamycin to lapitinib to all those drugs which are on when you search on the PubMed about it. Vestibular schwannomas, they show a response to bevacizumab, but only till the time you administer it to them. So, and you have other tumors also in these patients, especially the ependymomas, and the cystic ependymomas, they are the ones which show a very beautiful response to the bevacizumab, as the literature shows. But as far as the schwannoma is concerned, it's usually just the tumor growth is arrested till the time you administer the drug. Okay. And this is a disease for which you might need to give the drug for the lifelong, and bevacizumab is not a very simple, sane drug. It's not an innocent drug. Every 2 to 3 weeks you need to administer that drug. That's a huge financial burden, and there are side effects which include from the hypertension to thrombosis to hypergammaglobulinemia and all those things. So it's, yes, it's a part in your armamentarium, but I couldn't recommend it to any patient so far.
Okay, okay.
BEV should not be at the cost of avoiding radiotherapy. So if you have exhausted radiotherapy options,
you keep it as a last option.
Yeah.
After
So if it is
failure on-
progressing despite the radiotherapy, then BEV can be considered. I think there's a phase 2. Plotkin, he's put that paper. Plotkin has published a phase 2 study where they have used for refractory progression after radiotherapy. It can be a useful drug, but certainly neither approved nor should be used on a routine basis.
Yeah, actually this year we had 2 publications both on NF2. One recommended giving radiation and other recommended not to give radiation. So if you see the paper in July 2023, this one had a long-term clinical outcomes of stereotactic radiotherapy for bilateral vestibular schwannomas in NF2. They said that the 5-year and the 10-year survival, progression-free survival is in the range of 87 to 85%. And we had one more article in March 2023, which was in Neuro-Oncology Advances, where they said that NF2 patients should not be offered radiation as a first-line treatment for benign, as they are benign tumors, and they should be given a frank talk at the potential of 5% excess risk of developing malignancy or malignant transformation.
So malignant transformation rates are much higher in
much
NF2
higher with
associated.
NF2. Okay. So this, to take home, one more thing is what we have, what the most of the review had said is, in a pediatric population age less than 18 years, this vestibular schwannoma, when you give bevacizumab, they have an increased risk of tumor progression as compared to the adults. That's another take-home message which I thought I'll give you. I'd like to thank the organizers for giving me an opportunity. And there's a workshop on TMLI which we are going to have in our hospital in September. Those interested can definitely participate. Thank you.
Thank you so much. And I would like to thank all the speakers. And now we will move to other session right now. Thank you all.
Thank you so much, sir. I think we all had a very good panel discussion in that. Now we move to the last session of the day, that is a satellite symposium of CRAD, Indian Insight, Harnessing Surface-Guided Radiation Therapy for Enhancing Precision Radiotherapy and Radiosurgery. The moderators of this session are Dr. Arun Lal, Consultant Radiation Oncologist, Leslie Hospital, Cochin, Dr. Saju Basi, Chief Medical Physicist, RCC, Trivandrum, Dr. Manish Chomal, Consultant Radiation Oncologist, HCG, Jaipur, Rajasthan. I welcome you all to the stage and to please introduce the speaker of this session. Thank you.
I think it is the last session, so without wasting much time, we will quickly move on to the session. To deliver this Indian Insights Harnessing SGRT for Enhancing Precision Radiotherapy and Radiosurgery, I invite Dr. Saravana Kumar, Associate Professor and HOD, Medical Physics, PSG Institute of Medical Science, Coimbatore. Over to you, Dr. Saravana.
Good evening. So I'm just here to explain my experience on SGRT in our hospital. So I'm from PSG Institute of Medical Sciences and Research and Hospitals in Coimbatore. So we actually the Sons and Charities Hospital, we have established in 1985, and then we have in 87 we have started the PSG hospitals. Now it is like a 2,000 bedded hospital in southern part of Tamil Nadu in Coimbatore. So recently we have started PSG Institute of Oncology, in which we have radiation equipments, variant True Beam HyperArc incorporated with the surface guided radiation system from CRAD. And we have a dedicated RT-CT, 20-slice CT simulator, and then we have 12 channel brachytherapy from Electa, and we have a PET-CT and SPECT-CT. And SGRT is the basic thing. It is a non-ionizing imaging technique which will use to produce the image posture correction during the treatment of radiotherapy. So this is actually patient surface used for the localization of the during the treatment, and it is the alternate method, and it is a tattoo-free methodology for the treatment of cancers, and it actually creates the 3D images of the surface by using the structured light on the patient, and it will give the every single fractions, like every single they will give the patient posture correction during the treatment. And it is working based on a light projected on the patient surface, and patient will reflect at some kind of light amount to the camera system. So the camera system will capture the light signals and then will give the 3D surface of the image during intrafraction motion management. So this system is purely working by the visible light photons, and then it is a clinical literature. It shows the clinical margins are required similar to the IGRT, with the added benefit of the monitoring the patient positioning during entire treatment and addition without delivering excess non-therapeutic dose to the patients. And this SGRT allows the delivery of the same treatment with a more emphasis on the patient safety. And also the recent study published by Halak et al. Described that the role of SGRT as in driving potential to improvements for the patient safety in the radiation therapy delivery. And in particular, errors in isocenter and demobilization were highlighted as the most preventable events when the SGRT is incorporated into the radiation therapy workflow. And the principle of SGRT, the first day of treatment, they were taking a reference image based on that CBCT, after taking CBCT, and they'll produce the live image on the console. So match which both together, and they'll give the reference image for the patient treatment. So in positioning, in our hospital, we did a study using SGRT and 3-point method like on CBCT, in which it shows the lateral movement and longitudinal movement and vertical movement all within the limit, like using CBCT and SGRT. So you can see like a lateral, longitudinal and vertical, it is all well within the level and compared to the CBCT technique. So it is proven, and the applications in RT and radiation therapy, it can be useful for patient positioning and posture correction and other things, and patient monitoring, and like during the treatment delivery, it will be monitored by using the camera systems and get a delivery for DABH patients. And the system will combine with the two installation, like two kind of things. One is from Sentinel 4D CT, which is installed at simulator room, and where we have one Sentinel 4D CT system. It will transfer the image on the patient, and the patient will be reflected some kind of photons to the camera, and based on that, it will gives the image to the console. And then behind the gantry, you can see here, it is a couch tracking system for the DABH patient. If you are taking a deep breath deep breath inspiration hold technique, so the couch will be moved lateral into the gantry system. In that time, the couch motion will be captured by using the camera begin the CT. And then in gantry room, it has been through 3 camera system which is installed, and Catalyst plus HD, and these cameras will be capture the patient position and motion and respiration during the treatment, of course, for all fractions. And in SRS and SRT, it is like hyper-arc, which is the new technique. We can able to treat less than 2 mm of tumors, like brain metastases and brain tumors. And it is proven technique. And these are the treatment radiosurgery times are constantly within a 15 minutes of time slot. It is independent of the dose prescription, fractionated scheme, and the number of targets being treated for the patient. And it is the different kind of studies have been already proven in variant TrueBeam STX machine, like HyperArc machine. And during this treatment, what is the concept for the motion management? So in which the SGRT will give help us to monitor during the treatment for the patient intrafraction motion management. For to execute the treatment for HyperArc, we need QFix Encompass SRS immobilization device, which is validated by the variant, and then it is like a perfect pitch 6D couch which should be used to execute the treatment for SRS. And the SRS and HyperArc, we need the SRS Encompass to frameless based treatment, and we need a face mask. and then before executing the treatment, as per the SGRT and concern and an SRS and hyper-R concern, we should do the patient-specific QA by using SRS map check. We did the patient-specific QA. Then after that, we have to do the QA for SGRT system also. For the non-coplanar beams, we have to take the couch angles and the different couch angles, and then we have to confirm the dose delivery planned one and the deliver one. And after that, we have to follow the CBCT method. We have to take the CBCT and then match with the internal margins, and we execute the treatment. And the tolerance is less than 0.5 degree and then less than 0.5 mm is the achievable one, and we should ensure that tolerance should be achieved by using executing the treatment of hyper-arc with using the SGRT persons. So in it is a SRS hyper-arc. It is nothing but it is like a template which is provided by the patent by the Varian machine, and they'll give different kind of angles. It is a preloaded one. We cannot adjust this template. We cannot adjust the couch angles and other things. So and we have to execute the patient. We have treated Shavanoma in one 14-year male in our hospital. So they have before that we have started doing the patient-specific QA by using SRS map check, and then we execute the treatment in using hyper-arc. So while doing the SGRT, not only the SGRT for the SRS and hyper-arc technique, we should ensure the treatment delivery, how it is accurate and the precise. For that, the laser should be verified often, because non-iammatic case it's a plus or minus 2 mm, and iammatic case is plus or minus 1 mm, and SRS is plus or minus 1 mm. But in the limitation of using laser in the linachrome, that is way may it is a drift due to the temperature changes or vibrations in the room, and then inaccurately place the laser aperture can produce the more than this tolerance. To ensure that, the lot of studies have been coming out by using the SGRT, so they are ensured. So the using that SGRT for the intrafractional motion management or the SRS or SRT treatment, they are achieved less than 0.5 degree rotational correction, and then less than 0.5 mm it will be achieved. So as per the AAPM protocol, there is a recent study, and TG protocols is showing that demonstrated that it is possible to forgo the mask altogether for the frameless SRSs guided by the surface guided radiation therapy. And the recent studies also show there's a recent advancement in surface guided radiation therapy, which was published in Radiation Oncology Journal. So they are saying like the use of SGRT has shown to provide the increased patient safety throughout the course of the radiotherapy treatment and increased accuracy for the treatment of specific anatomic sites. So the SGRT can be considered an additional safety tool. For example, for the intrafractional motion management, and certain techniques such as the DABH or open face mask treatments can be made extraordinary progress through the SGRT technique. So it's already proven method, and there are a lot of other countries have implemented the system for their SRS and SRT and other SRS cases also. And in our hospital, we did some study by taking the phantoms, the couch rotational corrections. So in which we actually come up with the results, the difference between the vertical, longitudinal, lateral, rotational. So we ensure that less than 0.2 mm accuracy of the couch, and then less than 0.5 degree of couch angle. So it shows it is very proven method by using SGRT, the frameless SRS mask, and then to entire course of fraction we can monitor the patient by using this SGRT technique. So another some recommendations based on TG protocol. So recently which was published in task group by AAPM. So the intracranial SRS tracking option or equivalent should be selected within the SGRT software for high resolution surface grids, and then for SRS and SRT should contain the forehead, nose and temporal bones. Inside the region of volume we should select these regions for the monitoring the patient motion management, and when including the eyes, the sum of the patient, the SGRT may produce large movements for the patient blinks the eyes during the treatment. So that case we can remove the eye from the region of interest, and then we can include the temporal bone for the to execute the treatments. At the same time, the maximum region of interest size should be allow the frame rate at least 3 to 5 frames per second to give the better intrafraction motion captures. And then the treatment delivery occurs with a continuous monitoring of the patient employing the SGRT based on the post CBCT references. Again, still we are following the CBCT. This is a gold standard method. Apart from that, we are using SGRT, during the treatment, during the fraction of treatment, it will be captured by using SGRT. And the tolerance is always should be less than 1 mm for translation and less than 1 mm for the rotations, should be determined based on the institutional practice. And then whenever the tolerances are exceeded, the qualified medical physicist should determine whether this is due to the patient motion or camera occlusion or extreme couch rotations affecting the region of interest visualization by the SGRT system. And then recommendation the clinical or treatment shown up to proceed with the internal clinical teams. And so for using SGRT for the treatment of SRS or SRT or hyperarc techniques, the DICOM surface from the CT simulation for the initial setup should be used, and the camera acquired the surface taken at the treatment machine after the verification of the internal imaging method by like a CBCT. So blindly we cannot take it like from the surface guided, but before that we have to take the CBCT. Based on that we take the reference image and then we'll execute the treatment for the patient comfort. And the region of interest should tracking should include the forehead, nose, temporal as we discussed earlier, and repositioning is needed during the course of treatment, and re-verification with the internal margin, and acquire the new camera surfaces to represent the new treatment position if any interfraction motion stop the treatment. And the minimum tolerance of 1 mm may be used but can be larger depending on the PTV margins we are using for the planning and occlusion of the couch walkout effects. And then it should be taken when using SGRT. Mono-isocentric treatment of multiple lesions of the tolerance may be produced to be decreased and to ensure the comparable target coverages. And then always try to use the 6D of a couch repositioning capability to increase the overall treatment efficiency. These are the recommendation is given by TG protocol. And TG302 workflow for the SRS treatment by using SGRT. This is the steps. First we have to create the SGRT friendly immobilization device and CT scanner, and then we have to do the planning. In that we have to create the accurate head contour with using the DICOM images, and then export the plan and head contour to the SGRT system, and then prepare the data in SGRT system. We'll using import plan and head contour and select the region of interest based on that your institutional practice, and mostly you have to include the temporal bone and nose and other parts of in this region of interest. And positioning for the treatment, so initial positioning with the SGRT and head contour system, and X-ray based target localization by using CBCT method, and then acquire the new SGRT surface treatment position, then you can execute for the treatment. But make sure that every treatment before we should have a quality assurance would be done by the qualified medical physicist by using SGRT QA and as well as the daily QA parts. And the treatment of SGRT monitoring, it's a new reference surface should be followed, and if motion is exceed tolerance, go back to the positioning for the treatment and then again capture the new reference volume and then go execute for the treatments. And apart from this SGRT, it's not only for the SRS and the SRT, we'll have some other applications also. It is possible by using this SGRT system, like setup and positioning for the patient motion, because it's 3 different cameras that are inside the catalyst, inside the gantry room. It keeps on watching your patient, whether during the treatment the patient will move or coughing or some other changes will happen on the patient. It will notice you. So that is the reason it will give the live image on the patient during the treatment or the reference image from the day 1. So both will be matched all the time. During the treatment it will be always telling you like your patient or moved or not, or the tolerance within the limitation whether patient treatment is executed or not. So the patient position in PSG, we have monitored 3-point versus the 3D surface system, and difference with respect to the CBCT, we almost done the breast cases plus or minus 1.4 centimeter and then 0.6 to 0.2 centimeter differences. It is well within the level. It's a proven method also. And the 3-point was CRAD. We are ensuring that the difference between the CRAD SGRT and 3-point method was a laser. It is well within a limit, like a 3 mm. So maximum 3 mm accuracy we are doing the treatments. And you don't know what you see, what you can't see, and what you see you can't see. That is the advantage of the SGRT in the treatment room. So each and every second, each and every microsecond it is watching your patient. And very important thing is if you are set up the patient and about to execute the treatment, but the machine will create the interlocks. If you concentrate your mind on the clearing the interlocks, nobody will watch the patient. So that time also it will keep on watching the patient and keep on telling the information of the patient position and the motion managements. And the respiratory gating, there were 2 modules for treating deep inspiration breath hold technique, and one is the visual coaching panel and another one is the goggle. So in this, the goggle is provided educated to the patient to how to breathe, take a deep breath in the CT room. The patient will be minimum that protocol is to, if you are doing DABH cases, minimum 5 days we have to give the coaching to the patient, and after that we'll start the treatment in the gantry room. So we have to follow the day of treatment, day of CT simulation, how the patient history, like whether they had a food or whether they drink water or they having any problem the breathing, all those things should be considered, and during the day of simulation and during the day of treatment. And sometimes it like a seep respiration, sea motion also is an additional technique which we can give the more information about the patient during the treatment of breath hold. And another important thing is there are another module called visual coaching panel, which is a lighting system installed in gantry room, like treatment room. So in which the patient, if you are doing normal breath, the room light will be in the blue color. If the patient is taking a deep breath, it is within the tolerance, the room light will change into the green color. And if the patient is abnormal breath, the room light will change into the orange color. This is the additional advantage, the patient comfort, and patient can himself or herself to make sure that the breath is within the limit or not. So this is an additional technique, and we did our hospital few studies using DABH cases in which it clearly shows using DABH CRAD SGRT system, the organ dose of the lung and heart will be very less compared than the free breath technique. So this is a technique like a free breath is 16.8 gray and deep breath is reduced to 15.45 gray. And patient 2 is the same, like heart and lung dose will be reduced by using the DABH cases in our hospital we did it. And auto beam hold technique, it is very advanced one, because like during the treatment, if a patient moves or out of tolerance, or the patient coughs or patient feel uncomfortable, it's out of the tolerance, the beam will be hold. Beam will not be delivered. And especially for the breath hold technique, the patient, if you're not able to take a deep breath in particular time period, then they will reduce the breath in the below tolerance, means the beam will be off. So after that, when the patient takes a deep breath, then they can automatically the beam will be start and giving the treatment to the patients. And other than the DABH, it's a normal clinical example for other sites of the cancer also can be able to treat by using this SGRT system. Ankle we can treat, and sarcoma patients, and other kind of clinical sites also we can able to treat by using the surface guided system. And time difference between using SGRT and non-SGRT. So we did some study for last, because we started only 6-7 months before in our hospital by using this system, and we actually taking a different kind of study, like using SGRT, how much time we are spending for preparing the patient, mold, and then simulation, and then treatment room. And then if you are using SGRT, will considerably the time is reduced for the treatment execution, simulation, and other procedures. And the daily QA, it is mandatory as per the TG protocol. Before doing any treatment for SRS, we have to do the machine QA and as well as the SGRT QA. And every morning, as per daily, we are doing for the LINAC daily QA. Now, the same like kind of things we have to do for this SGRT also using this system. This system will be used for the CT room, catalyst, where the catalyst 4D CT are then we have to take the measurements and we'll align the laser, and we have to track the couch tracking system, whether it is working properly or not. And this system 3-ball technique, it is like a daily QA for the LINAC room. So I should ensure that my ISO center and the camera ISO center and all the same page. So if it is any difference, then you will give the additional error to the treatment during the treatment time. So the SGRT implementation is a team effort. It is mainly implemented, it is driven by the medical physics department, medical physics personnel, and in close collaboration with the chief therapist. And then the RT champions of each mission should create, and the team should be created for the surface guided radiation therapy for the better workflow management. So the clinical site, as per the TG protocol, like a task group 302, we can treat these kind of sites for the using SGRT system. And the implementation timeline, what we took for our center is like we have started evaluation period, it takes almost 3 to 4 months, and then we have started the installation, it takes almost 1.5 months, and then we have had a training about 30-35 days, and then we have started doing the breast cases treatment observation. Then after that we are very happy with that, then we are execute the treatment for the other parts of the body. Now, actually, we started doing head and neck cases without mask. For using SGRT, we can able to treat the patient. We have already done 2 head and neck cases without mask, and almost we treated 60 patients using surface guided without thermoplastics, and we did 11 DAB cases by using the surface guided radiation therapy system. So this is the implementation timeline for our we took for our hospital. And the key features for the SGRT, it's like high resolution surface imaging for the sub-millimeter accuracy, and it's excellent image quality with high dynamic range it can cover, and it's a real-time motion management with a high-speed camera. We can say every microsecond it will give the image about your patient surface, and it's a absurd handling of the patient change and swelling or weight loss. It will intimate to you, and it will be speak to our system, speak to our TrueBeam or LINAC, and your patient has this kind of thing, but it is in the like color difference on the patient, pattern color difference on the patient skin. And accurate isocenter alignment with the 6DF corrections, that also it shows, and breath hold and free breathing gating modes, it is possible, and augmented reality color projection directly on the patient's skin for the posture corrections, and it's enabled for the markerless patient setup. If you want to take CT simulation without marker, it is possible, because in Sentinel 4D CT, it will place the virtual marker on the patient. We don't want to touch the patient. Virtually, we can put the marker on the patient's surface at the isocenter. That will be transferred to the TPS. Based on that, we can do the contouring and the planning. Then it will be shifted to the treatment room, and then we can deliver the treatment. So that the monitor of the patient doing the entire fraction and beam delivery and verification imaging. So reduce the need of verification imaging dose. It's a very important thing, is because if you're comfortable with SGRT, we don't want to take CBCT for the daily cases. We can check randomly, like a day 1 and 6th day or 9th day or 12th day, something like that. And the couch status for the information of the couch actuals, and it's a control for the sending shift to the treatment couch of the automatic adjustment will be happened by using SGRT. And the beam status for the information about the beam delivery, and beam couch control, the automatic beam mold for the treatment delivery, and then non-ionizing radiation localization for using the real-time patient motion management. That's the advantage of the SGRT if you're implementing in your treatment sites. So thank you for the opportunities.
Thank you, sir, for the excellent talk. I have a few questions. You told for your hyperarc system, you are using your SGRT system.
Yes.
And your reference image is going to be the image that comes from the CT.
CBC, yeah, from CT, it will take the reference image.
Okay.
The same reference image will be followed in the planning system, and then will be shifted to the gantry room. And that time you have to take the CBCT, will match the CBCT, and with the first time of reference image were taken by the SGRT system. Then the treatment will be executed.
What if you have a non-coplanar, if you have a couch rotation?
Yeah, non-coplanars it is possible, because if you're because non-coplanar with the hyperarc, it is a standard template. We cannot create the more than 4 angles by executing the treatment of an hyperarc. In which case we actually taking the non-coplanar angles, and then will be executed before treatment by using the QA system, and then we'll ensure that whether the treatment properly delivered on, and then after that we are executing the treatment. So it is it's a clear one, proven one. A lot of centers, I think Lund University and other hospitals in US out there started using the SGRT for SRS treatment, frameless SRS treatments.
Okay. And one more thing is, like you told regarding totally excluding the IGRT thing. So does the surface guidance monitoring actually, can we exclude IGRT?
No, the IGRT means you're giving imaging dose to the patient. So that we can be avoid taking SGRT. So you don't want to give, because CBCT, there is a protocol based on the institutional practice. Some institutions are taking daily CBCT, and some institutions are taking 2 days once, alternate days, and some institutions are taking weekly ones. So if you're taking daily CBCT, it's additional dose to the patient. In which case we can avoid the daily CBCT. We'll take the CBCT in the day 1 treatment, and then we'll compare with 3 days. And then if you're taking CBCT, you match with that. If you are okay, then you can proceed with the SGRT system. Actually, we did this study in our hospital. We are taking first day treatment. We'll take the reference image. After the CBCT, we'll take the reference image. Then we'll execute the treatment. Then fourth day I'll taking the CBCT. Again I'm matching with my reference image and with the CBCT image. It will be matching plus or minus 3 mm. That's what I show the results. So it is well within the limit. So we are using like 6 day once or weekly once or 2 weeks once we are taking CBCT.
But can that be taken as a general thing for all the sites?
Yeah, we actually taken this for the pelvic cases, and now we have started only the head and neck case, and we are working on this. Maybe head and neck, maybe after 10-15 days we can come out with the results, and then we can able to publish that.
And to the audience, there was he was showing the publication wherein the SRS is being done without mask. So how many of you will practice that? And
No.
SRS case?
SRS with open face mask.
Open face mask
With
or
open
without
face
mask?
No, open face mask.
Oh, open face mask.
Yeah.
Okay, that's fine.
So you have to take, we have to treat the SRS cases with open face mask by using SGRT. So it is possible of during the treatment, it will make sure that the patient is in standard
But
position.
for your head and neck, you have gone maskless with 2 cases. That is what you mentioned.
Yes. So we have started, I think.
What if the patient loses weight? Patient will lose weight for head and neck cases.
Yes, I think that's what. Last 2 days only we have started using SRS because one patient we had a face a problem. He is not comfortable by using the mask on the couch. If you are putting the mask, he is not able to breathe properly. Because of that, we are able to deliver the radiation for treatment for him. So that case, our radiation oncologist decided to go with maskless. Then last the patient weight daily we are monitoring from day 1 to every day before he is coming for the treatment. We are waiting noted the weight. So we have to take the decision, clinical decision. Doctors should take the clinical decision maybe after the 10th fraction or after the 15th fraction, whether if you reduce the weight. That time you have to take the reference image.
If the patient's weight loses, does SGRT system works? I mean, can we make the decision making on the SGRT
Yes.
if the patient weight loses also?
Yes, it will changes your contouring system. No, the reference image will change. The day 1, what is the reference image, and day 6, what is the reference image. If it is the changes in the reference image, it will show you. It will tell you your patient is not in your treatment ISO center. What do you want to do? So like that, it will ask you. Then the radiation oncologist who is in the treatment room, he has to take a decision whether you want to go the replan or re-CT or re-planning, or we can treat within the margin. That's the clinical decision. It's like structured light pattern on the patient.
Yes. So if a patient loses weight, so it's able, the system is able to see that it is not able to match the reference which was at the first day on the CT. So you have the capability to take a new reference at that particular fraction itself, and then it becomes the reference for the
other fraction.
Yeah.
So I just have a last question because it's already late. So this system is basically working on the principle of optical light with some cameras, right?
Yes.
And when we deliver a complex SRS plan for a patient, then there are going to be multiple different gantry angles and
Yes.
couch angles. What if at some particular angle your gantry head is going to obliterate any of the camera? Then what will happen? How this system is going to work then?
It is a 3-camera system based on the light projection on the patient. If any one camera is occlusion is, other 2 cameras will be working. And particularly in CRAD is the front camera is the major one. So it will be keep on monitoring your patient. And also before the treatment execution, we have to do the QA for the system. So in that, we can always ensure that the delivery will be without affecting any occlusion. It will be can deliver like that. So it is already proven. So because you are not creating more angles on the couch angle, it is like a standard one. So we cannot create more angles. Maximum 4 angles we can possible only by using hyperarc. So in which we have to make sure that whether the occlusion are produced on it. Even though it is produced, one camera is blocked by the gantry, 2 other cameras will be working. So it will give the same results.
My understanding is SGRT can go in hand with IGRT because one cannot replace the other.
mainly
Not immediately.
Yeah,
Yeah.
mainly what I feel is the main positivity of this tool is it continuously monitors the patient throughout the treatment without the use of any ionizing radiation.
Ionizing,
So
yes,
the
exactly.
dose from imaging can be reduced, but I don't feel it can be totally be taken out. That's my understanding,
Yes.
at least for the deep-seated tumors. For
Yes.
superficial tumors,
Definitely, it will not replace by the CBCT. CBCT is a gold standard method, so it is additional tool, but you can reduce the imaging dose on daily. That is the concept.
No further questions from the audience?
Thank you so much, sir, for the detailed explanation about the SGRT system. I have a very basic question, sir. Have you tried with multiple isocenter plans? Have you?
No, we have not tried.
But how effective it is if we
is-
have multiple
Yeah, it is a
isocenters?
proven one. The TG protocols, the APM protocol has clearly says the multi-isocenter things also possible by using SGRT. But we have not tried in our hospital because recently we have started only 5 months.
Back,
It's
okay.
working. Yeah.
Okay. But it's
But
still
it is
possible.
possible. Yes, it is multi-isocenter treatment also possible by using SGRT.
Any publications are there?
Yes,
Okay.
a lot of publications are there in APM and TG protocol. So is there in ISTO also they have published a few papers.
Okay.
Yeah.
Thank you.
Thank you, sir. Mine is a very specific question regarding the setup that I work in. For the last 6 months, we are doing in a Versa HD Electa with ABC.
Okay.
We started with left breast, DIBH, and we did some metastatic lung from breast, N3B, head and neck, post-op. So recently, last week or that last week, there were 2 cases. One oligomets liver, and another was a node. So what we saw at that time, that the ABC was working good when the chest part we were working with. Anything that when the target volume was in the chest wall. But when we tried only with the ABC, without the other support systems, then many other, during 1 or 2 first 4 CBCTs, and those things didn't match. So my question to you is that, do you find such systems that SGRT, the surface guided stuff, can work good across all portion of the chest and abdomen?
Yes.
And the ABC system has some lagging limitations.
I think, yeah, it is a field of view is a larger field of view if you are using SGRT. So that is, I think you can.
What sorry, it's not working, but what SGRT does, it monitors the surface as well as your absolute lung air volume.
Yeah.
But what ABC does, it
Hmm.
only monitors the lung air volume.
Yeah.
So, and in the breast cases, the position of the surface matters a lot. The arm position matters a lot. So that time SGRT gives you one more particular thing to monitor, that your surface should also be in the correct position.
Yeah, actually the chest cases we're not having any problem. Regarding the MS protocol, you take alternate days. It's when we are coming to the abdomen part, we are finding
so
out
actually,
that...
Yeah, abdomen part also it is matter whether the patient, the time of simulation and the time of treatment. The simulation time, patient will not have a food, patient will not have a water, so their abdomen size is different. After the, coming for the treatment, that day the patient had a food or some bowel wall will be filled. So that time if you are making 2 or 3 mm difference, the SGRT will intimate to you. So your patient surface will be larger.
So the surface guided will be much more accurate in the abdominal part, I think.
Yes, for the external surface
For the
imaging.
external
So,
surface.
it's internal organ, we're not talking about the internal organ, but external surface it will be more accurate.
Thank you, sir.
So I'll just extend his case scenario further. If we look at RPM by Varian or ABC by Electa or even the SGRT that we currently have in practice, all 3 are actually surrogate markers. None of them is actually tracking the tumor, especially in the scenario when he was talking about tracking liver lesions for SBRTs or even lung SBRTs. So in such scenarios, I think all 3 of them are looking at the surrogate itself either by various methods, either by you tracking the tidal volume in electa or the surfaces by SGRT or RPM. So in such scenario, I would rather prefer going for if that much precision is really required, then putting fiducials is the only answer, and maybe CyberKnife is the answer for that. Although I don't practice on CyberKnife.
Okay. Okay.
If there are no further questions, I think we'll close this session. Thank you, Dr. Saravanan, for that wonderful session. And thank you for the organizers.
Thank you, sir, for the very nice talk. With this, we come to the end of this session for today. I now invite Dr. Ajay Shashidharan, Assistant Professor, Department of Radiation Oncology, Amida Institute of Medical Sciences, Cochin, to deliver the closing remarks.
So with that, we come to the end of today's sessions and the talks. So I'm just summarizing morning session's important key points. So morning we had a session on meningioma. Different types of surgical techniques, endonasal and transcranial surgeries were discussed. For skull-based meningiomas, the gross tumor resection rate is 60% and recurrence can happen in 30 to 40% of cases. That's where the role of radiosurgery comes in. Convexity and parasagittal meningiomas discussion included a very key point on looking at different parameters when you select cases for radiosurgery, including comorbidities, location, age, size and symptoms, and other factors such as edema and grade. For atypical and anaplastic meningiomas, the role of radiosurgery comes in the salvage setting for residual or recurrent tumors. In the cellular tumor session, the crucial importance of delineating the anterior optic pathway was talked about in the first talk. And for non-functioning pituitary adenomas, the indications included residual, atypical features, recurrent tumors, and refusal for surgery. And in hormone-secreting pituitary adenomas, the efficacy of radiosurgery comes to up to 50%. The hormone normalization takes longer than stabilization of tumor size. And in craniopharyngiomas, the main take-home message was do not push for gross tumor resection. The quality of life is better with subtotal, and RT should be done after the surgery. So thank you all for the attendance, and we invite you to the inauguration program of ISRS 2023 at Hotel Marriott, Kochi at 7 p.m. Buses are available for shuttle for the faculty as well as delegates from the main entrance to the hotel at around 6:15 to 6:30 p.m. So we can go to the main entrance of the hotels.
Thank you all. I'm wishing you all a very wonderful evening.